Right. So to start us right off, maybe I make one or two comments. Throughout the 2 days that we have had this conference, financing has been an issue that we have been touching on, circumventing it. But now this session is going to take a deep dive into how do we unlock sustainable financing for NCDs, and especially how do we unlock the private sector, or how do we harness those partnerships for sustainable financing for non-communicable diseases. So to start us off, we have Young Homin, who will give us an overview of the burden and the financing gap in the African region. Welcome.
Good morning, everyone. I hope everyone had a good breakfast, good sleep. And today is our day 3, our final day. And I'm very honored to speak in this session where I'm sure this will be the most exciting session of the conference, where everyone wants to know how can we further advocate for resource mobilization for NCDs. And I'm very happy to share this panel with our fellow panelists. And I'm very happy that I can see a few of you for this morning to discuss about this resource mobilization. So today, this morning, I'm going to give you a brief overview of the NCD burden in Africa and the financing gap. So for the past 2 days, we have been saying that we need more money, we need more funding for NCDs, but without actually knowing how much we are in gap. So this session will provide an overview, followed by our panelists. We're going to delve into more details on how can we further mobilize resources. So this session will be taken from Unlocking Sustainable Financing for NCDs, an overview of NCD burden and a financing gap in the region. And my name is Min. I work from External Relations and Partnerships in WHO Africa Region Office. Next slide, please. So in this map, this is a heat map of our NCD burden in Africa. As you can see, our region, when I say our, it's Africa. I'm from South Korea, but then I've been working in Africa for many years. So please, when I say our, my, it means for the region. So you can see the heat map that our red portions on the mortality for NCD is very heavily concentrated in our region. You can see that 37 of all deaths is accounted by NCDs, and it's even more, 2/3 are account for mortality rate from NCD before the age of 70. So meaning NCDs are a huge burden, disrupting the most productive years of population, which will bring us huge social and economic consequences. Next slide, please. You can see from this graph that we are facing a huge and historic decline of overseas development assistance. Yes, we see that on the news, but we don't really feel it until we put it on the graph. You can see that the net ODA from the most giving countries have been declined the furthest. This is a historic decline in history. So the top 5 countries who are providing the development assistance, namely Germany, the United States, United Kingdom, Japan, and France, they account for 95% of the total decline in ODA. Even the US single alone account for 80% of this decline. So this is the largest reduction in volume by any provider in any year on record. So having this global funding landscape as a background, next slide, we can move on. I'm not sure if you can see clearly on the graph on your left. This shows the financing gap between the available resources and the mortality rate of NCDs. So the 5th column you can see is for the NCD. You see the blue dot over there? The mortality rate for NCDs is nearly 75%. However, with the least dedicated resources available for this. This means, as you can see in the pie chart, the development assistance for health allocated for non-communicable diseases is from 1 to 2%. It's very low. So you mean there's a big mismatch within the burden of NCDs and available financing to address this gap. So knowing that it's only very less than 2% that is available for NCDs, we need to do something. And of course, we are still quite far away from achieving the targets we have set years ago. I would like to just showcase some of the initiatives that WHO Afro in the region have taken initiatives of. Next slide, please. So you can see here, this is actually a brief overview where WHO Afro with other country offices in the region with our member states have yielded from. So with many thanks to Hemsley, we were able to expand the PEN Plus strategy over almost 30 countries now. And of course, thanks to Hemsley, we were able to organize this conference where we were able to sensitize NCDs in the region. We have Roche, who also have contributed with very generous support on the breast and cervical cancer. We have now Wellcome Trust, who is very interested in supporting mental health care in the region. And we have World Diabetes Foundation, who are our biggest support for diabetes and cardiovascular diseases. And we have, of course, Gates Foundation and Bloomberg, who are supporting for us for tobacco control. Despite all this effort and initiatives made, we are still facing a high burden NCDs with critical gaps. As you can see on your right, we still have other cancers, including prostate and liver, which we don't have any funding related. We don't have support. Most of the funding are allocated for cervical and breast cancer. We have also oral health, which we sometimes underestimate, but we start our day with oral health. Without even thinking, you go to your bathroom, you grab your toothbrush, you do your toothpaste, and you brush your teeth. Our day starts with it. However, there are many population in our neighboring countries who do not have access to easy and affordable oral health care. We have chronic respiratory disease. We have a COPD, asthma, lung problems. However, we are seriously under lack of funding for this area. We have also epilepsy and neurological disorders, including dementia, Parkinson's, that are highly underrated. And also we have, of course, alcohol and substance use disorders, where we could mobilize more funding for prevention and rehabilitation. So this is basically the overview of what's happening in the region in collaboration with our member states. So next slide. So the key takeaway will be, after having this overview and landscape, of course, with the reduction of ODA, with a very recent historical decline, we still need to fill these major funding gaps persisting across the high burden diseases and risk factors. Addressing these gaps will require diversified innovative financing, which will be further discussed with our fellow panelists in this session, that should combine philanthropic foundations, international financial institutes, and private sector and domestic financing. But I would also highlight that, yes, we need resources. Yes, we need more advocacy. Yes, we need more funding to address these gaps. However, we don't have to just wait. It starts also coming from our daily lives, just putting away salt and pepper every day on your dinner table. You don't have to always put the salt before even you taste your food. Sometimes I go to a restaurant, personally, I try to reduce salt intake. However, when I see these 2 bottles of salt and pepper, I just immediately grab it and I just put it without even thinking, even without tasting it. So I think everything should start from individual level. And then, yes, we are trying to mobilize resources, these initiatives as a collectively, but from also individual perspective, we have to really process this and internalize it to make sure that we ourselves are advocates for NCD prevention. Thank you very much.
Okay, thank you, Min. Very nice presentation, and I like that you unpackaged the non-communicable diseases. In the last conference we had, we said, let's call them by names. You never hear people talking about communicable diseases. They talk about HIV, TB, they talk about STIs. When we lump everything together as NCDs, some things fall beneath the cracks. So I'm happy that while you're looking at the donors, you have unpackaged who is supporting what. And it's good to remember that money actually follows value, attention, and also follows structure. So I'm happy we have a panel that will be doing exactly that. So our next presenter is going to talk about key financing pathways and domestic resource, innovative financing, and external funding. And Dr. Kingsley sets the record straight. We sometimes use some of these terms interchangeably, but he's here to set it right. So thank you and welcome.
Thank you very much. Good morning, colleagues. Good morning, distinguished delegates. My name is Kingsley, and I'm from Health Economist, WHO. So my task this morning is to basically look at the health financing pathways, and I've split the presentation into two. So I'll be looking at the funding sources, and then we move into the pathways. And so I see this as more of a value chain journey. First slide. Right. So in terms of the funding sources, broadly, we can have it domestic and external. So these are the two main areas, domestic and external. But within these two revenue streams, you can have different substreams depending on what is happening within your country. So the context will bring the different substreams into the discussion. And so broadly, we are having domestic resource mobilization. And I think the entire week we've heard about innovative financing mechanisms. We've heard about external funding support. And then the final one we want to add is the integrated financing model, where you are putting all of that together. So with the next slide, we'll pretty much look into the various revenue streams and see how best we can harness that to support the PEN Plus implementation. Next. I thought it's important for us to have a global regional picture in terms of how currently we are financing our health sector. And so this is coming from the Global Health Expenditure Database. It's unfortunate you cannot see the figures down there, the letters down there. So you see government, you see out of pocket, you see voluntary prepayments, and then you see external and other. So from the technical point of view, when we are tracking health expenditure, this is how it is done in the system of health expenditure tracking that we have, which is a standardized system of tracking health expenditure. Now, with this classification, it tells you where we can get resources. But the most important message I want to put across here is that we want to remove out of pocket. And that's the reason why most everyone is calling for the need for us to have domestic resource mobilization. Next. Again, this is the same expenditure by source, looking at the WHO region. But the idea here was basically to compare that with the other regions of WHO, Western Pacific, Southern East, and see how the various sources are being played out within the regions. Next. Next. Right. Now, we are getting into the details in terms of the various sources. So if you look at the public domestic revenues available for health, it is basically looking at how the economy is doing, right? And so we need to pay attention. We need to look at the bigger picture within the country. How is the economy performing? So that gives us the domestic component of the sources. The next one you see there is the external, which is basically coming from grants from our bilateral and multilateral partners flowing through government or off-budget positions. And then the final one is the private one, where we have out-of-pocket, direct patient payment at a point of taking service delivery. And then, of course, voluntary prepayments, commercial insurance, the private ones, and non-profit community-based health insurance, all are classified under private once we get into the technical, expenditure tracking. Next. Now, We've heard about innovative financing, but there's a technical definition for it from the WHO task force responsible for looking at additional resources to the health sector. And the definition is, with your permission, let me just read: a range of non-traditional mechanisms. So any mechanism that is outside the traditional means of supporting health service delivery or financing health service delivery. Mechanisms to raise additional funds for health through innovative projects, such as micro contributions, taxes, public-private partnerships, and market-based financial transactions, among others. So that's basically innovative financing. So as I explained earlier on, you can have your domestic and external, but within that, you can have innovative once it falls within this particular definition from the WHO task force. The next slide will give us some of the criteria. Additionality here means created to fill the financial gaps that have compromised the attainment of health targets. And my colleague just mentioned about some of the gaps we have in the NCD. So any innovative means of filling the gap, we can actually term that additional resources as innovative. And so innovative, to pass the innovative test, effectiveness is critical and efficiency is paramount. Next. Right. So these are some of the examples of the innovative mechanisms we're seeing across the globe. So results-based financing, and these are some of the examples. Debt swaps. I think most of the countries are moving into debt swaps, cash on delivery, performance-based financing. When you look at catalytic funding, we have pooled investment fund, co-funding, seed funding, volume guarantees. Some of these mechanisms are within the private sector, but it's about time that we moved all of that into the health sector just to close some of the gaps we have. Impact investment, and I'm sure we've heard about blended finance facilities, impact-focused capital market. And then when you talk about socially responsible investing, social bonds, mutual funds, pension funds, and so on and so forth. Again, we have new taxation channels like the domestic health taxes, international solidarity levy, earmark taxes for health, and so on and so forth. So when you talk about innovative financing, it's a cross-cutting thing. It can be a domestic intervention or external intervention. Next. Right. Remember we talked about public-private partnership. So when we talk about multi-sectorial partnerships, we are looking at partnership between government, private sector, development banks, and civil society, unlocking resources and expertise for NCD interventions. So private sector innovation drives innovation in pharmaceuticals, diagnostics. You can also look at issues around digital health solutions and enhancing health outcomes. Development finance support is there, and then governance and coordination is critical once you are having this mechanism in place to support NCD or let's say PEN plus interventions. Next. Right. Now we've talked about domestic resource mobilization. We've talked about private, and we also mentioned out-of-pocket payments and so on and so forth, external support. An integrated financing model is where you are integrating all of that as a mechanism to support health service delivery. And so here it is important to look at the coordination alignments. It is important to look at the flexibility and adaptability of this integrated approach. And it's also important for us to leverage on this model as we move towards service delivery with special focus on PEN plus. Next, please. Right. So I thought it's important for us to showcase a country that is using a model for domestic NCD financing. And I'm happy my next presentation, my colleague is going to share some of the reflection from the Ghana experience. But we have domestic financing reforms where 2.5% national health insurance levy. In March 2025, the government uncapped the national health insurance levy, which directs 100% of proceeds coming out of the taxes to Ghana National Health Insurance Fund. Now, the innovative aspect from this is really the insurance and the risk pooling mechanism. And then, of course, in terms of real policy relevance, the National Health Insurance active coverage reached 57% in 2025, and is climbing to 70% with free primary health care. And I'm sure we'll get more from Dr. Jokoto next. So given what we've talked about in terms of the various funding sources, this is the NCD financing triangle that we have in Ghana: the domestic public, then we have the pooled insurance, and then we have the external slash donor revenue streams. So all of that gives you that level of innovation. And so what we keep on saying is that innovative financing can be a domestic issue and it can be external support issue. Thank you. Next one. Now, for us within the health financing space, financing path starts with the resource mobilization. So my colleague from the resource mobilization team will scan out where the resources are coming. But for us, it gets into, that's the first stage of the health financing function. Next. Now, I just want you to look at who meets the benchmark. Africa versus the key health financing threshold. If you look at out-of-pocket payments, 4 out of the 54 countries are doing less than 20% of the current health expenditure. 28 out of the 54 countries we have in Africa, when you talk about the current health expenditure greater than 5%, which is a threshold, only 28 of them, and we have listed all the countries there. Now, in terms of per capita, we are looking at only 22 countries out of the 54. Right, that should tell you generally how we are performing from the health financing indicators. I'm sure almost everyone talks about Abuja targets. We have 5 out of the 54 meeting the target: Algeria, Rwanda, Seychelles, Botswana, and Lesotho. And this should tell you that there is more we need to do in our respective countries to be able to change the narrative. Next. Now, I wanted to focus on the out-of-pocket because if you look at the NCD interventions, it is important for us to ensure that we are moving away from this number of 36% up to a threshold between 10 to 20. It is important for us as we get into our respective countries to support policy directions that will help us to reduce the 36%. It is not going to help us in terms of our effort towards NCD reduction. Next. Now, country variation shows that policy choices matter. If you look at the spread between Rwanda and Nigeria, Rwanda is 4.1% in terms of the out-of-pocket share of current health expenditure. And look at the share of that relative to Nigeria, which is almost 72%, right? This variation suggests that the financing architecture, not the geography alone, okay, shapes financial protection outcomes. And so country reform pathways can therefore be designed and improved, given the fact that out-of-pocket is a major hindrance, so to speak. Yes. Next one. Now, in summary, even before we get into the pathways, I wanted us to look at what is happening within the space, within the region, in terms of some of the issues and challenges. We have insufficient domestic resources, and that is really weakening the resilience and the equity that is needed within the space. System-wide fragmentation from external partners and government streams hampers UAC. New vertical funds must be discouraged, and we need to encourage consolidation and integration as we move ahead. One issue that is missing in the equation is the issue of public financial management and budget execution. And I think managers of NCDs should work towards an advocacy system where PFM reforms are encouraged within our countries. It is really not about having budget line items for NCDs or malaria or whatever it is. It is really about ensuring that we have PFM reforms that will ensure flexibility and reduce rigidity of resources that have been allocated to your budget centers. It is important for us to advocate for reforms looking at issues around program-based budgeting. That gives you the level of flexibility to move the funds around. Governance and accountability is a big issue, and then capacity gaps, information systems, and innovation scale are some of the issues and challenges within the space. Next. So to us, when we talk about health financing pathways and mechanisms, it is really about going through the entire value chain. Resource mobilization, how are we pulling the resources together? Next slide. So if you look at the first, from the left side, the funding sources, we've gone through all of that. Now, the second one talks about the pooling entities. So the pathways are basically two pathways. We have two pathways. Some countries are using the insurance mechanism as a pathway for financing resources. Others are also looking at direct facilities, making resources available to facilities directly. So this basically talks about the pooling mechanism, the pooling entities we have in our countries. And then within the pooling, after the pooling, it's important for us to look at how strategically are we buying services from the service providers? How are we paying the service providers? Because there's some level of incentives in the way we pay the service providers. And then the big issue to me is the public financial management, which serves as the facilitator in transferring the resources that we are getting from the donors, from the partners that has been allocated to the health sector. How are we transferring all of that? So the budget allocation, budget formulation, the execution, the audit, the oversight. This is really where you get your flexibility as a program manager responsible for NC. Now, we need to look at the inputs that will support PEMPLAS. You know, government stewardship is important. Health workforce, fiscal infrastructure, supply chain, all of that is part of the spending work streams within the PEMPLAS implementation. And it's important for us to look at it from the entire value chain, where the resources are mobilized, pulled together, and then transferred to the various service providers using an incentivized provider payment mechanism. Next. So if you look at what has happened the last 12 months, the last 12 months, the red boxes you see there highlight potentially greatest immediate impact of aid reductions, and broken ones, the red box is the off-budget resources. And this is where we are encouraging NCD not to go the direction to have a vertical programming, because anytime there is a shock, you guys are going to be the first to hit. And so I thought giving this information is actually going to help us as we move into the policy directions for NCD intervention. Next. So this is the final slide. Next one is basically a takeaway call, call to action. Next. And a couple of points for takeaway. So increasing and optimizing funding, boosting domestic public funding must match the rising burden of NCDs. There's a total mismatch in terms of how the resources are being allocated. So the budget formula within our countries should reflect the disease burdens. And once we know NCD is really an issue, why don't we advocate for more resources? The policy levers for resource mobilization, implementing health taxes, reducing medicine cost, and expanding pooled financing can actually improve resource mobilization and financial protection. Multi-sectoral collaboration and advocacy, and I'm happy to see most of our partners here. It is critical to fill the gap that my colleague talked about. And finally, transforming the financing system. It is really about the design of the health financing system. You can have all the resources in this world. If you missed out in terms of having the right designs, definitely you are not going to achieve the health outcomes required. So on this note, I would like to say a big thank you for inviting us to be part of this. And together, we can close the gap. Thank you very much.
Thanks, Kingsley, for an elaborate presentation and for enlightening us on matters health financing and health economics. And just before we hear from the government of Ghana. The Deputy CEO, Dr. Kwesi, will be speaking here on government, and he will be talking about, you can come, he'll be talking about mobilizing political leadership and sustaining the momentum on NCD financing. And Dr. Kwesi, I'm trying to save some time so that we have more time to deliberate. So if you can catch up on your slides, we'll appreciate it.
Right. Thank you very much. Let me greet all of you in your respective capacities and also commend the earlier speakers here. Kingsley is also from Ghana, but he is based in Ethiopia. So I think I'm better positioned to say good morning from Accra, Ghana. My presentation is going to be very brief, and it's going to be on mobilizing political leadership and sustainable financing commitments, our experience as a country. Before I do that, I'll give you a brief background on our health financing journey at Ghana, then why the financing question is still relevant. Most of it has been answered by Min and Kingsley already. We'll talk about our health financing sovereignty, something that was launched somewhere last year by the President of the Republic, and Ghana's health financing reforms. And I'll end with Ghana's call for action for Africa. Like you all know, Ghana has a very vibrant national health insurance scheme, but we just didn't start. In 1957, when Kwame Nkrumah took over as the President of the Republic, that was when Ghana got independence. We had free health care, actually, for everybody. But in the next 13 years that followed, economic shocks led to the structural adjustment program. And hence, Ghana started collecting nominal fees. After that, by 1985, the subsidization of health was even not possible. So we had to go for user fees, what we call cash and carry. If you don't pay, you will not be seen. You can imagine how devastating that was. Then after that, the country came together, pulled together, and saw the need to have a national health insurance scheme, which basically will be tax funded. So that is one major difference between what we have in Ghana. The national health insurance scheme is supported by our taxes, 2.5% of what we pay for VAT, and all public sector workers or formal sector workers also contribute 2.5% of their SNIT or their pensions towards the national health insurance scheme. Together, this gives us about 90% of the funding that we generate for the national health insurance scheme. Now, to put that in even broader context, 56% of our current health expenditure comes from Ghana, come from government, and this is mostly from the National Health Insurance Fund. 26% is from out-of-pocket payments. Prior to 2024, 16% came from ODA, but it has since declined to about 4%. So following this journey, by 2003, we had a very vibrant national health insurance scheme. We have an implicit benefits package that covers about 95% of disease conditions. And we do individual contracting with public, private, and faith-based sectors. We deploy several provider payment mechanisms to make us, our NHIS very, very efficient. But after all this progress, Ghana significantly is also facing the same epidemiological transition of diseases. Non-communicable disease incidence is one of the highest in the country, and I'm sure when Min was presenting, we all saw that. And what even makes it a challenge is that NCDs actually require continuous financing for medicines, diagnostics, out-of-patient follow-up, referral care, and management of complications. At the same time, out-of-pocket spending remains significant for chronic care. You heard me say that it's around 26% of the current health expenditure. But if you actually want to zoom in on chronic care, they suffer the brunt much more than those who have acute illnesses. So the financing challenge is not only about expanding services, it is about doing so sustainably, equitably, and with greater national ownership. So that this brings us to our response from last year. The President of the Republic, President Mahama, held what he called, or what we all call the Accra Reset on August 5th. I'm sure some of you were in Accra then. I was also present. So, and this is supposed to be the anchor for our health reforms, the health finance and sovereignty. So there is a need to progressively reduce the overdependence on unpredictable external aid, especially within the context of dwindling ODA that we find ourselves in. So the policy implication would be very clear. Financing for NCDs, including Pen Plus, must increasingly be built on domestic public fund finance and strategic pooling and innovative partnerships, something that Kingsley eloquently talked about. But I must emphasize that this is not a rejection of partnership. It is a shift towards country-led fiscal responsibility and resilient financing for health. So although we are cutting down on the over dependence on ODA, we are still very much open to partnerships that really would focus on dealing with the challenges that we have as a country. So these commitments or these pronouncements have actually been followed with very strong commitments from the government. The first thing that the president did when he took office was to uncap the National Health Insurance Fund. Kingsley alluded to that in his presentation. And this created additional fiscal space for health. So we in 2024, let me just give this example. In 2024, we had about $600 billion for healthcare when the National Health Insurance Fund was capped. When it was uncapped, we had an extra $300 million. So this actually improves the flow of pooled resources available for benefit expansion, strategic purchasing of priority services. It also creates a platform for financing chronic disease care through the National Health Insurance Scheme rather than relying on episodic project support. So for Pen Plus, this matters because severe NCDs, NCD care requires predictable financing for long-term medicine, diagnostics, and referral level services. In addition to that, we are dealing with the WHO PEN using the new free primary healthcare policy that we have in Ghana. So this would basically focus on preventive and promotive care. The National Health Insurance Scheme Act was established in 2003, was mostly curative. So with this, we are introducing a program that is fully financed by government. We have a benefits package that is looking at screening for hypertension, screening for diabetes, screening for some very common cancers like breast cancer, and also intensifying education on healthy lifestyles. And this is supposed to facilitate our path to universal health coverage. Additionally, we have another mechanism, the Ghana Medical Trust Fund, which is affectionately called the Mahama Cares, named after the president. And this actually begins with, or it was initiated with some proportion of the National Health Insurance Fund, but they are focusing on mobilizing support from the non-traditional sources of funding, from industries, from international organizations, even from philanthropic individuals. And I must say that in the last 12 months, they've been able to bring in an additional $100 million just because of this innovative way of funding. So this funding is solely dedicated towards non-communicable diseases. And what's good about this? There's predictable resources, and it also complements the coverage of the National Health Insurance Scheme. Like you all know, WHO pen would actually reduce the incidence of complications from non-communicable diseases and actually non-communicable diseases. So in other words, this is actually good returns on investment. So additionally, the Ghana Medical Trust Fund would also assist with specialized treatment. So when you're talking about PEM Plus, you want to build capacity in district hospitals and regional hospitals. So that's one good thing that the Ghana Medical Trust would do. It will also help to build infrastructure, the relevant infrastructure, and then also get the right equipment, especially laboratory facilities for diagnosing some of these non-communicable diseases. So we also would encourage strategic partnerships so that more funding will be released for non-communicable disease. So in a jiffy, the next diagram will show you Ghana's health financing reforms. So at the very base, where you have the pre-primary health care, everybody has access to preventive, promotive health care and to basic health care services. Usually, that will be at the CHIPS compounds, the small community clinics, the health centers, and the polyclinics in the country. Then beyond that, at this level, you actually don't need to be registered with the National Health Insurance Scheme, but we would facilitate your registration nonetheless, because beyond that, if you want to seek care with the National Health Insurance Scheme, you'd need a card. Then after that, for the conditions that are not covered by the National Health Insurance Scheme, especially complications of non-communicable diseases, most cancers, that will be covered by the Ghana Medical Trust Fund, as I have mentioned. So this is Ghana's health financing reforms in one diagram. So what this means for PEN Plus is that PEN Plus fits naturally within Ghana's broader universal health coverage and health financing reform agenda. It offers a way to effectively decentralize management of conditions such as type 1 disease, diabetes, sickle cell disease, and chronic kidney disease, especially to the district and regional hospitals like I've mentioned. So from a financing perspective, PEN Plus requires a defined benefits package, predictable provider payment, medicine and diagnostic financing, and clear referral pathways. So Ghana has a good environment to be able to make PEN Plus a very good success. So Ghana's reforms now create a good opportunity to embed PEN Plus within a sustainable domestic financing framework rather than a standalone project. So we recognize that non-communicable diseases and PEN Plus as their core UHC priorities that require high-level political leadership. This has been made possible because the Minister of Health and President of the Republic deem it as a priority. It is important that we build domestic fiscal space for NCDs through public pooling, insurance reform, innovative financing, and stronger budget prioritization. Then we'd also have to use strategic purchasing to finance chronic care packages. Ghana has one of the best strategic health purchasing teams, and we've gained a lot of experience over the past 23 years. And we've also engaged with our partners, WHO, World Bank, and many more in Ghana who have actually complemented what we do. And we also make sure that we work very well with public-private, with private partnerships and the philanthropists as well, both in Ghana and outside Ghana. And they actually also offer a lot of technical collaboration. So in conclusion, Ghana's experience shows that political commitment must move beyond statements to financing decisions, institutional reforms, and a clear accountability for results pathway. The recognition of health financing sovereignty the uncapping of the NHIF, the National Health Insurance Fund, and the establishment of the Ghana Medical Trust Fund are important signals of that commitment. The next step is to translate these reforms into effective coverage for chronic non-communicable diseases through PEN+, strong primary care leakages, and sustainable protection for patients and households. On that note, I want to thank you very much for your attention.
Thank you, Dr. Kwesi, and we are all invited to the country experiences side events. That is where we go deep, and you'll be able to ask questions to Dr. Kwesi to understand how different countries are looking at their financing infrastructure. Finally, and certainly not the least, is my friend Dr. Njeri Gitau, and she's representing many people. You're carrying many people on your shoulders. I know you work for Roche Africa, but in here we have other partners of government, Hemsley Trust, we have Welcome, we have WDF, we have Bloomberg, we have Gates. I know you can't speak for them, but you can speak in principle about how to partner with government. And your talk today is basically looking at how do we unlock private sector financing to strengthen NCD care in the African region. Thank you.
Thank you, my fellow countryman, Daktari. Good morning, everybody. Habari ya asubuhi. I hope those who are not East Africans have learned a few Kiswahili greetings. So this morning, I'll be taking us through the economic case for private sector financing in NCD care. I know we were all here during the opening ceremony, and I think the children's presentation really represents why we need to urgently address NCD care. They told us to stop NCDs now. Why is that important? Everybody has spoken about the demographic dividend that Africa has, but are we really planning? Please stay on the first slide. Are we really, please go back. Are we really planning for this generation? Are we going to reap the dividends and ensure that they remain productive to their very old age, like in Japan? So my name is Dr. Njeri Getao. I work for Roche Africa, and I'm the health policy and access partner. Next slide, please. So it's good to speak in numbers. Private sector loves numbers. That's the only way we get convinced to invest. And so we've talked at length this morning about the shrinking fiscal space. So these 62 countries, I'm talking about LMICs, so beyond the 54 countries in Africa, we are spending so much money servicing debt. What does that mean? Our priorities in terms of investing in healthcare, preventive healthcare, infrastructure are not there. I've talked about the demographic dividends. 60% of our population is under 25 years of age, and we have our rising NCD burden. So how do we position health as a macroeconomic driver? I like to say that I hope during the COVID pandemic, one of the things that came out very strongly was that the health of individuals is important to economic growth, and the numbers speak for themselves. So we can see that by 2050, if we invest in health, we'll have an annual growth of about $12.5 trillion. And so we're looking at proven interventions. We're not reinventing the wheel. So going back to the drawing board. If we look specifically to women's cancer, women's health, for every $1 invested in women's health, we get a $3 return on investment. This is about 137 million women being in the workforce. We can see this across all regions in the world. A working mother, working woman contributes to the economic well-being and the health of the home, the community, and the country. Next. And so we have what I like to describe as the vicious cycle and the virtuous cycle. We want to break this vicious cycle and move into the virtuous cycle. And what is this vicious cycle? It's been clearly described, but In summary, we are talking about delayed diagnosis and treatment of NCDs, which are rising. If I take breast cancer as an example, we have a study that we conducted as Roche with the Y4 Institute in 7 countries: Kenya, Ghana, Tunisia, Egypt, South Africa. And we saw that about $10.3 billion is lost the GDP due to breast cancer alone. What does this mean? We have about an 89% loss in working productivity, working age women. What does this mean? We have a productivity drain, economic stagnation. Why? The high out-of-pocket spending that has been illustrated by my colleagues. So this is an extremely vicious cycle, and we really need to think about how do we break this? Where does private sector come in? Where do other partners come in? Where does government come in? In the virtual cycle, we want to realize the demographic dividends. We want to ensure that our workforce productivity is high. We want to be able to increase the economic return on the little investment that we need to do in our healthcare system. $1 can give us a return on investment of about $12.4. And so how do we do this? And so private sector comes in what we like to say blended finance and pooled risk. Kingsley has really talked about it at length. And next slide. So how does private sector come in? How does this work for us? So as we all know, traditionally, if you look at banks, private equity firms, and other private sector players, they tend to run away from high risk investments. They want to look at low risk investments, medium risk investments that guarantee a return on investment for their money because they have shareholders to respond to account to in terms of where the money has gone. So when we talk about blended finance, we're talking about a cake where we have the concessional foundation, where we have those who are able to absorb the high risk. These are governments, these are your multilateral development banks, philanthropy organizations, and these have what we like to call flexible capital that can absorb higher risks and accept below market return on investments. And they provide an essential de-risking guarantee to the private sector, which then is a commercial engine and is able to provide scale, execution. We require market-based returns, and these can only be unlocked by the concessional foundation. And what we expect at the end of this, if these two come together, if these two work together, if we work towards really prioritizing blended financing, we can de-risk a lot of innovation from the private sector, whether it's through digital products, diagnostics, biologics that can serve our public health goals specifically for NCDs. Next slide. So I will take us through 2 examples where Roche has played a key role. This is not exclusive, but I thought that I should share these 2 examples. So we have been in Cote d'Ivoire for many years. This was microfinancial engineering 10 years in the making. We're now reaping the benefits. We provided technical support in thinking around the debt swap, debt restructuring, where the government bought back the short-term, very expensive commercial debt and secured a 15-year low interest loan from the World Bank. So what did this do? This unlocked money that the Cote d'Ivoire government was paying the commercial creditors, unlocked about 330 million euros savings, and without raising taxes. Around Africa, we are all crying. Let me speak for my country in Kenya about being overtaxed. And so what did the government choose to do? It chose to invest in the social sector. And the health sector was one of the beneficiaries. And this is where then Roche came in. We have a 10-year public-private partnership where we consolidated about 12 innovative therapies on NCD, biologics, medication, diagnostics into what we like to call a basket deal. And this is a single fixed cost agreement, negotiated cost agreement below market rates. And this basically meant that in terms of clinical delivery, we have a predictable expenditure for the government, reducing out-of-pocket costs for the patient for these diseases. So what are some of the results we are seeing currently? In the last 2 years, we've been able to treat about 3,000 patients. When I talk about breast cancer, the National Cancer Institute has reported a 25% reduction in breast cancer. In 2014, Cote d'Ivoire only had 4 oncologists. They now have 20 as a result of this investment, amongst many other health system level investments. Next slide. The second case study is Nigeria, infrastructure and risk sharing. We saw earlier today, Nigeria has one of the highest out-of-pocket expenditures in healthcare across Africa. When we look at breast cancer, about 30,000 new breast cancer cases are diagnosed annually. And so what is happening? What are we doing as private sector as WASH? We have partnered with the NHIA and with the National Sovereign Investment Authority of Ghana, NEDSAV. And what is happening here? So the NHIA is integrating diagnostics and treatment within the National Health Insurance framework to protect against financial catastrophe. Cost sharing, we have given a 50% discount to cover for biologic medical costs for breast cancer, and we have also partnered with the NSIA for sustainable financing for physical equipment, where we have about 152 newly trained clinicians and new diagnostic centers. Why is this important within the current dispensation, especially when we talk about the ACRA reset, when we talk about health sovereignty, using our sovereign wealth funds? This is a fantastic example of Africa taking charge of its own financing, and something that we should really be proud of and try to emulate. And what are we seeing currently? We have about 3 times increase in the cancer centers of So this last slide really embodies what we, a quote I hate to hear, but we love saying. Africa has so many good policies, very many good strategies, but we don't implement them. All these policies, all these strategies have amazing data, but we need to make decisions, we need to take action. So we have the evidence frame, we need to reframe health from a welfare driver. Our regional director, WHO, talks about it at length and really emphasizes on it during the opening ceremony. We need to anchor the $12 economic return on the only $1 investment in cancer care to restore workforce productivity. What is the policy ask? We need to demand blended partnerships, whether it's basket deals, cost sharing, tax or debt restructuring, and these have to be bankable projects. From the private sector perspective, what we would love is to ensure that when government partners with private sector, with philanthropic organizations, with other donors, these are bankable projects. Will they actually lead to some some impact? And then the choice is ours, really. Inaction is not a neutral state. It carries measurable costs. So breast cancer alone will see a 27% projected burden increase by next year. So very close to us. So policy trade-offs are political choices. Which architecture will you build? Last slide. Bringing us back to where we're here. Stop NCDs now. Thank you.
Thank you, Jerry, and thank you for reminding us to move beyond saying we have dreams, we have desires, to talking about plans. Let's commit these policies to workable interventions for our people. I'm guided that because of time, we will make sure that we look for these colleagues outside there, their booths, the country experience. There'll be a session where the two gentlemen from Ghana will attend and will share their experience more. And if you have questions, then you can reach them there. My colleague Min will be around, and myself, you can reach us in the corridors so that we can quickly move to the next session to try and catch time. So please join me in giving this panel a round of applause. Thank you. Thank you, colleagues. We will take a group photo here, colleagues, even as Dr. Chido from WHO Afro Mental Health comes in into the next session. Thank you very much.
Good morning to you all. All protocol observed. So we are going into our parallel sessions. And I don't mind if you stay in here because this will be the mental health one. So we've got a parallel session in this room for mental health, accelerating progress towards 2030 African mental health targets. And there is another session in Mikumi conference room on the second generation pen, which will be happening in Mikumi conference hall. So if you stay in here, you'll join us for the mental health side event, or you can go to Mikumi. As I said, we do not mind if you stay with us in here. So as people settle in, sorry, IT, can we play the mental health recap video from Johannesburg? And as they're playing that, I would ask if Dr. Kofi can get ready for his opening remarks.
Been working for WHO for 25 years, and the changes in global mental health are amazing, hard to synthesize. Right now, we have a lot of organizations that are realizing how mental health is important. So they are committed, engaged in promoting change in order to make sure that anyone, no matter where they live, finds an answer to the needs that their mental health challenges present.
Mental health is always thought of as an afterthought, that, you have funding available, you're going to focus on this particular program, and if you have a little bit left, you put it into mental health. We need to change that narrative.
So this meeting is going to encourage countries to come up with clear roadmaps for what needs to be done to meet the 2030 targets within the region. At the back of your folders is another reminder about what our targets are. So we keep talking about these 2030 targets. What are they? The roadmap. What is it that we want to do? The 2022 regional framework illustrates it very well. Those 4 to 6 targets are achievable. We're encouraging countries to identify a few key priorities that can be pushed forward in the next 4.5 years. We will then be supporting countries technically to implement these plans, and we'll also then be working with partners to be able to come alongside our ministries of health to meet the targets and to encourage strengthening of our mental health systems.
Forums like this mental health intercountry learning meeting is very important because it brings countries together to learn from each other, lessons learned, best practices. It helps the countries to develop their capacity, and this learning helps us to align our various policies into the global and the regional frameworks in WHO, such as the Global Action Plan for Mental Health.
Investing in mental health is incredibly important because of the scale and size of the need, but also the opportunity for changing people's lives. And we know a lot about what works, we know what some of the barriers are, and now we need more investment to make that change.
As you all know, mental health care is a Cinderella of the healthcare system, which means when budgets become mean, when we go through austerity, they are the last ones in the queue. We're trying our best to uplift them. And we've tried, because of shortages of staff, to train as many mental health care nurses as possible. Because South Africa has got only 850 psychiatrists for a population of more than 65 million people. And 80% of those psychiatrists are in the private sector, taking care of only 14% of our population. That's why we're training lots and lots of nurse practitioners for mental health. We have also tried to train a number of traditional healers.
The main lesson I've learned, which I'd like to share, is that any provision of mental health care service should be contextualized. In doing so, we are able to address the different social determinants of health.
What is special about us that we train specialists here, we train psychiatrists, we train specialized nurses that are placed from the universities in our area. We've got a lot to offer to other African countries in that we have managed to structure the mental health care services very well, such that at least we can then be able to categorize our patients accordingly. We have established very good working relationship with the primary health care, the mental health care services.
These forums help us to accelerate progress to achieve the main targets for mental health. And once we come together to accelerate progress, it helps countries to learn innovations from one another and also help countries to come up with innovative strategies to be able to achieve these targets.
Rwanda has two particularities. One is a country in Africa that has a high burden of mental health problems. The historical background, it's a country that faced the genocide against Tutsi, and this led profound trauma and mental health consequences. And two, in the last 3 decades, it's a country that tried to put in place systems of care, policies, institutions, to alleviate this burden in a country that have limited resources.
But what's the next step? What is that you think you can actually do to move this agenda forward?
The 7th Global Ministerial Mental Health Summit is a very important event. For the first time, it is coming to Africa and to Rwanda. Rwanda is very proud to host the event.
It is reconforting how much progress we have made globally. It's amazing. In 40 years, so much has changed, but a lot still needs to change. Let's continue this work with urgency, with commitment, and with decision. And I'm sure that much sooner than that, we will see way more changes in the world. Thank you.
Thank you, IT. So I'll call upon Dr. Kofinyaku, our team lead for NCDs and mental health, to give us our opening remarks for this session. May I kindly ask if you can move forward? It is a side event, so there's few of us in here, and we'll be having a conversation as we go. Thank you.
Thank you, Dr. Chido. Distinguished guests, colleagues, and partners, good morning. Welcome to this important side event on mental health. It is my great pleasure to welcome you all to this important side event on mental health at the 3rd International Conference on 10 Plus ICPPA 2026. I would like to take this opportunity to acknowledge the presence of representatives from ministries of health, WHO colleagues, development partners, civil society organizations, and all stakeholders joining us today. Your participation reflects a shared commitment to advancing health and well-being across the African region. This conference, as you all know, provides a critical platform to accelerate progress towards achieving Sustainable Development Goals for NCD. And today's discussion on mental health places mental health where it rightly belongs, at the center of health and development. We cannot talk about NCDs without mental health. And mental health is not a luxury, it is a fundamental component of overall health and basic human rights. It enables individuals to realize their potential, cope with the stress of life, and contribute meaningfully to their community. Yet, across our region, the burden of mental health issue remains both significant and deeply concerning. I'm sure that you are aware that in some countries, mental health practitioners, we can count them in some of them double digits or even single digits. Nearly 150 million people are affected by mental health conditions, including depression, anxiety, and substance use disorders. At the same time, the region continues to experience the highest suicide rate globally. These figures remind us that mental health is not only a health issue, it is a developmental challenge, a social justice issue, and an urgent priority for action. And despite this burden, mental health systems across our region remain under-resourced. At the same time, we must recognize the strong and often overlooked link between mental health and NCDs. As people have chronic conditions, it leads them to other mental health issues. And I think, as I said on the first day, even globally, it is said that out of every 7 people, 1 may be affected by a mental health condition. And this underscores the need for integrated person-centered care that addresses both physical, mental health, and that is accessible within our communities. The Africa region has demonstrated its commitment through the adoption of the regional framework for strengthening mental health systems. However, we must also acknowledge the progress that the progress has been uneven, and we are not yet on track to meet the 2030 targets, and a lot needs to be done. As we move into the presentations and discussions, I encourage all of us to engage actively, to share openly, and to think boldly about what more we can do in our region, individually and collectively, to transform mental health care in our region. Let us use this opportunity as we gather here to strengthen partnership, mobilize investments, and accelerate progress towards accessible, equitable, and high-quality mental health services for all. I thank you for your attention and wish all of us a productive session during this side event. Thank you very much.
Thank you very much, Dr. Kofi. And as we proceed, I will call upon our various speakers who will be joining us today. Ms. Beryl Naikin, State Secretary for Mental Health from Seychelles, and Mr. Jacob Shamiarira, a person with lived experience, who is also a managing trustee for Pamburi Private Voluntary Organization. Dr. Liviana Dinima from Ghana, psychiatrist from Ghana and with the WHO country office. I will introduce them in detail as they come to speak. And then we've got Ms. Emily Miner, the head of equity and mental health at the Wellcome Trust. She's joining us online. Can we check if she is able to hear us and able to speak? Is Emily online? Before we proceed. Okay. All right. So I will start just by giving a brief overview of where we are in terms of mental health in the region. I think I've been introduced before. My name is Chido. I'm a psychiatrist. I don't think there are many of us in the room at the moment. I think there's two, me and my colleague Liliana. Are there any other psychiatrists in the room? No, I didn't expect it. Because our crowds are very different, these are some of the challenges with the silos that we have within NCDs and mental health. The very fact that there are very few mental health practitioners in this room when we're talking about NCDs. And it's the same when we have mental health discussions with very few NCD people in the room as well. These are some of the challenges. So next slide. So I'll be talking about accelerating progress towards these 2030 targets, but we need to actually talk about the burden and what these targets are, what the region has agreed to do before 2030, and where we are, and what needs to change in the next 4 years. Next slide. So Dr. Kofi has already started us off. Mental health is about thriving. It's not just about treating mental ill health. It's about thriving. It's about being able to cope with the challenges that we face, to connect with others in a healthy way, to function, to be able to be productive and fruitful and contribute to our communities, and to thrive, to really reach our full potential. So it goes beyond the absence of illness, but it's actually being well. And we need to build systems that support that. Systems that are not only managing mental ill health when it happens, but actually supporting prevention of mental ill health where possible and promoting mental well-being. So we really need to be conscious about that when we talk about it. So it's not just about illness, it's about well-being and thriving. Please, next slide. Then there's a link between mental health and NCD. This is not just stress. I think on day one, someone commented that some of the drivers to NCDs is stress. True. One of the challenges that's there. People are stressed and they've got stressful lifestyles, stressful environments. They can develop NCDs. But there are other linkages as well. The severe non-communicable diseases that we've been talking about for the last few days are very closely linked with mental well-being. And people living with NCDs are at a higher risk of depression, anxiety, and psychosocial distress. Part of it is yes, dealing with a chronic illness, but part of it is physiological as well. We know that people with diabetes are actually at a higher risk of depression physiologically because of their condition. So there's a link between the condition and the higher rates of mental health challenges. But mental health challenges on their own can also worsen physical health outcomes. We know people with chronic severe mental health illness are at high risk of dying. People with schizophrenia are at a high risk of dying, partly because of poor care, because mainly when they come to a hospital, their mental illness is what is cared for, not necessarily some of the physical health challenges that they might face. But if someone has a mental health challenge, they also have challenges with treatment adherence. So if I have a mental health problem and I've got diabetes or I've got hypertension, I might have challenges being adherent to treatment. I might delay health seeking because of my challenges with my mental health issues, and there might be poor self-management, which is so critical with NCD management. And then NCDs and mental health issues are chronic. So these are things that you might have to live with for the rest of your life at times. They're often stigmatized as well and require long-term people-centered care. So there is an interlink there. And when we address mental health along NCDs, we are really improving quality of life of people and strengthening treatment outcomes both for mental health and for NCD and providing holistic care. When someone walks in, we're taking care of the whole person, not just part. Next slide. So as Dr. Kofi alluded to, there are nearly 150 million people in the African region who are struggling with mental health, neurological, or substance use conditions. Top of the list is anxiety. Anxiety is the most common mental health problem, but it's one of the least recognized. Many times it goes unnoticed because there's no mechanism or systems to actually catch it. And this is within mental health systems, but also within general health systems, within NCD treatment systems. Anxiety is something that is just not recognized. Followed closely by depression as well. And then we have challenges with alcohol use. And we know very well the linkages between alcohol use and NCD issues. Drug use is a problem within the region, and we also have issues around schizophrenia and bipolar, but these are much less, as you can see, compared to anxiety and depression. We're now seeing quite a bit of neurodevelopmental problems like autism. And this actually brings in a complication because if someone has a neurodevelopmental challenge, if they develop an NCD, it is quite a complication in terms of how to manage them. They need a way of not only diagnosing their challenge, their physical health challenges, but being able to manage them in a way that is appropriate for their condition. We have close to 2 million people living with dementia within the region. This one is important because of the interlinks between NCDs and dementia. Dementia is very poorly recognized at the moment in the region and poorly cared for. Because we're a young region, many countries are not prioritizing it. Not a single country within the region has a dementia plan or action plan of how to deal with it because the priorities are elsewhere. But we're expecting that the number of people with dementia will increase because of the rising increase in NCDs. NCDs drive the dementia risk as well. And then suicide. Suicide is something that we cannot go without mentioning. The African region has the highest age standardized suicide rate amongst all the other regions, sitting at 11.5. And these are mostly young people, young men who are dying by suicide. So we need to be conscious of this. Mental health conditions can be managed at relatively low cost if systems are actually capacitated to be able to do. Next slide. Then we're talking about young people as well during this conference with 10 plus. And we must highlight that over 250 million adolescents live within the African region. It's a large number. And we know up to 50% of mental health conditions start before the age of 14. So even before you introduce the issues of NCDs, severe NCDs, young people are at a higher risk of developing challenges with mental health, especially if they don't have a lot of support. Anxiety and depression are very common among children and young people. Anxiety particularly can actually start presenting as early as 5 years old, but we don't have the systems to be able to actually pick that up. Those people are only managed much later on when they've had chronic issues with anxiety, which can contribute to challenges with managing their severe NCD as well if they have them. And there are consequences of not managing mental health within young people. It affects their school performance, it affects their prospects in career. They can get socially withdrawn. They can start to have other risk behaviors as well. So we need to be holistic in the way we look at young people. Not only their severe NCD, if they have one, but their mental well-being as well, if we really want their outcomes to be good. Next slide. Just to highlight this issue of anxiety, I'll keep harping on it because our systems really are not built to pick it up. If you're looking at the age of 5 to 9, anxiety actually is the mental health condition with the highest disease burden amongst young people. But if you think about how our clinics are set up, how our health facilities are set up, we're not actually picking this. And this is a major challenge, then followed by a neurodevelopmental problem also. Next slide. If we go a little older, between 10 and 24, we start to see depression as well. And the autism remains, but anxiety is still at the top. So really, if you are thinking about your services, think about this. Are we picking up this anxiety and building systems that are fit for purpose? Next slide. Suicide I've mentioned, and we've got a very high rate, particularly amongst men. The age standardized suicide rate for men is 18.4 amongst African men. And this is something that is completely being missed. There's very little policy direction about how to manage this within the African region. But these are needless deaths, these are preventable deaths, wholly preventable deaths. If the mental well-being is being considered, and suicide prevention has got many evidence-based approaches to actually curbing this challenge. But we must talk about it because one of the drivers for suicide is also chronic illness. So if someone has a chronic illness, they're actually at a higher risk of suicide. But a chronic illness, they are young, they are male. Already they've got a lot of risk. Next slide. Then alcohol, I think this one is well known within the NCD community. Alcohol is a high risk factor for NCDs, but it's also a risk factor for poor mental well-being and a lot of other things, including infectious disease as well. It increases the risk of that. and then the NCDs for malignant, the cancers, the cardiovascular diseases are there as well as injuries, both intentional injuries and unintentional ones as well. So alcohol is a major challenge. Next slide. Then dementia, I'll come back to this one. Just highlighting also that within the region, although we have got a very young population, if we don't do any dementia risk reduction interventions, we will have a bigger challenge with dementia in the coming decades. Because we've now got a higher rate of NCD, this is putting us at risk of higher rates of dementia. And also to highlight that this is going to affect our communities very differently to the way maybe it affects higher income regions, because a lot of the care actually currently is happening within families and households, and the burden is on women. So the care is happening within the home, care being done by mostly women who also have other responsibilities to do to take care of. So we really need to think about prevention. Because we will have challenges in terms of how to manage this burden as it increases. Next slide. And just to mention that we are guided by the Global Dementia Plan for our actions for dementia. I've highlighted that only 6 of the 47 countries in a survey that we did in 2024 for the Global Dementia Observatory reported running active dementia risk reduction campaigns. And this was whether it's integrated with other NCD campaigns or it's a standalone campaign. So again, it's not really a priority. I've already mentioned that none of the 47 countries have a national plan of how to manage or deal with dementia. Next slide. So just looking at trends since 2014 until 2023, where we have the latest data, there's been an increase in depression, and this is something that had already been noticed, particularly after COVID. We had a sharp increase in rates of depression in the region. Anxiety has gone up exponentially, and this is something again that I'll highlight. Our systems are just not fit for this. We're not picking this up, and we're not managing it. Alcohol use disorders have gone slightly down, but our alcohol use per capita hasn't. So that's a challenge. And then, of course, dementia is there as well, and our neurodevelopmental conditions, particularly autism, have been going up. Next slide. So what was the response of the region in 2022? We aligned with the Global Action Plan. There's been a Global Action Plan for mental health since 2013. It's running until 2030. And then in 2022, we aligned as a region to this plan. Prior to that, there had been other plans that the region was following in terms of mental health. But in 2022, the region developed a framework to strengthen the implementation of the Comprehensive Mental Health Action Plan. And this is going to run until 2030. And it really is looking at strengthening our systems for mental health, including leadership and governance and financing, but also improving access to care through decentralizing care, through integrating care, which is what we will focus on today. And then an increase in the mental health workforce. Most of the specialist mental health workers are living in cities, concentrated within cities, the few that are actually there. And then that then affects geographical distribution, and this becomes an equity issue. So if you're not living in a city, you don't have access. And this becomes a challenge. And then our data systems as well, to strengthen our data and research around mental health, and then to strengthen prevention where possible. Many of these conditions, there are ways to prevent the social drivers, the socioeconomic drivers towards that affect our mental well-being. I think that can be addressed. Next slide, please. So in 2024, going into 2025, we did a progress report on the regional framework. If you haven't accessed it before, the QR code on top there, you can access the progress report that was reported at the regional committee last year. And we found that 29 of our countries now have a mental health action plan of some sort of policy or plan, whether it's standalone or integrated into other health plans. And only 17 of these plans, though, are aligned with international human rights standards. As you know, mental health, we've got an unfortunate history of human rights violations and abuse. So this is a challenge to have so few of our policies actually aligned. So we've got policies, but they don't necessarily protect the rights and dignity of people who live with these conditions. When we look at neurological conditions, only 20 countries actually have some plan about neurological conditions. When it comes to financing, 16 of the 47 countries have got a budget line for mental health. And the median government expenditure on mental health sits at 7 cents per capita. This is actually down from 50 cents per capita in 2020. So we're going this way, not up. So I know my brother Kingsley talked about having flexible budgets for NCDs, but mental health is the Cinderella really. Even in that flexible budget, the portion that goes towards mental health is very, very small. And the portion that is going towards mental health often goes to our big institutions, the asylums. So most countries have 1 or 2 asylums, and most of the budget goes to that asylum, and then they say we've budgeted for mental health. We are the budget for integrated care is very limited, and this is challenging. Then we go to data. 24 of our 47 countries have got indicators, are routinely reporting on indicators for mental health, which is a challenge, and 15 for neurological conditions. Then service expansion. Only 7 of the 47 countries as of 2025 were implementing comprehensive primary care integration of mental health. What does this mean? It means that there's a guidance document that guides mental health care within primary care. There is training of primary healthcare workers in basic mental health care management using tools such as the MHCAP. There is support, supervision, and mentorship of those primary healthcare workers, because a primary healthcare worker will not turn into a specialist because you've given them MHCAP training. They need support, they need supervision, they need mentorship by the available specialists. There is availability of medications where they are needed. Then there's availability of psychosocial intervention as well within primary care. So only 7 countries are meeting at least 4 out of those 5 criteria. So we are a long way. And of course, we've got very few specialists already within the region, only less than 1 psychiatrist per 100,000 and 2.2 mental health workers. This is inclusive of psychiatrists, mental health workers, clinical social workers, clinical psychologists, occupational therapists, 100,000 population within the region. Next slide. So these are just maybe diagrams that we can skip over just to illustrate where those policies are within the sub-regions, but I think we can move for the sake of time. Next slide. And the next slide. Next slide again. Yes, you can stop here. So mental health and psychosocial support is important, particularly in emergencies and disasters, as you can see right now with the Ebola crisis. This is important. When care is being provided, that we are conscious of the mental health needs within those situations. And the countries in green are the countries that have reported having integrated mental health and psychosocial support within their disaster preparedness and response plans. So we still have quite a few countries which haven't done that, and also a few where we don't have to. Next slide, please. Again, you can move on to the next one. This is about medications. We looked at neurological medications. They weren't actually mental health at this point. We've been working with a few countries now for both psychotropic and neurological medicines. For psychotropic medications, only 10 countries in the region report having availability of these medications at primary care. So many countries don't have the medication at primary care. It will be available at secondary or specialist level, which means that the care is inaccessible. And then neurological medicines as well, a similar picture. This graph is from the Intersectoral Global Action Plan survey that we did again in 2024, which is illustrating which countries have readily available medications. There are countries that are doing well, like Cape Verde, like Seychelles. They will have 10 neurological medicines available, generally available in primary care. But there are also countries that are struggling with 1 or even less than, fewer than that in terms of neurological medicine availability. Next slide. So what are the targets? Like I mentioned, policies, budgets, integration into primary care, and routine reporting. The projection for 2020, 2030 for policies was 100%. So in 2022, countries agreed that all countries within the region by 2030 would have a policy or a plan for mental health by then. Currently, we are at 60, just over 61%. the projection, looking at the trend from 2014, we are not going to reach that target of 100%. We will likely be around 54%, if nothing more, if we continue business. In terms of dedicated budget lines, very similar picture, where 34% will only just go to about 37%. We were aiming for 70%. So something drastic needs to change at this point if we're going to get anywhere near that target. Integration particularly, and this is the most important because this is about actual services being available to people. At the rate where we are likely going to only be at less than 7%, and we're aiming for 20. We were aiming for 60% of countries, and then data as well. We will likely hit around 58% if nothing changes, and we're aiming for 95. So we are off track on all the targets of the regional framework as at this time. Next slide. So what needs to change? A number of countries need to develop plans, need to put money aside for these plans, need to integrate mental health into services and to strengthen data. But really does need domestic financing. At 7 cents per head in the region, we're not going to be able to do it. This is again has gone down. In 2020, it was 50 cents a head, which was low already. Now we're at 7 cents a head for mental health, probably because of the challenges with financing generally. Then we need a stronger emphasis on integration and person-centered care, a collective advocacy around this area of work, and really intensive implementation of the region. Next slide, please. Just keep pressing so that until we get to Kigali. Yes. So there is a global ministerial mental health summit, and we are very grateful to welcome Trust for the support that they're providing for this. This is the first time that the summit will be held in the African region. Several summits have been held since 2018, but it had never been held in an African country. And this is, we're very, very excited that this conference is coming to Africa, and all the African region member states will be invited, and the ministers will be funded to attend. So we're very grateful to welcome for the support. And this will be next year in March in Kigali. So if you want to find out more about what these mental health summits are about, it's about political commitment and really political advocacy around mental health. And they have really worked in other regions. And you can find out more using that QR code about what has happened in the other summits. Next slide. And again, with support from Welcome, we've been now preparing for this summit. It's such a strategic meeting that's going to happen within our region. We thought that we need to be well prepared for it. So we've started having preparatory meetings with member states. The first one was held last month in Johannesburg, and it was quite a successful event with the first 21 countries in attendance. And you saw the spotlight video as we were starting our session. And we worked with countries. They did a landscape analysis before coming for the meeting. They presented on these, discussed around key priorities. The way we framed it was, what can we do with what we have? Not saying we need funding for a million things and for a lot of money, but with the resources we have, what can we do from now until 2030? So that was how we were framing our discussions. Partners were available. There were close to 30 partners who also attended this meeting. So the discussions were great, and also people with lived experience were a key part of the discussion. Next slide. We're now moving on to Togo, where we will have a meeting with the West and Central African countries from the 15th actually until the 18th of July. The 18th of July will be a youth engagement. We're going to get consultation with young people, particularly for this session. So we will be in Lome in a few weeks' time doing the same exercise. Next slide, please. And this brings us here. We're also considering this meeting as one of the consultative meetings that we're going towards Rwanda, because the NCD community is very important in terms of how we are going to be able to integrate mental health and NCDs, but also how we're going to accelerate progress towards these targets as well. And towards the end of this session, we're going to do a fun exercise with a slide of poll where we will collect your thoughts around this area. So please do stay with us. Next slide, please. So I'll stop here. I think you've heard enough of my voice. And we will start with our other speakers. Next slide. So I'm going to introduce Ms. Beryl Niken before we play this video. You can start getting it ready. Ms. Vero Naikin is the Secretary of State for the Mental Health Care Agency in the Seychelles. And I believe this is the only country that we are aware of that has a state secretary for mental health. And it is a new way of really looking at mental health. She sits in the office of the president, which is multi-sectoral. So she has a unique opportunity to influence mental health across different ministries and in a multi-sectoral manner. She was appointed this year in 2026, so this is a new initiative for Seychelles, a different direction that they are taking the country in terms of mental health. And she is a senior clinical psychotherapist and a public sector executive for the last 28 years, with experience in counseling, in human rights-based practice, and also in mental health services. So we will play a spotlight video about what is happening in Seychelles, because it's quite unique, before Ms. Vero gives us her keynote address. Thank you.
The region, countries are re-examining how mental health is within government, recognizing that leadership and governance are critical to building health systems that work for people. In Seychelles, that recognition has shaped policy and practice over recent years. The country's experience offers other governments in the region a practical reference point for what change can look like. Mental health affects how people live, work, and participate in their communities. In Seychelles, government has increasingly treated it as a public health priority that demands a direct response. Challenges linked to substance use, social change, and growing pressure on services have made clear that mental health cannot be handled at the margins of government. It requires political attention and sustains coordinated action across government. Over time, this shift has moved mental health closer to the center of national health and social policy.
There is this perception out there that mental health is merely mental illnesses, but it encompasses more than just illnesses. It's about the lifestyle, the way the individual is actually going through life itself. Our government, over the past few years, have been observing the situation in the country, and we've realized that there are a lot of causes related to why currently we've had such an increase in the number of mental health issues.
We are a population of about 120,000 only. I would say that the prevalence of mental health illnesses in the country is gradually growing. According to WHO, at least 1 in 5 people in general will suffer with mental health issues at least one point in their lives. But given there's a prevalence of social ills in the country, compounded with the drug use also, which is on the rise, so we'll see that this is multiplied twice or even 3 times higher.
So for our government, it was a very important decision was to create the mental health agency, of which the portfolio is under the purview of the president. This policy in itself will allow us as a country to focus resources, that is human resource and also capital resources, to try and find the root causes and at the same time addresses the problem and try to come up with programs, specific programs that will help to alleviate the issues of mental health within our population.
Seychelles has restructured how mental health decisions are made. Responsibilities have been clarified, agencies brought into closer coordination, and dedicated structures put in place. The aim has been to move away from approaches that were fragmented across government and to replace them with something more coherent. With support from the World Health Organization, These arrangements are increasingly aligned with broader national and regional health governance frameworks.
Seychelles is currently undergoing a significant transformation in how we approach mental health. We are moving from a model that was primarily clinical-based, service-oriented, to one that is more coordinated and also one that will promote mental health and well-being, as well as safeguard the human rights, and also ensure coordination across all levels of service. The previous Mental Health Act made provision for institutional management and care, so it didn't have components of prevention, and that and so there were those existing entities that were offering their services, but there was no coordination. So with the introduction of the new Mental Health Care Act, we are making provision to have an agency under that, and that agency will stand as the like a coordinating body. It will actually establish a regulation between service providers, and so which will mean we'll establish standards of care, what will be the standard of training that the service providers will need to have, standard of environment to offer the service, all in the best interest of clients.
Stronger leadership and governance arrangements have created conditions for more integrated approaches to mental health care. Mental health is increasingly embedded within primary health care, bringing services closer to communities and supporting more people-centered models of care. Training under the WHO Mental Health Gap Action Programme, MHGAP, has supported primary care workers to identify and respond to mental health needs in their communities.
There's a lot of that needs to be done when it comes to providing the proper services in the country, and this is why tackling community mental health plays a significant role.
The long-term vision is to look at the well-being of the society and provide our people with the best care that they deserve.
Ms. Niken, we're really honored to have you with us today. Please do come and give us your feedback.
Morning, everyone. Distinguished representatives of the World Health Organization, developmental partners, colleagues, ladies and gentlemen, good morning. It is both an honor and a privilege to join you today at this important side event of the third International Conference on Mental Health. I wish to express my sincere appreciation to the World Health Organization Region Office for Africa, the government of the United Republic of Tanzania, the NCDs Network, and all partners involved in convening this dialogue on accelerating progress towards the 2030 African Region Mental Health. I wish to express my sincere appreciation to the World Health Committee. I bring you warm greetings from the Republic of Seychelles and from His Excellency President Dr. Mental health is no longer a peripheral issue in the health development. It is a human rights issue, it is a social justice issue, and inclusively. The evidence before us is undeniable. Across African region, millions of people continue to live with depression, anxiety, substance use disorder, severe illness, and other mental health conditions. Suicide rates, as spoken about this morning in the presentation, remain among the highest globally, while investment in mental health remains among the lowest. Yet, we know that there can be no health without mental health, and there can be no sustainable development without addressing mental well-being of our population. The challenges before us is not simply to meet this. The challenge is to transform the system.
We must move from fragmented responses to integrated. Okay. We must move from institutional dependency to community-centered. We must move from crisis response to prevention and early intervention. And we must move from policy aspirations to implementation. Ladies and gentlemen, mental health and non-communicable disease are deeply interconnected. Individuals living with diabetes, cardiovascular diseases, cancer, chronic, and other long-term conditions, they experience significantly higher rates of stress, anxiety, and psychological distress. Likewise, untreated mental health conditions can negatively affect treatment adherence, health-seeking behavior, and recovery outcomes in the overall quality of life. The artificial separation between the physical health and mental health will serve neither patient nor health system over the years. Integrated care is therefore not it is unacceptable. When a person enters a health facility, they should not be viewed merely through the lens of diabetes. They should be seen as a whole person with physical, psychological, social, cultural, and economic realities that influence their well-being overall. And the essence of a person-centered care. This is the essence of person-centered care. It is also the essence of universal health policy. Distinguished guests, in Sage Health, we have recently embarked on a significant journey of mental health. We recognize that growing complexity of mental health needs and the necessity of stronger governance. The government established the Mental Health Care Agency under the Office of the President. The agency was created to provide a leadership, coordination, oversight, quality assurance, policy implementation, prevention, research, regulatory functions, and strategic development across the mental health. At the same time, Seychelles established a dedicated agency responsible for rehabilitation and substance use. This dual agency model reflects our belief that mental health outcomes cannot be improved with healthcare services alone. They require coordinated action across prevention, treatment, rehabilitation, social support, education, employment, housing, and community strategy. Our reform agenda is grounded upon three. Third, of course, government responsibility. We recognize that mental health is not solely the responsibility of ministers, it also must involve education system, the labor sector, social protection programs, youth services, law enforcement, local government structures, and civil society organizations for them to have a role in health. Secondly, community-centered care. People should receive support as close as possible to where they live. Workplaces, and we should have strong communities where foundation of strong mental health system like. Thirdly, we believe in a focused growth approach where people living with mental health conditions must not merely be recipients of services. They must be active partners in shaping policy, programs, and solutions. Ladies and gentlemen, as we look towards 2030, I believe there are 5 basic priorities that should guide our collective efforts as South Africa. The first is strengthening leadership governance without effective governance, because even the best policies remain dormant or remain in the shell. Countries must establish clear mechanisms for coordination, implementation, and monitoring, supported and dedicated budget allocation, and measurable outcomes. Secondly, financing. We keep talking about this, but unless we reduce it, finance ways supposedly we will not affect. Mental health cannot continue to be funded as an active. Investment in mental health is not expenditure, it is an investment in therapy. Social cohesion, education attainment, workforce participation, and national well-being. Third, integration. Mental health services should be integrated within the finance NCDs program, maternal and housing, health services, school health programs, workplace well-being initiatives, and emergency preparedness. Integration increases access, reduces stigma and inequality. Fourthly, priority workforce development. Across the region, we face significant shortage of psychologists, psychiatric nurses, social workers, and counselors. We must expand training opportunities, maintain supervision systems, invest in multidisciplinary teams, and enhance task sharing approaches while maintaining quality. Fifth priority is prevention and promotion. This is most necessary because then we are being taking a proactive stance. If we are serious about achieving 2030 targets, we must invest upstream. We must address social determinants. We must promote mental health literacy. We must strengthen family community. We must reduce stigma and discrimination, and we must prioritize perhaps the most important lesson emerging across the movement. No single institution can achieve these goals alone. Government need partners. Partners need communities need people with lived experience, because they have experiences and they know better. The people with lived experiences need the system that listen, respect, and respond. The future mental health in Africa will not be here, isolated suicide. It will be built through collaboration, with shared learning, with innovation, with evidence-informed policy, and through collective commitment. Today, I encourage all of us to move forward beyond the threshold of what is possible, with commitment about what is necessary. The African region is already articulated ambitious targets. It has already articulated our task now is implementation. Our task is delivery. Our task is ensuring that every person, regardless of where they live, can have access to quality, affordable, integrated, and compassionate mental health care. If we succeed, we will not only improve mental health outcomes, we will strengthen families, we will strengthen communities, and strengthen economy. And ultimately, we will strengthen the future of our country. I thank you for your attention. As we engage in discussion, learning opportunities, and engage changes that lie ahead of us, let us seize this opportunity to form shared challenges and shared solutions. Shared aspiration is tangible outcome for the millions of people across Africa whose lives depend upon our collective action. Thank you very much.
We can give her another round of applause. And what is happening in Seychelles is actually quite fascinating. If you do find time to talk to Ms. Knighton, it is a whole new approach of looking at mental health, and really the first country that is doing it in this structure. So I heard so many key nuggets from her keynote address. Mental health is a human rights issue, social justice issue, and it's now an economic issue. I'm sure we're noticing the challenges around substance use, we're noticing the challenges around depression. Depression is linked to presentism. You won't even know that you're struggling, you're being affected economically by mental challenges until many, many years later. She also mentioned that mental health is a key part of sustainable development. We really can't talk about sustainable development without talking about mental health. Yet within the SDGs, the only thing that we measure is suicide rate and also use per capita. So sometimes these are some of the challenges that we are facing. And then this artificial separation of physical and mental health. It's artificial and it's harmful. A person is a person. You don't separate their mind from their body. And we need to treat people as whole. And moving from policy to implementation. So we've done the policies, 29 policies in the region, but the implementation is poor. And the financing of those policies as well. And then the whole of government multi-sectoral approach. Everyone can play a part in improving mental well-being within our communities. And people with lived experience are critical, not only as recipients of care, but part of the development of our services and systems. So we will now move on to a panel discussion. This will, we want to explore barriers to integration because we want to talk about integration and how to do it in a practical fashion within our countries, integrating mental health and NCDs. But there are barriers, there are reasons why it's not happening. Opportunities that lie between mental health and NCDs, but also practical approaches to integration. And we're going to draw from lived experience, we're going to draw from government, ICPPA, and from partners. Welcome Trust will be is joining us online, as well as from perspective of WHO, particularly in a country where there's been intensive investment through the social initiatives in Ghana. So I will introduce our panelists. We've got, I've already introduced Ms. Naiken, then we've got Mr. Jacob Chamiaria. He's a mental health advocate and managing trustee of Kamburi Private Voluntary Organization, a nonprofit that's dedicated to addressing mental health and substance use challenges. He works with government, so his organization actually works with the Ministry of Health in Zimbabwe and partners to support national responses to the drug use challenges and substance use and also awareness building programs and community-based programs. So this is Jacob. And then we've got Emily Miner, who's joining us online. You can all see her. Emily is the head of equity for mental health at the Welcome Trust. And we're very grateful for the support of the Welcome Trust. They've also supported even this side event, but also the meetings in Johannesburg and in Lome and definitely the summit as well. So we're very grateful for that support. And Emily is head of equity, as I've mentioned, at Welcome. And Welcome is a global charitable organization, foundation, dedicated to improving health through science, policy, and partnerships. Her work focuses on ensuring that mental health research and interventions are equitable and impactful across diverse populations. So Emily's joined us online, and thank you very much. And then we've got Dr. Liviana Gnima from the country office in Ghana, the WHO country office. She's the mental health technical officer. She's a psychiatrist as well and a fellow of the Ghana College of Physicians and Surgeons. She has clinical and research experience as well. And her work focuses on strengthening mental health systems and services. She has supported the WHO Special Initiative for Mental Health in Ghana. The special initiative was running across 4 countries globally, and 2 of those countries were actually in the African region. We were the first region to have 2 countries, Ghana and Zimbabwe. So we'll be hearing more about this work. She also works in integration of mental health into TB programs, HIV, maternal health, and NCD care. So I will start with Jacob, just going on the lived experience that you have, and also the work that you're doing with government. What barriers do you see communities facing in accessing integrated care? So where mental health is integrated into other health services, into social services as well, into NCD care, and how can lived experience be meaningfully embedded into these integration stuff? So you've got 8 minutes.
Okay, thank you, Dr. Chido. Good morning, everyone. Good. So I'll start off by sharing a bit more detail into my lived experience because I believe it's relevant and will give a bit more background to the discussion. So I struggled with alcohol addiction between the ages of 15 and 29. I started drinking at 15. I would say the last 3 to 4 years were quite bad, where I lost track of almost all the key milestones in my life. And having realized that my life was inevitably going to end up in jail, hospital, or dead, I had to do something about it. So I've been in recovery for nearly 10 years now. And that journey has opened up my eyes. It opened up my eyes into seeing how big of a public health issue alcohol addiction is and how it contributes to all these other challenges, including NCD. So when I sobered up, I also went to my GP and I asked for them to run several tests. And I've been on hypertension medication ever since. So I believe I've experienced that correlation between alcohol use and NCDs. So in response to your question, based on the experience that we've had and the work that we've been doing as Kamumburi, we work closely with the Ministry of Health and Child Care and other government departments in Zimbabwe. And we're also working closely with the WHO country office and the Special Initiative for Mental Health. So some of the key barriers to integration that we have come across. First of all, mental health services remain separated from primary care and NCD services. Yes, there is great work that has been happening in terms of integrating mental health into other programs. We've seen it with HIV, we've seen it with various other activities that are happening, but we believe a lot more still needs to be done in terms of having a lot more integration with mental health services and other services. Then stigma and discrimination, delay help seeking. That is a common challenge across countries and across different individuals and organizations that we work with. We've seen that stigma continues to affect people in terms of help seeking. So it causes a long delay, and the longer you delay a problem, the more complex it gets to solve. And then I'm sure this is across most African countries where we have mental health workforce shortages. That is a definite barrier. We have a lot of people migrating from Africa to greener pastures to offer their services there. So yes, work is being done around image gap. In Zimbabwe, we are currently working with 4 out of 10 provinces. So there is a huge gap, and there is need for an increase in investment and an increase in the number of personnel that is available to be rolling out the image gap and other interventions that are evidence-based. Then we also look at poverty and social exclusion. I think the discussions yesterday and the previous day spoke highly about limited investment from both the private and public sector around mental health. So when we have limited resources being put into a problem, it is inevitable that we'll have limited outcome. So there is need for an increase in resources. And some of the suggestions that have come up around taxation are some interventions that we strongly support, particularly if we look at the safer package around alcohol addiction. The raising of taxes and raising prices, that will help mobilize more resources that can be put into addressing some of these challenges. So when we've been working in this space for several years, and these are some of the challenges that we have seen. But not only have we seen challenges, we've also seen opportunities that we believe we should be able to tap into. For example, the issue around peer support. We work in communities, we sit down with other people going through similar challenges. When we sit down and lend an ear or lend a hand, when trust is built and that connection comes about, we have seen it as a low-cost intervention that can help people get more involved and more willing to seek help. Community-based intervention around awareness campaigns, around coming up with various interventions that help at community level. We've seen that to work as well. And then reintegration, when people go through various challenges with mental health and they get to a place where they are now better and able to function more, there's still a huge gap in what opportunities exist for them out there. So community reintegration is an area that we believe is an opportunity and needs to be looked at in a more robust way. And then connecting livelihoods with social services as well. We find a lot of people in recovery do need that integration. And then I'm passionate about alcohol. That's where my lived experience is, and I'll keep on hammering. Let's adopt the safer package as countries. Let's keep on working on that. And the issue around prevention and treatment, it should always go hand in hand. And development of national alcohol policies that work. So I would say my key message in terms of how we can achieve the 2030 targets as a continent and many of our countries are lagging behind. But how we can, in our view, let's integrate services, let's integrate prevention, let's have strong alcohol policies, let's have community leadership, particularly working closely with people with lived experience, involving people with lived experience from the onset in the crafting of policies and programs, and providing adequate resources and support for things to happen. That's my take. Thank you very much, Dr. Chido, for this.
Thank you so much. I think he deserves a round of applause. And thank you for just sharing very authentically your lived experience, but also how that has now shaped what the work that you are doing. I think it was very important for us to recognize the uncontrollable nature of alcohol use problems. Many times people talk about safe limits. There is no safe limit for alcohol. It's really a challenge. Alcohol use is it can become so uncontrollable and can take away so much from your life. And then you mentioned the complications, hypertension being what you have faced, but there are over 200 conditions that are linked to alcohol use. 200 health conditions. So it is something that is really an area of work that if we manage to control alcohol use, we should be able to then control a lot of other challenges, many of them being non-communicable in nature. The SAFER package, thank you for highlighting this. This is a WHO package that looks to reduce the harms of alcohol use, looking at, yes, increasing the prices of alcohol through taxation, but also looking around alcohol policies, looking around improving access to care, looking around issues around road safety and blood alcohol limits and uses of alcohol when driving. Alcohol-related road traffic accidents are a major cause of death within our region as well. So thank you for bringing that up as well. Then you mentioned this separation of mental health from primary healthcare and other healthcare services. This is not just theoretical. It's usually physical. In most of our countries, the mental health center is in a physical building that is far away from all of the other services. So already the integration is difficult to do. If someone is then referred, please go and pass by and talk to the counselor in the mental health unit. They have to walk a distance or drive a distance to be able to actually reach the mental health services. So integration starts by location as well. Where are our mental health services in relation to all the other services? You mentioned stigma and discrimination in two parts. You said one is the access to care issue, that if I'm stigmatized, I will not seek out care. But also the reintegration issue. When I'm now better, are people going to receive me back in the community and allow me to contribute to the community, or is the stigma going to be with me for life? And then the need for community-based approaches that are really close to where people live and work. This is where care is supposed to be, and the need to work with people with lived experience, not in a tokenistic manner, but really engaging right from the policy development, but even in the service provision through peer support. So thank you very much, Jacob. We'll move on to Emily. Emily, if you can hear us, again, thank you so much for joining us online. And my question to you, from a donor perspective, what are the key barriers that have limited integration of mental health and other health programs, particularly NCDs? Where do you believe the biggest investment opportunities lie? And how can funding and partnerships better support sustainable and equitable integration? Over to you, Emily.
Brilliant. Thank you very much. Can you hear me okay?
Yes, we can. Please go ahead.
Okay, great. Great. Lovely to be on this panel, and thank you so much for the conversation so far. It's been really edifying. To respond to your question, I think a major barrier, as the video this session started with articulated, is thinking that mental health is an add-on or something that's nice to have. It's important to start any conversation about this area by framing what I think is the core principle that is central to our success, which is not only is access to mental health care essential for a healthy and flourishing population, and as Dr. Naikin articulated, it's an essential human right. But also, we're not going to reach our other global health commitments, including our other global health commitments and NCDs, without integration of mental health and without a consideration of people with pre-existing mental health conditions. I think one barrier to integration and scale is the challenge of bringing together expertise. So both the expertise necessary to understand the local context of an issue and the understanding and receptiveness to the idea that similar principles can be useful across different contexts. And what this takes, in my experience, is to be successful is to bring these two things together is robust investment. So investment of time, investment in true partnerships and trust, and a willingness to make long-term investments in an idea and a principle rather than a discrete piece of work. We see, and I know everyone on this panel and participating sees a lot of brilliant pilots fail to successfully scale because they do not have the local knowledge as part of the program to adapt to the local context. But equally and perhaps more directly relevant to the work that we do, you see a lot of excellent work fail to scale because donors either lose interest or their funding criteria changes, or a piece of work that should be expansive and about integration and about being patient-centered and patient-focused doesn't fit within the rigid criteria of the way in which they think of their funding priorities. This combination can lead to what is often called the graveyard of excellent ideas, and a lack of coordination across our sector that means that the best ideas don't always flourish and thrive. From the perspective of a donor, I think the biggest barrier to integration is that we sometimes are too committed to the constraining measures of impact, which are often quite siloed. This is in a way understandable as it reflects how we talk about our own work and we measure our ability to have success. But we in global health philanthropy talk a lot about the negative impacts of siloed health systems on health outcomes of the populations we served, without always fully acknowledging that these siloed systems are a reflection of funding flows. And I think we have to really rethink and be very open to thinking about different ways to operate to prevent that. So from my perspective, the biggest opportunities and the biggest investment opportunities come from the ability to look past our siloed objectives and make big long-term bets on systems, structures, and partnerships, not just on discrete projects. I think this is reflected in Welcome's new strategy, its new agenda, which seeks to make larger, longer-term big bets on investments, specifically in mental health, but also in climate and infectious disease, and a determination to ensure that those priorities are set by our partners and not in our office on Houston Street. But doing this is tricky. It's much easier to say it than to do it. So long-term systemic change is harder to measure than discrete pieces of programmatic work. And most importantly, it requires, and I think this is the kind of maybe the big takeaway I wanted to articulate, it requires genuine trust in your partnerships. The chance to think, a change in thinking is required to make investments in real meaningful partnerships rather than in discrete programs. An actual partnership is a necessary step to ensuring long-term work with governments and with implementing partners, where we're investing in stakeholders and not just standalone pieces of work, and where we trust the experts on the ground as the people that are best placed to make prioritization decisions. In more concrete terms, I think there are maybe 5 ways in which we can think about sustainability, which is obviously a complex web of factors. But from a donor perspective, here are a couple of sort of reflections on what makes for the best sustainability. I think first, we need to be responding to the expressed needs of communities and governments. Our work should reflect the priorities of communities we serve and the commitments of their governments, and it should never be vice versa. This is something that Welcome is actively working towards, and I think other partners do this to a greater and lesser extent. But I think meetings like this one, as well as the brilliant intercountry workshops that Cheeto referenced earlier in advance of the Global Ministerial Summit that the WHO is hosting, are a really important way of ensuring that we're doing that successfully. Second, we need to co-design not just the programs, but also the parameters by which we fund and ensure that the parameters by which we fund the communities that we wish to serve. This takes a lot more time. It takes consultation. It requires the donors develop expertise in new areas. It requires humility, the need to give up a vision that maybe is sort of, this is my own project or sort of ownership of it, but I think it's critical to start in any conversation with your partnership around an idea point to say, is this what we should be focusing on, or what do you need to succeed is at the core, not just of sustainability, but also of equitable, meaningful partnership. Third, I think we need to fund beyond programs. We need to think about funding beyond programs. So we need to provide funding that supports long-term capacity strengthening above and beyond the discrete needs of a particular program. We need to provide organizational funding, not just programmatic funding, especially to local CSOs, to advocacy groups, to live experienced groups, to ensure that they're able to flourish beyond discrete program support. And we need to create communities of practice, cross-country or organizational learning opportunities where donors, implementers, policymakers, CSOs, people with lived experience have the opportunity to make long-term sustainable relationships across different geographies and with experts in different fields. Fourth, we need to invest in risk. A good question to push any donor on is, what can you do that would enable change that requires a risk that the private sector or governments might not feel that they are able to do? This is the role that philanthropy should play and at its best does play. A good example of this is a series of programs that Welcome is currently supporting for researchers to investigate any secondary health implications of generic medications, so that if successful, the use of those medications can be expanded in an affordable way based on already available medication. And fifth, we as donors need to work in partnership as donors and across donors. I really believe that we should always be looking for opportunities to shift the burden of funding from the recipient to the actual donor. A good way to think of this is by creating ambitious pooled funds where applicants apply to a single fund from multiple donors, where they co-develop that work with those donors and then are funded via the fund to do ambitious long-term work. And the goal of the funding is larger systemic change. And so from the outset, that funding and relationship acknowledges that the partnerships will be long-term, collaborative, and built on trust. Perhaps the final point is that we need to build the kind of partnerships where partners feel empowered to push either individually or collectively for the kinds of investments that they see will really make a difference. The best ideas will not and certainly do not come from inside the buildings of philanthropies. They come from the people in the room, the people doing the work of integration and scaling. We need to actively promote open dialogue and partnership that fosters and facilitates that kind of frank sharing of opinions and views. Thank you very much.
Thank you so much, Emily. I think she deserves a round of applause. And really hearing it from funders that investment in mental health is critical, but also it requires local understanding, and that prioritization is best done by the people on the ground. Having worked with Emily, really, this is how Welcome has been working. Mental health is not nice to have. I think that's what I quote from what you said. It's not a nice to have. It's not an add-on. It is an essential part of a health service. And siloed programming is reflective of siloed funding. And it was great to hear a partner say that, because often this is the pressure. When partners come, they've got priorities, and then we are aligning more with the partner priorities than we are with the government priorities. So thank you to Welcome for actually working in that fashion to say, what are the government priorities? How do we align with them? And how do we not silo programming? We should be funding beyond programs, organizational funding, and not project-based financing, looking at funding of sustainable health systems. So again, thank you so much, Emily, for highlighting these, and also the issue of accessible, affordable medications for mental health, which is critical. So I will now go to Dr. Liviana from Ghana. And like we said, Ghana is a special initiative country. It's one of the countries that has received significant support from the WHO Special Initiative Project. And based on this experience, Dr. Liviana, what are the barriers that you have seen, but also opportunities for integration between mental health and NCD programs, and how can countries learn from the Ghana experience to scale up?
Thank you. Thank you very much, and good morning to everyone. So Ghana joined the Special Initiative for Mental Health in 2022, and we are currently implementing in 6 regions which have relatively weak health system structures. Through this initiative, we have been able to successfully integrate mental health into HIV, and we have supported the grant writing workshops for HIV, TB, and in maternal health, we supported the government and partners to conduct a situational analysis for maternal mental health, following which recommendations we supported the Mental Health Authority to develop a mental health policy, which was recently launched. And again, we have successfully piloted an integration of mental health in maternal care across selected primary health care, which provides evidence for scale up. In emergencies, we've also supported during the COVID and other humanitarian outbreaks in Ghana, supported with training on mental health and social support to support the response in various regions as well as nationally through MERVEC, through yellow fever, etc. And then also in health financing, we supported the government in the processes that has led to the inclusion of 4 main conditions, mental health conditions, under the benefit package of the health insurance scheme that will provide financial risk protection for service users. So prior to this initiative and achieving all these, there were some barriers, mainly health system barriers. We've all heard about inadequate health workforce in mental health. It's not, Ghana is not unique in this. And so there was a need to intensify training of mid-level staff. And also within even the existing staff, there's a lot of workload that makes the integration challenging. We've also mentioned fragmented health programs. NCD stands alone, maternal health stands alone, HIV stands alone. And also within these programs are weak referral pathways between community and primary health care as well as specialized services. Medication stockouts is a big challenge when you have to diagnose somebody and provide the treatment. And if there are no medicines, then it's a big challenge, as well as other non-pharmacological support systems, psychological support, social welfare, etc. And then stigma has been mentioned, which is in mental health a big issue, and I would not belabor the point. Then data and information system gaps. Even though mental health data is collected routinely through the health information system, sometimes it's not prioritized because it's not part of the performance indicators for health system reporting. And we know that weak data limits planning, monitoring, and demonstrating impact. But there has been, regardless, great opportunities that's facilitated the integration process. We have a strong policy foundation. Ghana has a Mental Health Act and policy that provides guidance for prioritizing community care and also for the integration process. And these documents align with the universal health coverage policy. And then we've heard about the pre-primary health care that also even further supports the integration. Ghana has a robust primary health care and community structures from the very lower level, which we call the CHIPS, community-based health planning and services, that is community-based. Then we have the health centers, the polyclinics, which forms the primary health care structure. And these have a network of mental health staff and have a community of practice that ensures communities are supported with health promoted interventions and linked to care where there's a need, and also followed up in the communities as part of their recovery journeys. Then partnerships. So as part of the special initiative during the design stages, we actually had a commitment letter from the Ministry of Health ensuring that there's commitment of government to the initiative. And then we had various stakeholders, the agencies under the Ministry of Health providing service and policy. So we had the Ghana Health Service, Mental Health Authority, and civil society organizations, as well as service user organizations being part of the design process. Through this, we also established a coordinated platform for mental health stakeholders where we have periodic updates and individuals share their work plans, as well as provide updates on what they are supporting, where they are working, where they are strengthening within the health system building blocks. And so through the special initiative, we're able to leverage the WHO's normative function and avoiding duplication and maximizing efforts. And so through this, we had a few lessons to share together from the integration process. Integration must be intentional. There may be policies, there may be commitment, but the process requires intentionality. And this requires dedicated training of the health workforce, leveraging tax sharing, tax shifting to ensure that the health workforce are trained and provided with support and mentoring to be able to undertake this integration. Again, we need to make available the logistics that would be required, psychotropic medication and non-pharmacological intervention that will promote recovery of the persons we are serving. In Ghana, we had a challenge with psychotropic stockouts. And so we had to support the ministry and the mental health authority to fine-tune the procurement processes to reduce the stockout. And again, with the 4 selected mental health conditions, schizophrenia, depression, anxiety, and bipolar, coming under the benefit package of the National Health Insurance, this ensures that medication procurement will follow the routine procurement processes for other conditions that prevent frequent stockouts and ensuring there's availability. Data drives visibility and also provide evidence. So we have trained in our health workforce to strengthen data capture for mental health, and we have supported the mental health authority to reform the data collection tools in the district health management information system. And this, for the special initiative, is established a surveillance structure where we track service coverage and quality care, among others, quarterly from the implementing regions. And this provides us with what we are doing in terms of service coverage. And this data has actually been utilized as a baseline for resource mobilization to further support the process. Communities were not left out, and we need to engage communities first to reduce stigma and also to improve service uptake, and also have engagement. We've had engagement with community service users, community leaders, and faith-based and traditional leaders to help with acceptability and also demand. Lastly, we had to embed mental health into the existing program. In NCD, Ghana conducted its first national STEP survey a few years ago, and we co-opted a mental health component, and so we had data on depression and suicidal behavior, giving us a national prevalence data on depression. And this provides us with critical information, data that we can build on. And also, we've talked about the maternal mental health projects. Importantly, we need to have government ownership for sustainability. And so our frequent engagement with government throughout the process of design implementation makes it easy for government to take up this initiative and routinize it and provide budgetary allocation, as well as routinely operationalize all these interventions as part of the holistic health system strengthening.
Thank you so much, Dr. Liviana. I think we need to give a round of applause to Ghana as a country. They have been one of the top performers with the Special Initiative Project, and we whenever this is the global platforms are held, we're so proud of the work that they've done. And I think you've highlighted the key issues that integration must be intentional. It's not going to happen by accident. It's not going to happen because we wish it to happen. We need to be intentional about it, like you were with the STEP survey. They did include several questions about mental health within the STEP survey, and this has collected very valuable information. Data drives visibility, community engagement. We shouldn't leave our communities behind. And then the coordinating platform, I think this is going to last long after the special initiative funding ends. This is now a framework, as a mechanism that is now embedded within the government structures to make sure that there is coordination, there is clear clarity of roles, who is doing what, where are they doing it, how are they doing it, so that there is coordination amongst our partners. And then the community of practice, I think that's another excellent example of how primary care integration is being done, and everyone is supporting each other in terms of how that is done across the different areas in Ghana. So thank you. So last but not least, we'll come back to Ms. Naiken, just to ask you, in terms of multi-sectoral approach, because you now sit at a level where you can coordinate a multi-sectoral response, how can this multi-sectoral collaboration support an integrated approach to mental health care? And just to ask our IT to line up the Slido as Ms. Naiken answers. Thank you.
Okay, thank you for your question. In terms of, anyway, since the agency just formed in January, we are still at the establishment phase, whereby we are looking at best practices, and we want to get this right, learning from what exists out there to ensure that we get it right from the get-go. So with that said, we do know that definitely we have to, the multi-sectorial collaboration is key. And our aim is actually to get all departments and different ministries on board to align and their policies, and to see where it sort of aligns to the common goal of the country. So we aim actually to meet up with all the ministries and look at what it is that they have existing, and then to ensure that mental health forms part, like the backbone, and if there needs to be realignment of the existing policies, and this would be the activity that we actually will undertake to get all the different ministries to get the policies aligned, even budget, because you can find that maybe if we collaborate, so that we can save on budget, or there can be collaborative where there could be collaborative work. So yeah, so that's the way forward in terms of how we aim to go about it.
Thank you so much. And you've actually brought up something that we need to highlight. WHO did release a guidance document of mental health across government sectors. This was released last year. So please do make use of that. This is going to be a way that guidance actually gives very clear ways to integrate mental health into labor, into education, into social services, into defense and veterans, so across the different sectors, into tourism, into all of the sectors. So this is a key document that we can definitely make use of, and very exciting to see what will be happening in Seychelles. So because we've got limited time, we will ask for your input through a Slido. I hope you guys have used this before. We're going to try and do some technology here. So you can scan that QR code, or you can go to slido.com and type in that code, and then you access our Slido. It's just two questions that we are consulting you on. Two questions that we're consulting you on. So if you can log in so that we can get started, and this is just a quick way for us to collect some information from you about what you think are some of the barriers and challenges, but also what you believe are actions that we can make to accelerate progress in terms of integrating NCDs and mental health. Are we in? Has everyone managed to scan or to go to slido.com and put in the code? Okay, just show of hands if you're in so that we can switch to the live. Not enough people yet. Great, great. Because your opinions are very important to us. Great, thank you. And as we said, this is part of our consultations as we are preparing for the Global Ministerial Summit. Okay, are we in? It looks like most of us are in. We can switch to the live now, so we can start to see some answers. Okay, so the first question is, what are the key barriers to effective mental health NCD integration? Looks like stigma is winning there. It means that stigma is a big part of the problem. So stigmatization of the conditions, stigmatization sometimes of the profession as well. Yeah, when I decided to become a psychiatrist, even my family was like, are you sure? Yeah, so there's stigmatization of the profession as well. Human resources is coming up, poor political will and commitment. We're starting to see their workload issues, improving perception of mental health as an NCD. That's interesting. Separation of programs, that's true. Inadequate workforce, community awareness. Thank you so much. These are all valuable responses to us. Siloed mentality, true. Lack of prioritization. Adolescents, teenagers, yes. Socio-cultural barriers, that's also true. That's also true. And yes, we see a limited scope, shortage of medications. This is really great. People are still typing. Please type, please type. We want to collect all of this. And stigma is still winning. Can you see? This is the biggest one. All right, then the next one. Please go to the next one. The next question. Right, so what priority actions would you like to see in terms of accelerating mental health and NCD integration? I guess addressing competing interests, I think that's something that needs to be done. Money, yeah, I suppose that is true. That's a major issue that needs to improve. Mental health screening as routine, yes. Development of clear guidance documents, improving access to medication, more human resources, and that keeps coming. Policies coming up as well, incorporating routine screening, addressing mental health issues in medical workers. I'm missing some, but I will read all of them, believe you me. We need convergence, yes. Financing is coming up. Mental health of first aiders, true. Adolescent screening, tackling stigma. So just to say, this Slido is going to be open for the next 24 hours. So if you do want to continue giving us input, please do. And if you want to share it with people who you think should be giving us input, please do as well. So it will be open until the end of the day tomorrow. So please continue giving us input. So I will now close this session. I think we need to move on. Thank you very much. I think we had a decent output from this session. And thank you very much all for joining. I'm very grateful to our panelists. Ms. Naikin, we're very grateful for your support and for sharing with us what is happening in Seychelles. Jacob, we cannot thank you enough for coming and really sharing your personal journey. We appreciate that and that honesty and authenticity, which we all need to emulate in our lives. And thank you, Dr. Liviana from the country office in Ghana. And thank you for our funder, Welcome Trust, and for Emily for joining us online. So we will be moving on to poster presentations outside in the lobby. And presenters, you need to stand by your poster so that people can interact with you, to those who've got poster presentations. And we can move on to the next session. Thank you very much.
Hello, everyone. Please, there's tea, coffee set up on the first floor. So if you haven't gone there yet, you can go upstairs, first floor, and help yourself. Thank you.
Hello, everyone. It's not even going, eh? Hello, everyone. Please move to the hall. We're about to begin the next session, please. Can we move to the hall, the plenary room? Hello, hello. We are waiting for you in the plenary room. So, can we move to the plenary room? We are about to start. We are about to start. Poster exhibition. They can't hear me outside. It's about to start, so everyone move. Please, please, everyone, we are about to start the next session. Joanna said they will have to start the next session.
Hello again. Please, can we settle down? We want to start the next session, please. So our next session is session 6, patient-centered care for NCDs. And it's going to be a panel discussion. And to moderate this session, we have Dr. Vivian Nabita, who is the founder and executive director of the Sonia Nabita Foundation. She's dedicated to improving the lives of children with type 1 diabetes in sub-Saharan Africa. She is an environmental engineer turned global health expert, and Vivian brings a unique interdisciplinary perspective to her work, combining technical expertise with a passion for health equity to drive innovative solutions in global health and sustainable development. In establishing the foundation, Vivian leveraged over a decade experience at the United Nations Development Program, where long career they expanded beyond environmental issues to encompass energy, climate change, and South-South cooperation. Her diverse professional background also includes roles at the International Finance Corporation and as a project engineer at Rizzo Associates in Connecticut. Vivian holds an MBA in Finance and Strategic Management from the Wharton School, University of Pennsylvania, and a BSc and MSc in Environmental Engineering from the University of Windsor in Canada. Distinguished participants, kindly help me welcome Dr. Vivian Nabita.
Well, good morning. Is it still morning? I'm not sure. It's a little bit delayed on this. So good morning, and thank you for that kind introduction, Joanna. So thank you, everyone. First of all, thank you, WHO Afro and the Poverty Network for this introduction, for this invitation to this event. I mean, it's been 2 days of distinguished panels. Excited about this one because the conversation is one that I care very, very deeply about. And oh, there we go. That's better. Okay, and a model of care that I believe in. At the Sonia Nabeta Foundation, SNF, we have long held that community-anchored model of care, patient-led, patient-powered care, really. I think I'm going to convince you that this session should be patient-powered care, not patient-centered care, but patient-powered care where warriors, we call them warriors at SNF, are central and core to the health system. If we want to have a chance at good health outcomes, I really posit to you that patients have to power the system. And to me, this belief, 10 plus, is really that belief at scale. You know, and a movement, I'm not sure where Gene is right now because he calls it the 10 plus movement. And I really am behind that train because a movement of change agents is harder to ignore than any single disease community alone. So this panel, this patient-powered panel, the 4 people joining me on the stage in just a little bit, their careers prove exactly that. I think you're going to hear first from Dr. Symphorien Kambou, who will challenge us to think beyond survival, to functioning, participation, quality of life as the true measures of whether the health system is working. You will then hear from Dr. Catherine Karekezi, who I'm hoping is going to be walking down in a minute, Dr. Catherine, who will take us from community all the way to the National Operational Plan in Kenya and how patient warriors powered that effort. Then Dr. Yolanda Marcelino, who should be walking down in a little bit as well, will show us what peer support looks like on the ground in her wonderful country of Mozambique and what happens when patients start to lead. And finally, Lucy John Bosco Kifaru, who's sitting right there with her beautiful daughter, will bring us back to what it all feels like, it looks like when you are the one living with that condition every single day and have to engage and interact with the health system with the condition. So I'm thrilled to be part of this panel, my friends, a panel of deeply respected leaders, frontline implementers, advocates. So I think let's get into it. Let's not waste too much time. I think I'm eating into Dr. Sanforia Kambu. Dr. Sanforia Kambu is a physical and rehabilitation medicine physician from Afro. He is currently a PhD candidate at the University of Luigi Vanvitelli in Naples, researching disability and rehabilitation in public policy. He is here today to make the case that keeping people alive is not enough, and I couldn't agree more. And that functioning, participation, quality of life must become the new measure of whether health systems are working. Dr. Sampoyan, the floor is yours, and you have 10 minutes. You need a big clock somewhere, but I'll
Okay, thank you very much, Madam Chair. Hello, everyone. Good morning, everyone. It's a real honor for me to be here, standing in front of you to discuss about rehabilitation, because it's a really important topic when we manage NCDs. So I am truly honored today to represent the World Rehabilitation Alliance and also the International Society of Physical and Rehabilitation Medicine. So one quick word about the World Rehabilitation Alliance. The WRA is a WHO hosted network of stakeholders with a mission to promote rehabilitation as an essential health service that is integral to universal health coverage. And the WRA support the implementation of the Rehabilitation 2030 initiative, which has been launched by WHO a few years ago. So next slide, please. Next slide. Okay. Just first take a look at what is people-centered care. So according to WHO, people-centered care is an approach that adopts individuals, carers, families, and communities' perspectives as participants in, beneficiary of, and trusted health system. So for WHO, people-centered care involve health systems which are organized around the comprehensive need of people rather than only individual disease, respecting social preferences. So the key word here is the comprehensive need of the people. So addressing the comprehensive need of the people. So for us, functioning and participation, not only survival alone, are what people-centered care is organized to protect. Next slide, please. Since the beginning of this event, we are much aware about the burden of NCD in the Afro region. So I will just emphasize on the fact that by 2030, NCD is set to surpass communicable, maternal, neonatal, and nutritional causes combined. So in the region, as it has been shown before, there are many diseases who are leading the NCDs in the region: cardiovascular disease, diabetes, cancer, chronic respiratory disease. So what's important here is to notice that each of these conditions brings limitation in functioning and changes in quality of life, not only course, the risk of death, but also limitation in functioning, which is something that's really important to take in consideration when you want to manage NCDs, and especially severe NCDs. Next slide, please. The functioning burden of NCD is large, and it's very important to notice that by 2030, this functioning burden of NCD is projected to be almost 3 times that of communicable disease. But unfortunately, functioning is rarely planned for, finance, measure in routine NCD delivery. So this is a real issue that we would like to address. We should consider integrating functioning and participation issues in the management of patients with NCDs. Next slide, please. So what is rehabilitation? Rehabilitation is an essential health service that helps people optimize functioning and participation when they experience a health condition across the life course and the whole continuum of care. So when we are talking about functioning, we are talking about the biological health of the person, but also we are talking about the lived experience of a person who has a health condition in the interaction of this person with his environment. So when we are talking about rehabilitation, we are talking about communicating, walking, we are talking about relationship, we are talking about managing stress, moving around, and so on. This is part of functioning and participation. Next slide, please. Let's look now at the need for rehabilitation in the Afro region. From 1980, 1990 to 2021, we observe an increase of the yearly with disability in the Afro region up to 153%, which is very huge. And this burden is due most to NCDs. So you can have the correlation about the burden, the increase of the prevalence of NCD in the region, and the burden which is due to these NCDs on the functioning of the person. So that this is why it is really important to consider the functioning of the person and the rehabilitation need of the person when we are managing NCD. So this is very important to consider and to keep in mind. Okay, next slide, please. Rehabilitation interventions are diverse. So we can range to functional assessment, for example, swallow, or get assessment, for example, and we have different techniques that we can use, exercises, training, and other physical modalities that we can also use. And also we have some specific medicine that we can use to manage conditions like spasticity or pain, for example. And it's also important to notice that we could, through rehabilitation, involve or have an impact on the self-management of the patient, especially, for example, simple positioning. It's also part of rehabilitation to prevent certain conditions, and also we can train caregiver. And one another point which is important is the provision of assistive products, especially wheelchairs, orthosis, prosthesis, for example, for the patient in need. Next slide, please. So what is important now is to notice that early rehabilitation is key to improve, is key to get better outcome for the patient. So that with early rehabilitation, we could improve or prevent secondary complications of different conditions. But also, we should integrate rehabilitation since the beginning of the management of the person, not only at the end of the management, so that we should think about integrating rehabilitation in guidelines, protocols, and so on, going from the beginning of the management of the person. Next slide, please. So rehabilitation and non-communicable disease. So rehabilitation could be involved in the management of a lot of conditions, cardiovascular disease, cancer, diabetes, and so on. And what is important to notice here is that rehabilitation could help to manage symptoms, reduce complications, and also restore or maintain mobility, improve the patient's daily functioning, or improve the quality of life of the patient. So that rehabilitation could also support the return to work, education, and education of the person, involvement in social life, and many others benefits. Next slide, please. So if we take a quick look at the rehabilitation across NCDs, we can have rehabilitation involved in all the type of NCDs. You can have rehabilitation in diabetes type 1. For example, if you have a patient with or someone of a person with sickle cell disease, maybe a child or young man with sickle cell disease who has a stroke, for example, because you have many cases like this. You have a child of 5 years with sickle cell disease who has a stroke. How you will give the patient or the person hydroxyurea, but you couldn't have with hydroxyurea move the patient or use the person or improve the function of the person. So it's really important to consider that rehabilitation is the key component to improve this. Okay, next slide, please. So rehabilitation, there are a lot of evidence of the use of rehabilitation in a different type, cardiac rehabilitation, pulmonary rehabilitation. There's a lot of evidence for this. I will not too much emphasize on this. Next slide, please. So integrating rehabilitation in NCDs is possible, which, for example, functional training, functional assessment, health worker training. We can train nurses, people who are not rehabilitation professionals. We can train them to have basic skills of to identify rehabilitation needs and to provide basic rehabilitation services to the patient in need. We can also put in place referral pathway and also provide appropriate assistive technology for the person in need. So that's very important. Next slide, please. So the key tool to help us to do it is the basic package for intervention of rehabilitation, which is a really important tool which have been proposed by WHO and which target strengthening rehabilitation at primary care level. And strengthening rehabilitation at primary care level is also a goal of the Regional Committee for WHO Afro, because there's a strategy which has been adopted last year according strengthening rehabilitation in health system, and strengthening rehabilitation in primary care is one of the important goals which have been proposed in this strategy adopted last year by the Ministry of Health of the Afro region. So that's very important. Next slide, please. So just to conclude, I think I mentioned that rehabilitation could be involved in many of the NCDs condition, going through the assessment, the delivery of care, and also the monitoring of the care which have been proposed through the basic package of intervention of rehabilitation, which is a very key tool, which is possible, which is that we could implement concretely through the PEN and the PEN Plus in the African region for all the different type of conditions which have been selected. Okay, next slide, please. So, next slide. My final slide. My take-home message is all of us, let's together move from survival to functioning for our NCDs patient. So rehabilitation is important. It's an important component. Rehabilitation completes people-centered care for severe NCD and should be integrated in the WHO operation in PEN and PEN Plus strategy. Thank you for your kind attention. Merci. Obrigado. Thank you.
Thank you, Dr. Sanforian, for such an insightful presentation. And I want you to ponder, I think the most exciting thing about these panels is that they, the questions that come from it. So I want you to ponder this question that will come back to you in the Q&A, Dr. Sanforian. The biggest thing that I took away was the data. You mentioned that, functioning burden on NCDs is going to be 3 times that of communicable diseases by 2030. We're here with a lot of countries ready to implement their national operational plan. What would it take for countries that are on this runway to implementation or even to develop to begin measuring functioning with the same seriousness they measure mortality and clinical indicators? So sit on that. Now, Dr. Sanforian has just shown us what the goal line looks like, and that is a full life. Now, but who gets to define that, what that life looks like? And I would argue it is the people living it. And nobody has done that more to put the argument into national policy than our next speaker, Dr. Catherine. Dr. Catherine Karekezi is a pharmacist by training with a PhD in medicinal chemistry, and she's the executive director of NCD Alliance Kenya. She's the founder, director of the Kenya Diabetes Management Information Center, and contributes to NCD prevention, health system strengthening, advocacy, and policy development across the region. She has brought patient voices into national policy and helped shape Kenya's 10 plus national operational plan by again putting patients front and center of that process. And she's about to tell us how exactly she did that. 10 minutes and a hand of applause for her as we join her to share a Kenyan
Good morning, everyone. Firstly, I'd like to thank WHO for this invitation and also thank you for joining us for this presentation. Can I have the next slide, please? This is just an outline of my presentation, so I'll just give you a brief about the burden of NCDs in Kenya, and then I'll focus mainly on the advocacy and implementation structure that NCD Alliance Kenya uses, both at the community and at the national level, and then some policy and health financing wins, lessons learned, and conclusion. Next slide, please. So basically in Kenya, NCDs account for 43% of the deaths and more than 50% of hospital admissions are due to non-communicable diseases. The slide just shows you the kind of burden we have in terms of childhood diseases. We have more than 5,000 children living with type 1 diabetes who are on different programs, and basically the majority of whom are diagnosed while they have ketoacidosis. In terms of sickle cell disease, about 14,000 newborns every year with about 50 to 90% mortality. I can move to the next slide, please. This is just the advocacy structure that we have adopted at NCD Alliance. We have a membership of more than 60 members, and this includes organizations led by individuals with lived experience of different non-communicable diseases, professional associations, as well as local and international NGOs. In addition to this, we have set up what we call county chapters. In Kenya, health is a devolved function. We have 47 counties. At the moment, we are active in 22, and in these 22 counties, we have established what we call county chapters. These are mainly composed of youth members or women and other community members who are interested in NCDs, either have a lived experience, either themselves or their caregivers or family members living with NCDs. And these are the ones that we have been working with to create awareness about NCDs in the counties and in their communities, and also to advocate for NCD prevention and control in their counties. We also have a national caucus, which kind of reflects the county chapters, and this operates at the national level. And then we also are part of different global and regional networks, and this also gives us a global spectrum. We do have a media network, and we have been working with media, which also helps to amplify the advocacy issues that are important for the people living with NCDs. And these are basically media personalities who have been trained on different non-communicable diseases and different issues affecting people living with NCDs. And lastly, we are part of the NCD Interagency Coordinating Committee, which has been established by the Ministry of Health. And this is an agency which is tasked with implementing the NCD strategy, but also tasked with bringing on board the non-health sector for them to understand their role in NCD prevention and control so that we can have a whole of government approach. Next slide, please. So basically, in terms of empowering local county chapters, as I said, these are the ones who are working at the community level. So we build advocacy from the ground by establishing these chapters and basically capacity building them on advocacy, social accountability, the public finance management cycle, and therefore they are able to interact with the duty bearers at the county level to really advocate for the needs that they have in their communities, for example, in terms of supply chains and so on, and also resource allocation for NCDs. Next slide, please. And this is just a case study from an advocate in Isiolo. We have 3 clinics established in Kenya two in Isiolo County, which is in the northern part of, actually in the central part of Kenya, but it's a semi-arid region. And then where we have two clinics, and then we have one clinic which has been established in Vihiga, which is on the western side, and it's in an agricultural sector. So basically, some of the advocacy asks that they have been identified: access, the issue of the distances that persons with NCDs and their families have to travel to access treatment and care. So it's really, the ask is in terms of access to establish comprehensive NCD clinics, which are at the community level and closer to the community. The other major ask is equity, ending drug stockouts at the primary care level. It's also important for us to be aware that some of these county chapter advocates have actually now been nominated and are working as voices of Pen Plus, basically involved in Pen Plus global advocacy. Next slide, please. In terms of national advocacy strategy, what is strategic impact? The advocates have been advocating to the Social Health Authority, which is now looking after social health insurance. They have participated in tariff reviews to enhance the packages for NCDs. They're also involved in policy co-creation, for example, in the NCD strategic plan and also the national operational plan for Pen Plus, which is now looking to scale up Pen Plus into 20 counties to improve access. And they're also involved in legislative consultation with the Kenya National Assembly, the Council of Governors, and the National Treasury. That is just a commitment to the goal, protecting patients from financial hardship. This is from the Social Health Authority through enhanced oncology and chronic care packages from Kenya shillings 550,000 to 800,000. So this is some of the advocacy wins that these advocates have been able to advocate for. Next slide, please. In terms of the national level advocacy, and this is the Kenya National Operational Plan for Pen Plus. This is a costed policy document which was developed by including individuals living with different NCDs and is striving to really have care to be decentralized to district hospitals. As I've mentioned, targeting 20 counties by the year 2030. And the document includes essential packages of the care to maintain quality of care. I think you heard yesterday, we are now expanding into the first county this year. Next slide. Other policy and health financing wins. We have advocates have also been involved in alcohol control. Basically, the Kenya National Alcohol Policy was launched last year, where the legal age was raised to 21, with strict advertising restrictions and alcohol-free zones. In addition, they've also been involved in food policy, for example, in the Kenya Nutrient Profile Model, which was launched in this year, and then other budget gains, and also I've mentioned the issue of the increased tariffs for the Social Health Authority. Next slide. These are just some additional advocacy milestones. For example, the proposed increase in excise duty on beer in this year's public budget statements, and other campaigns that the lived advocates have been involved in. Of course, stronger lived experience involvement nationally is having a major impact on policy development and other wins. Next slide. Some of the lessons learned from the impact of people with lived experience. Lived experience is powerful advocacy. The county chapters for local ownership and also to drive sustainability because they're advocating to the duty bearers in the counties. Flexibility in advocacy is key, especially in response to geopolitical events. Multidisciplinary stakeholders are also key. And then engaging the Ministry of Health and county health departments is key. And lastly, partnerships drive transformation. Next slide. In conclusion, advocacy for equitable access of care of 10+ condition depends on the voices of persons with lived experience, structured and deliberate advocacy. And lastly, in acknowledgement, the last slide, when lived experience leads, change follows. I'd just like to acknowledge the lived experience advocates, the Ministry of Health, and the different county chapters, the local and national media, journalists, as well as Isiolo and Vihiga counties who are implementing 10+. And last but not least, to the NCDI Poverty Network. And I thank you for your attention. Thank you.
Thank you, Dr. Catherine, for such a powerful presentation. A very, one to really think about. And again, as you sit down, I'll do the same for you. I have a question that we should engage the audience on with after the panelists speak. Kenya is one of a handful of countries leading the Pen Plus movement. You've launched your national operational plan. You join an elite group, but of course, there's a lot of countries that are on this runway developing their plan. So what advice would you give these countries, to put the lived experience into the conversation beyond consultation, and really the way you've done it in Kenya, that genuine partnership in implementation? I'll come back to you on that after our panelists. So, Dr. Catherine has just shown us what happens when patient voices reach the highest levels of policy. But policy only matters if it reaches the people. And that last mile, basically between policy, but the plan and the patient, is exactly where our next speaker, Dr. Yolanda Marcelino, works every single day. Dr. Yolanda Marcelino is a specialist in family and community medicine and the clinical mentor of the Pen Plus program in Mozambique. She has led family medicine training, directed residency programs, and is currently a PhD candidate at Utrecht University researching child-centered rheumatic heart disease in rural Mozambique. What makes her particularly compelling for this conversation is that she has built a peer support model that does not just retain patients, it moves them, transforms them into leaders within it. How exciting is that? Please, let's give a warm welcome to Dr. Yolanda.
Good afternoon, everyone, and thank you for the opportunity to share this lovely experience for peer support mechanism for Mozambique. So I'm here to talk about the peer support mechanism and how it retains patients in our Pen Plus clinic in Nyamatanda that we started implementing in 2023. So next slide. Actually, I'll do a little overview and then action that we are doing in Nyamatanda, how we support patients, and the planning that we have that for the camping, and what are the camping benefits, and then the conclusion. Next slide. Firstly, say that integrated Pen Plus camps are transformative spaces for chronic care, spaces that allow young people with type 1 diabetes, sickle cell anemia, cardiac condition as rheumatic heart disease and congenital heart disease to learn, connect, and heal together. Camps go beyond clinical care, creating peer support ecosystems that build resilience, trust, and empowerment. And we have the experience in the regional area. Mozambique is now preparing our first camp, but we learned a lot with Zambia and Zimbabwe experience last year that we have the opportunity of part of the team to join these camps, and we are bringing this all experience to our first camp. Next slide. Next slide. So we did a lot of actions before, while we were preparing this first camp, and one of the most important activity are the home visits that we do by the community health worker, and supported when it's needed by the health providers of our staff from Pen Plus Clinic in Yamatanda. And what they do is they do educational health education, adherence check, mainly for patients with type 1 diabetes. When we go to their homes, we found that they are not conserving properly the insulin. They still have problems to inject themselves. So we use these community home visits also to teach them to engage the family in their treatment and care, and also find with them what are the challenges that they have at home. Next slide. We also have group visits to the clinic for the three types, mainly for the three types of the three conditions, where the parents have the opportunity to share experience, peer modeling, seeing other managing the similar problems. Also helps to build confidence with them, collective problem solving, and cultural relevance, because this section can be tolerated by local language with their beliefs, with their practice, and it's beneficial from them. So each of these conditions, we group them a week. So we have a week for type 1, sickle cell, and for cardiac condition. And we group them into various groups according to their age that we are going to see after. Next slide. So we have now 15 peers groups, 5 for each condition. They meet monthly, except for the cardiac one that they meet once in 3 months. And then these peer groups are leading by the patients and the caregivers for those patients who are still very young, and has the duration for 30 to 45 minutes before they see the clinician at the clinic visit day. Next slide. So we have a range according to each condition for type 1, sickle cell, and cardiac with rheumatic heart disease and congenital. So each day we have a specific group, but we group them by age. So the youngest children, they are the first on the first days of the week, with their caregivers, and then on the following days we have older patients that join the peer groups. And we now in Yamatanda we have 56% of the patients that live in the village, and then 44 outside the village. Next slide. And in this peer group, they discuss a lot of topics relating to their conditions. Some are specific for each condition, but some are common, like nutrition, stigma, mainly for sickle cell anemia, that it's a disease that it's people don't know in rural areas like Nyamatanda, mental health also, family support, treatment, prevention, and also the daily challenge that they're facing. Next slide. Here is experience that I'm proud to share with you. Is a peer group for children and caregivers for sickle cell anemia. Firstly, it was the first peer group formed in this clinic, and their first meeting was at the hospital, and then during the year they decided to do their meeting at the community. So they choose a place at the community to do their meetings. It's now where they are doing the meetings. And these mothers has the idea, they have the idea to create an association that they want to call We Deserve Life. And through this initiative, they also were offered a cutting and sewing course for them. And then at the end of the course, they receive a machine for them to do their work. And now in June, we will have the first graduate of these mothers. And their plan with the association is to create a kindergarten, community kindergarten for the community also. So it's I am very proud of them because of that, and we are organizing to help them to create the association. Next slide. And what we are planning for the camp, we didn't want to do a camp with many children, so we decided to do a camp with 25 patients, 8 for each condition, and each of them with their caregivers, because although we learned from the experience for Zambia and Zimbabwe that only young children went with their caregivers, but we also think that adolescents mainly, they need their caregivers and this family support, so we also are inviting them to the camp. And we will have recreational activities, educational activities, and cycle of therapy. We will have a multidisciplinary team also with the cardiologist, pediatrician, family doctor, nurses, and other people to support. Next slide. And we will have many recreational activities, as you see, but we also asked the children what are the local games that they wanted to have in the camp. So they mentioned this local game that we have in Mozambique, Neka, Pinga Pinga, and game of 12. Some of them I don't know. I only know Neka, but you lend me them. And you also have a therapy circle. Next slide. So we have a lot of educational therapy regarding to treatment, sexual and reproductive health, genetic counsel, and you also have section especially for the caregiver at the campus. Next slide. What we want to bring with this camp, it's new. We did photo voices. We implemented photo voice with adult patients with hypertension and diabetes last 2 years ago. But now, because we are going to have drawing and painting, we are going to use this drawing and painting to do a drawing voice for them to express through the drawings, through the paintings, their trajectories, their feelings about their condition, and it will be integrated. So in the first day, we'll do the drawing, and then on the second day, we'll have focus groups to discuss the drawing, and at the last day, we will end with the exhibition and reflection about these paintings that they are going to do. Next slide. As the other camps, we also have medical monitoring, especially for type 1 diabetes, and also medical staff 24 hours per day, and medical emergency station at the camp. We are going to the venue of the camp. We have only 1 minute from the camp to the hospital, that is a rural hospital of Nyamatanda. Next slide. This is the venue. We will be at Instituto Ciências de Saúde de Nyamatanda, and these are the many parts of the venue. Next slide. And what we want to have finally after the camp is empowerment, improving their self-management, improve the patient-centered care, and the retention of care. Next slide. And in conclusion, I'm going to say that peer support is not necessary to care, it's a pillar to retention. When patient and the caregiver share experience, they learn together and support one another to transform treatment into a shared journey. And finally saying that peer support keeps the flame alive, ensuring that every hero of Mozambique continues to thrive behind the camp. Thank you.
Thank you, Dr. Yolanda. That was extremely exciting for me personally, because I love these gatherings of warriors. I'm glad to be a partner of you on that. So, Dr. Yolanda, as you take your seat, I'll also give you a question to think about. You know, how has this peer support model you described shaped or influenced Mozambique's broader Pen Plus rollout? I think I'll come back to you on that. Okay, so Dr. Yolanda has shown us what retention and this peer support looks like from the outside. The model, the data, the exciting associations that have formed, and so on. But Lucy John Bosco Kifaru, our next speaker, is about to show us what it looks like from the inside. Lucy John Bosco Kifaru is a passionate diabetes advocate, journalist, radio presenter, and community health educator based right here in Tanzania. She has lived with type 1 diabetes for over 3 decades. She writes for Mwana, a non-cheap newspaper, hosts the radio segment Sugar Na Lucy, and leads a community initiative using visual art to reduce stigma and improve diabetes awareness in rural communities. She is a voice of Pen Plus. She's also trained as a warrior educator with the one and only Sonia Nevada Foundation. So you know that's important to me, which makes her presence on this panel particularly meaningful to me personally. Lucy, you have engaged and interacted with the health system for over 30 years. No perspective is more important than yours. So please, a hand of applause for Lucy.
Thank you so much. I'm so happy to be here. I don't know if it's still morning. It's noon. Good, good afternoon, everyone. Greetings. Assalamu alaikum. Shalom. As she said, I'm Lucy John Bosco, a journalist, but an qualified diabetes educator. Thanks to Sonia Nabeta, I'm a founder of Diabetes Consciousness for Community, and I'm a member of Pen Plus Tanzania. But I'm also a mother, and this is so important for everyone to know, just to kill the myth of having diabetes, you can't be a mother. And that's my sister yesterday. I forget to say that she's also a mother. So we always use that to kill that myth that once you have diabetes or sickle cell, you can't be a mother. Today I'm here to share my lesson from my living experience, the reality of navigating health system and people living with NCD in order to have a healthy lifestyle. Living diabetes, I've been living with diabetes more than 20 years, and I also have asthma since birth. But I came to realize that having diabetes and asthma is something that it's a journey that it will never stop. It's a living journey. So it's something that it's in me, and I did learn how to educate myself to know to give myself enough, not even enough, but right education, knowledge on how to live with these conditions. That's to say, knowledge is power. As we continue reading, but not reading, navigating, not only that, but also discovering ourselves, how we're going to live, because every day is different. Today can be tomorrow, and tomorrow can be like yesterday. We always experiencing new challenges. So for me, it's always a case study of my own life. And also self-awareness in order, even before the self-management. And I always say this when I teach other warriors. We know about diabetes, but we don't know how to live with diabetes. Those are two different things. We have to know how to live with diabetes. How my diabetes react or behave is different from another type 1 warrior. So we have to accept it. Before even knowing how to live with it, we have to accept it. And here, if there is anyone living with type 1 warrior at home, you have to know that diabetes is a part of life. And it won't, or that is not something that can be described ourselves. We're not supposed to use it's like I'm diabetes as something that can describe us or explain us. Next slide, please. Here we'll talk about self-stigma. We always talk about diabetes stigma, but for me, I always specific talking about the self-stigma. We always have that self-stigma within ourselves. We always questioning ourselves. I'm diabetic. Will I be able to be this? I'm diabetic. Will I able to do this? I've been like studying in Uganda from S1 to university with diabetes. That shows that I can be more than that. Fine, diabetes is part of me, but we need to stop questioning ourselves. But also, um, having a right education, information, reduce that fear and misconceptions. We know Africans, we have a lot of myth. So if we have right education, right information on how to live with diabetes, can reduce that fear and can like take away the self stigma that we always give ourselves. But also, patient learn best from sharing experience. I remember when I started Pen Plus, visiting the clinic, Kondoa and Karatu, the first thing was like, I wanted them to stand introducing themselves, sharing their lifestyle, living diabetes. I wanted that because for me, sharing experience can take us from one point to another and it brings that belonging. Oh, so we are belonging together. But also, most of youth do experience the self stigma. At the youth living with diabetes is not easy. So here especially I want to talk to the doctors. Even if we come like to our clinic visit, you find our sugar is high, don't start judging us. We are going through a lot. And as youth, I'm telling you, we are going through a lot. We sometimes feel ashamed. We don't like people to seeing like injecting ourselves. So please don't judge us. Just talk to us nicely so that we can open up to you. Peer support. This is a very important aspect. As my sister said that I think peer support can help us take us from one place to another. Can help us discovering us more. Discovering, not only discovering, can help us to know ourselves more. So that's also is an important aspect. Next slide, please. Now, with my own experience, when I was young, um, I remember today I still going on the program whereby you receive free insulin, medical, as in diabetes supply for free. But when you reach a certain age, you transfer. Now that's bring up the challenge. I think we need first to be educated that hey, now you are in this program, you are giving this for free, but when you reach a certain point, certain age, you have to now depend on your own self. You have to have health insurance, or if not, you just have to find a way so that you can get this medication. But that's also it's a struggle to many youth. Not every youth can provide for themselves diabetes supply and insulin, and also family. Thanks to Pen Plus, I'm seeing it that they do provide diabetes supply in Kondoa and Karatu, and that's real help to overcome these challenges, because most of people sometimes to tend to not able to access medication and diabetes supply because of now they're out of that program. They don't know where to start right now. Next slide, please. Affordable medication and supply, accurate information, counseling, and emotional parts, but respectful and patient-centered care. This is very, very important. I did talk about the medicine and supply, but accurate information. Here in Tanzania, we tend to have a lot of doctors. We tend to have a lot of nutrition in the social media that believe once you are diabetic, you can't eat this, you can't eat that, you can't eat a lot of things. But they forget that sometimes it's not about what you eat, it's about how you eat what you eat. And I think if we have any Tanzania nutrition here, I think this is a very important aspect, because you advise us maybe to eat, not to eat sweet potatoes. But where I'm from, we have sweet potatoes. You need to educate me. How am I going to eat that sweet potato without even raise up my sugar? So if there is any nutrition aspect here, that's something that you need to figure out, because misinformation is really drive us crazy. But counseling, it's also something that we really need. We need counseling, because diabetes will mess up our mental health. As I said, it's very a lot to live with diabetes, but also respective care. That is also something that important. I've said that we need you need to listen to me, not to judge me, to respect what I'm telling you, so that you can come up with a very useful solution of what I'm going through. Next slide. I'm finishing. I think that is a last my last slide, but it's all about the peer support, patient-centered care, but also the importance of Pen Plus, how the Pen Plus really bring about the changes in youth's life, especially in Kondoa and Karatu. The peer support is very important, and I believe good NCD care combine clinical service, and education, counseling, and peer support can bring about very free, but not even free, I think comfortable environment to us who are living with diabetes. Now, my closing message, please. Next slide. good good NCD care is not about medication. Sometimes it's about knowledge, support, dignity, and partnership. When I say partnership, you need to use us, in every kind of aspect, in policy making, decision making, because by the end of the day, we know what we need. We know what we need, and we can bring about very maybe useful arguments when you're making these policies. And last, I want to thank me for allowing myself to use my life as a center of a case study, to use myself as a research. I want to say to thank God that was supposed to be the first one, who making sure that I'm living this life, giving me the strength to live this life. I'd like to thank Nabeta for trusting me. Before Pen Plus, you are the one who like using me in Tanzania to gather some information. So I really do appreciate it, and the training you gave me, it's very impact. I'm using it with my local community. So thank you so much. I want to thank you, my daughter. My daughter, she's there. She's not diabetic, but most of people like will ask me, you are diabetic. Is your daughter also diabetic? No, she not having diabetes, but she knows a lot about diabetes. She knows when I'm high, she knows when I'm low, and she knows what to do to make sure her mother is okay. Thank you.
Lucy, first of all, let me apologize. I think I said 30 years with type 1 diabetes, but 20 years is still a warrior of, oh, well, we're not looking at numbers. I just wanted to clarify the number of years we had with type 1. Okay, so Lucy, your question, and we're going to get into the exciting part of all of this, is the debate and kind of question. And I think we'll only probably have 10 minutes or so for that. But if people writing a national operational plans could spend one day in your shoes, what would they understand about this condition that no data, no clinical indicator would ever tell them? So think about that, and I'll get back to you. So audience, Lucy has just said it. Self-acceptance before self-management. And to me, that's the kind of knowledge that you wouldn't know. You wouldn't be able to capture in any policy or any plan without the lived experience, and yet it determines how any of this actually works. So I would like to applaud you, Lucy, applaud the clinician. We've heard from the advocate, we've heard from the implementer. Now let's talk. So Dr. Sanforian, let's get back to you. You sat and warmed the chair for a little bit. I think I gave you that question. When you spoke about rehabilitation and functioning, you said 3 times, almost 3 times, is going to be the burden of functioning NCDs. So tell us, what will it take for all these countries that are on, developing their PEN Plus national operational plans? What do you think it will take to really begin measuring functioning with the same level of seriousness, like I said?
Okay. Okay, thank you, Madam Chair. From my perspective, I think that the first point for handling this situation is to recognize that rehabilitation is relevant for NCD management. So this is the first point. Rehabilitation is relevant and should be integrated in guidelines, operational plan, and all the other tools that we have. After this recognition, we should have commitment, high-level commitment to integrate rehabilitation concretely in all the toolkit which exists for the management of NCDs, for the management of NCDs. So this is very important, and I think that we have a good start with this commitment with the new regional strategy, which have been adopted by the WHO Regional Committee last year by our Ministry of Health. So all of our countries who are here, most of our Ministry of Health endorse this new strategy. So that the question is, how could we implement it or make it concrete in our context? For primary care specifically, we presented the basic package for intervention for rehabilitation, which is a tool that could help us to concretely bring rehabilitation at primary care level. And I think we have some milestone where we should assess this the implementation of this strategy. So I think the recognition is it's first, is key, and after it, the commitment of all the actors at the policy level, the donors, and also the professional, the patient also, and the community is important. All the stakeholders should be involved to improve the situation.
Thank you, Dr. Sanford. Yeah, that's very clear. Political will at every level, I think, is important, and certainly involving the patient advocate. Again, central core message there. Dr. Catherine, I think I left you with the question on Kenya leading by example. What advice would you give countries now developing their national operational plans, moving the lived experience beyond this consultation into real partnership and implementation?
Thank you for the question. And yes, it's true, we do need to move the involvement of persons with lived experience beyond just consultation. I would suggest that it's important for us to identify lived experience advocates who can speak for other advocates, for other persons. So they're not just speaking for themselves, but they're speaking for the whole community, and not just for their own disease condition, but across disease conditions. And even as we identify these individuals, we need to invite and ensure that they are part of the process from the beginning. They have equal opportunity to contribute to the discussions, and that their views are taken seriously. We need to remember that even as Lucy has just reminded us, that they are the experts of the disease condition. They live with this condition 24 hours in a day, 365 days in a year. So they really are the experts of their condition. They're also the experts of what they need, because they know exactly what they need. And even as we develop the national operational plans, we need to remember that these plans are being developed for people to have access to treatment and care, and not just the medicines. As Lucy has reminded us, good NCD care is not just about medicines. We also need to think about the psychosocial aspects of living with NCDs. So even as we develop these national operational plans, let us remember that they are about individuals, they're about children in some cases, and we need to really make sure that persons with lived experience are part of the entire process from the beginning. They contribute their ideas. Their ideas are taken seriously. We can debate and discuss, but we need to acknowledge their ideas. And then even not just about contributing ideas, but once a policy has been developed and accepted, they also need to be part of the implementation process. And in addition to implementation, when it comes to evaluation, they also need to be involved in that process as well. So all the beginning, from before, all the way to implementation, as well as monitoring and evaluation, so that they're able now to see how are their views taken up, how are they put into practice, and did they really make the difference that they expected them to, those views to make in implementing 10 plus. So I just like to acknowledge Lucy for your contribution. I cannot say that I'm speaking from lived experience, although I've been a caregiver, but it's different when you have the specific individual who's living with a condition at that specific moment to speak for themselves because they know exactly what they need. So thank you very much.
Thank you, Dr. Catherine. I think what I took away from there, again, this is the patient-powered involvement at every stage of the cycle of the policy from beginning to end, and then the after. Again, that's important, which leads us to Dr. Yolanda, your question. Now, we have these peer support mechanisms, which are ever more important in the model of care. You described, something exciting that's happening in Mozambique and involves patients, but how has this shaped and influenced? I know Mozambique is developing its national operational plan. How is this involving that rollout, the 10 plus rollout?
Good afternoon once again. Yes, first, let me share with you what is our experience about the percentage of retention that we have since we started the Pen Plus clinic and since we started this peer support group until now. So we have 86% of retention of all our patients. Specific for type 1 diabetes, sickle cell, and the cardiac condition. And we have a mean of 10 clinic visits within all these patients with a maximum of 48 and a minimum of 2. That means these 2 are for patients that are new case for this 1 month ago. But it means that we have many people coming to the clinic visit every month. That is what we have, and what we also learn, and we think it's important to put in our operation plan is this empowerment of the patients and empowerment of the caregivers also, and the importance of leading with mental health, the importance of screening for mental health for every kids that comes to every patient that comes to our clinic, and then also to try to understand what are their doubts, their challenges, to put as a priority and the topics for, especially for health education, because sometimes we think that we know what we need to educate, but when we listen and we participate in these peer support groups, we understand that they are challenge and doubt that we don't include in our educational plan for our patients. So I think it's a very important thing to put and to think about. Thank you.
Thank you, Dr. Yolanda, for that. I think, Lucy, will jump right into your question because it ties into what Dr. Yolanda has said. Tanzania similarly is writing its national operational plan. If the folks involved were to spend one day in your shoes, what would they understand about the condition that no data, no clinical indicator would tell them without you?
Well, as you said, Tanzania, we have a national operational plans and policies that address NCD, include diabetes and other NCDs. But for me, just that's what I think and what I see. There is a gap, and the gap is to ensure these plans translate into a real support to the at a community level. Yeah, because especially in the area of psychosocial care, access to information, right information, but also the patient-centered service as advocacy and an important role in helping them to bridge the the gap. Yeah.
Thanks, Lucy, for that intervention and that input. All right, audience, it's time for you. I'm going to say we have maybe 5 minutes. I'm not sure. This is my clock, and my clock might be fast. Forgive me. Anyway, we have time for a handful of questions. So, anything? Okay. So, do we have a roaming mic, please? We have a lady in the front row. Thank you for that intervention. I'm hoping everyone has your card so we can access that information afterward. I think we have another question in the second row. The second row is pretty active.
Yeah, thank you very much. My name is Dr. Mugisha from Benjamin Mkapa and Medical Association. Professionally, I'm a general surgeon. I'm very happy to hear the rehabilitation and other community-based or population-based comments on how they view NCD, particularly diabetes. I'm very much interested to see how best do we integrate surgery and rehabilitation services into the PEN Plus. I understand from at the drafting level, at the document level, is well written and well articulated how best we can engage them. My worry is the timing, entry point. Rehab comes at the point when we have a problem already. We have an issue. Surgeons come when we have a complication to fix, vis-a-vis maybe they have already diabetic foot ulcer or things like that. I am worried that if we continue with such a trend, we will have a limited role in turning or improving experiences of these patients. I'm calling upon on entry point be at the prevention side, early engagement of surgeons, early engagement of other allied health professionals, the likes of physiotherapists and other rehabilitation officers or specialists. They should be early, right at the clinic when the patient are coming. They should go to the community to educate, to participate in the preventive plans of severe complications that we see that comes with NCD. Many a times we are not there, and time has come we should be there. Prevention is always better than cure. It is less costly, it is less invasive, and you'll be able to manage these complications that requires surgery and sometimes rehabilitation. For type 2, type 1 diabetes, as it has been said, it is important that the community understands also. From the medical point of view, when a patient comes as a non-diabetic to me at the clinic, I've just refilled medication without understanding what they are going through. I'm calling upon for the doctors and healthcare professionals to at least give an ear to these people who are on chronic illnesses, the likes of diabetes, especially type 1 diabetes, where they have a lot of fears. Let's give them more ears and listen to their concerns beyond a prescription. Thank you very much.
Sounds good. Did you need an answer to that first question, or I appreciated that second part, but I think maybe Dr. Karekezi, quickly you can touch upon at what point surgeon can be integrated into the planning process of the National Operational Plan. What your thoughts are, at least on that. I think it was Dr. Karekezi, because it's about these operational plans and at what point. Am I right? Am I understanding? Have I interpreted? Exactly. So Dr. Karekezi. Based on what he asked, my thoughts were Dr. Karekezi, but if you have any thoughts, please, by all means, go for it. Indeed, Dr. Sankara. Thank you, Dr. Sankara. I will end on that note. Thank you all for such a compelling conversation. All these insights have been so rich, and I think the audience agrees with me on that. We have heard today, this is more than patient-centered care. I said I'd convince you, and I think I have. It is patient-powered care. It is exciting to see that this work is happening in Cameroon, in Mozambique, in Tanzania, in Kenya, and from the point of view of sustainability, you know, patient-powered care is a must. The community is invested in the success. Warriors are invested or patients are invested in their success. So it makes great business sense. And I go back to day one of this conference when I heard Dr. Jean Buckman speak about the case for investment. And it's right here. You know, the case for investment is right here on the front line with these teams doing incredible work. Friends, the Pen Plus movement is well afoot. Based on what we have learned and heard today, it is patient-powered, and that alone, I say, the future is very bright. Thank you for your attention.
Thank you very much. Thank you very much, Dr. Nabita. Thanks so much for our panelists. I think you can just move to my right for a group photo. So we want to move to the next session on monitoring and evaluation frameworks for PEN Plus. And I have the singular honor of introducing our moderator for this session, who is in the person of Dr. Sidi Mohammed Old. Dr. Sidi has a lot of experience working within the NCD space. He's currently supporting a number of countries and is a multi-country assignment team officer, but he's based in Burkina Faso. With a round of applause, let's welcome Dr. Sidi. Thank you.
Thank you so much. I think we are going to start a most important session that will talk about the monitoring and the evaluation framework for 10 plus. It is important and difficult because it is still in the building phase. So I will have three very experimented participants, presenters. So I will call Dr. Emily Rowe from NCDI, Poverty Network, to come and sit on the stadium. Our second presenter will be online. It is Dr. Prasad from WHO HQ. And our last presenter will be Dr. Faston Goma, Professor Faston Goma. Also recognize Dr. Fasad that is online, please. Thank you so much. So we'll start with Emily. Emily? Okay, thank you so much.
Thanks, everyone. Honored to be here. I'm a little nervous following the patient-powered panel and all of that energy, and also just really honored to have the opportunity to represent a lot of great work from a lot of people in the room and hopefully online. So thank you so much for the slides. But I'm Emily. I work on 10 Plus with brilliant colleagues from around the world every day. I'm the director of programs for the NCDs Poverty Network. And thanks so much to WHO AFRO and to the government of Tanzania and to Helmsley and to everybody else who made the conference happen. I was stalling for the slides, but it gave me a chance to express gratitude. All right, here we go. So I'm going to talk about early experience about M&E from the NCDs Poverty Network with partners in a bunch of countries we work with. Next slide. So quickly, just we'll do some background and tell you how we sort of started building data systems to really see what was happening with patient care and how to learn from it. And then we're going to actually look at some results from the first 2 years from 16 clinics in 9 countries. So please get excited. Hot off the press. We will be looking at that. Next slide. And it's from these countries. So in turquoise there, in 2022, PEN Plus expanded to those 10 countries. And really we had the chance there to say the data systems didn't exist at the district hospital for the most part for type 1, for sickle cell, for rheumatic and congenital heart disease. So we got to put our heads together and try to build it together and learn from it. And that's what I'm going to describe. So you're going to see data later on from those turquoise countries. And I should say the Chhattisgarh state in India, Liberia, Malawi are also using some of these data systems, but for timing purposes aren't in this data set. So next slide. I also want to acknowledge, I think the last panel did it better than I ever could, but we're looking really narrowly here, right, at clinical process and outcomes. So that yellow box is around where we are today, but the universe of M&E for Penn Plus is far beyond that, and we're learning a lot specifically on the lived experience and how to make the programs better for people living with these conditions through M&E with peer support groups, through M&E with integrated camps. So just know this is sort of part of the big picture of what we covered today. Next slide. So just when we were getting started, we said, okay, how do we create some common language across all these clinics so we can learn together but still allow for contextualization and adaptation of the data systems? So we started by gathering what was out there, which gives you this huge list of data elements, of indicators from all sorts of governments and partners and other bodies. And we built that big, huge list into a big data dictionary, into a huge list, and then we narrowed it down to what was feasible and what we thought across these new countries, these 10 new countries implementing, that we could measure together. And then of course, locally, they could add on things from that. So we have this priority set of indicators that I'm going to show you. And then we built some clinical forms out of that. Some countries used those forms that we built together. Some countries adapted those. Some countries already had formats or even digital systems, so they included the data elements that we come up with together. But the key point here is we started with really big thinking and then really continually narrowed it down until it was really feasible and tried to focus on that basic common language for clinical process and clinical outcomes across all of the countries together. We made our best guesses because we knew that WHO was going to come in and work on these, and you're going to hear about that in the next talk from Dr. Farshad. So we were trying to create something where we could meet in the middle and all have a common language. And then we also designed for paper-based systems. I know everybody, we all want to go digital, but we knew that we weren't digital yet everywhere. So we said, well, if we do a really good job on a paper-based system and know what we want to measure, then we'll be so ready when digital systems come. So the next slide shows kind of the maturation of data systems that we've observed, going from low granularity to high granularity, going from manual to higher automation, and also, of course, going from a little more feasible at the beginning to a higher initial investment and risk. So that moves from paper records, sometimes stopping through an Excel database, which is often a short stop on the way to structured digital data collection tools. So we do have countries using EpiInfo, ComCare, Kobo Toolbox, and then of course the last stage being a true electronic medical record. And I will say DHIS2 tracker is coming highly into play. You're going to hear about that more, I think, in both talks after me, so that'll nicely tie together. So next slide. So this is the list that we started with of priority, clinical, process, and outcome indicators. So outcomes are in blue, process is in yellow. At the top there, I'm going to talk a lot about loss to follow-up, but we really wanted to make sure not only are we enrolling, but what's happening to the cohort. Are they still alive? Are they in care? So that's on the top of the list for a good reason. But we also wanted to know what impact the treatment was having on people's lives. Are we keeping them out of the hospital? Are we getting the kids back in school? And then the process indicators really kind of reflect, is training working? Are people on the right regimens? Are they getting the right laboratory tests? And then, of course, the blue are the clinical outcome indicators, which are imperfect, but is how we started. So next slide. I mentioned collaboration with the WHO in Geneva and WHO Afro, really thinking from the get-go about shared resources, including tools, training materials, facility assessments, and then contributing to the Delphi process that I feel pretty confident will come up in the next talk on this panel. Next slide. So this is an example of, so we had two sort of ways we were measuring things. One was quarterly aggregate reporting, looking at the cohort. What are the new enrollments? What's the condition breakdown, age, gender, and then of course the loss to follow-up and the deaths and the active in care. So just giving you a quick screenshot of what this looks like across these countries that I'm talking about. So reaching over 25,000 patients with severe conditions at district hospital level in the first couple years. And this is what I'm showing you from the sort of aggregate reporting, and then the second way we collected data was in what retrospective record review, so much more manual and much more detailed, and that's what we're going to spend the rest of this talk on. Next slide. Okay, so at this point, I'm up here, but there are tons of people in this room who worked on this data. Can you all stand up for me just so we can see who you are and direct the questions to you? I know you're out there. Prof. Goma, you should stand actually, because Bavin, Catherine, Harrison, Yvette, Elias, Bernard, Abhijit, Sarah and Marta from Sierra Leone, Alvar and Fortune, Justin, Dr. Mary, Peter, George, Anna, Yolanda. You guys aren't standing up. Come on, stand up. Basufakad, Atuwandu, Adisu, Dr. Isaac, Judith, Frank. Thank you so much, everybody. If you have any hard questions, all right. But really, it's been such a joy. These are the people that know these patients, okay? They see the little kid with sickle cell who's been missing school and now is on hydroxyurea and back in school. They know him. They're in the clinic with the peer educators, teaching the teenage girl to measure her blood sugar at home and adjust her insulin. They're moving mountains to get kids with congenital heart disease to the OR. So just really want to honor that. And then with that, we'll get into the results from this record review. 9 countries, 16 clinics. If you show the next slide, we can look at the population. We did not, next slide, we did not do every single patient in the Penn Plus clinics. So we chose these sort of sentinel areas of type 1 diabetes, sickle cell disease, and then the cardiac conditions, which ends up being a family of rheumatic heart disease, congenital heart disease, and cardiomyopathy. So we ended up looking at 4,814 patients across those 9 countries and 16 clinics. I want to tell you, this is what it looks like for early clinics. So these are little baby clinics from the first day they open the doors and the first couple years of data. So we have about 2 years of data we collected. Half and half female and male, average age of 22, and 3/4 of them under the age of 30. More than 20% reporting food insecurity across the cohort, but a lot of range. The range is true of all of this. Incredibly different contexts, so I'm showing you aggregate data, but lots of variability and a lot of things we're still learning from. 44% received material social support of some kind, which was typically transport reimbursement for people living far away or nutritional support, and then a very wide range of travel to clinics. So average across clinics was between 8 and 66 kilometers. There's 1 or 2 clinics particularly that are pulling from a national audience and sometimes even international, so you see this very wide range of distance traveled. Next slide. So case finding, we had referral source for 94% of the patients, and unsurprisingly, I think to all of the folks working in the clinics, most of the patients are either coming from an acute care setting, this is in the early years, like the ER or the inpatient wards, or from outpatient clinics like the OPD at the hospital. This wasn't surprising because in the absence of a pre-existing clinic, a lot of folks were showing up quite late and quite sick. And I think we're watching these numbers because we kind of expect it to flatten out as we go. With even now, I think that we're seeing more even like referrals from primary care, the community. So this will be really interesting to watch. And the other thing to know is that 51% of the patients didn't know their diagnosis before, which is pretty remarkable because these are like brand new clinics. So presumably some people, right, about half knew their diagnosis but were looking for a medical home and longitudinal care. But over half were living with these conditions in their community and didn't know their diagnosis. And I would say from routine data going forward, we've seen the case finding remain very steady. It's not going down. So we are continuing to find people living with type 1, people living with sickle cell who are new diagnoses. Next slide. Okay. I agonized over how to present this slide because it's so important thinking about loss to follow-up and really like, okay, we find all these people, are they alive and in care, right? So first I'm going to explain the slide and then I'm going to tell you what we think about this data. There's 4 lines on it because we split it into, so there's death as 1 line and then sort of total loss, so death plus loss to follow-up. Then we did the same thing only for people with more than 1 visit. And that's because for people with with only one visit, we think there's different dynamics going on. So they might be quite sick and showing up very, very ill and not actually making it out of the hospital. The second is some of that crew is coming in from afar, having one visit and going back to their home very, very far away in like a different part of the country. So it's a little bit, they haven't really had the chance yet for the sort of magic of the chronic care, right? The peer support groups, the trust in their clinician, the social support, the stabilization of their medication, and the self-management education. So that's why we're kind of looking at those a little bit differently. But ultimately what we saw is the probability of, okay, we know this person is alive and they're in care at 12 months after they were enrolled, the patient was enrolled, is just over 90% for type 1, similar for sickle cell and lower for cardiac. So some progress to go. I want to say a few things about loss to follow-up here and the cardiac number. And then I just have like 2 more data slides and then I'll be done. The cardiac number is probably partly because of cardiomyopathy in there, and there's like a lot of older, quite sick adults in that, but also we know that echo training takes longer as these clinics open, so those numbers tend to lag in many ways. And then we're also looking very hard at access to cardiac surgery, so therapeutic and definitive intervention for some of those patients. The lessons that we see here are, one, the risk of loss to follow-up is highest in the first 3 to 6 months of enrollment. So this is actually kind of intuitive when you think about it, but we've started adjusting the programs to really pay attention to that risk early on. Number 2, we have very good qualitative data from a couple places that show one of the biggest things that keeps people coming back to clinic is if they see the same clinician. They are known. Their name is known. This also probably feels intuitive, but it gets at the importance of the training conversation we've been having. Number 3, this also taught us about the importance of, we've talked a lot about integration, but distinguishing from the patient's perspective, the Pen Plus and Pen. So while a lot of shared services and systems are happening at the health systems level, the patients really need to be in a line that's short enough that they're not there all day and in line with their peers, getting that really individual care. And I can say that with confidence because one of the clinics in here had a loss to follow-up rate that was like 5 to 8 times higher the rest of them, and that was the difference, was that they were still mixed Pen and Pen Plus, and that has since been like largely fixed. So looking to that new data. And then the other program components are social support, consistent medications, and a data system that can flag missed visits. Okay, I have 2 more. Next slide. So this is some process measures. Again, this is the training working? And by and large, we're seeing pretty good results for people on glucometers, getting their A1C measured, 93% of the sickle cell cohort on hydroxyurea. And again, the cardiac screening lags a little for echo, but we're following those, and a lot of them are a lot higher now, 2 years later. Next slide shows some outcomes and really seeing average A1C go down from 11.2 to 8.9, and importantly, people with A1Cs above 12 going from above a third of patients down to 12%. So things going in the right direction, and also seeing some things to work on. Less people needing transfusion and less people with a dangerously low hemoglobin with sickle cell, and then improvement in symptoms for cardiac. And the next slide shows really a reduction in hospitalizations and school absences. Next slide. For type 1 and for cardiac. And then for sickle cell, we saw a reduction in school absences, but there's a high degree of variability in that hospitalization data. I had a long conversation with Professor Mapani yesterday, and we have some ideas that I don't have time to share right now, but so still learning a lot across this. And the last slide is just showing everybody the resource library and letting you know that these are kind of our conclusions. Tons to learn. Thank you so much to the many, many people who made this possible and all the ongoing work, learning about case finding, the loss to follow-up, which I spent a lot of time on, and then the clinical process and outcome indicators. And we've actually started building this thing to measure indicators at the clinic level for those loss to follow-up systems to really understand kind of what's happening at the patient level so we can replicate it. And with that, thanks for the
Merci beaucoup. Thank you, Emily. think when you ask people to stand up, I saw a lot of people. So you are doing a lot of work, but it is hidden. It's hidden work. So we only see the data. We don't know where it came from, but it is a great job. I would like to ask Dr. Fashad if he's online, if he can directly continue. Thank you so much. Can't hear him, please. Can you try to speak?
Confirm you can hear me.
Yes, we can hear you now.
Okay, perfect.
Okay.
And can I have also a slide?
You have 10
before-
minutes, please.
Yeah, sure. If I have the slide, I will try to keep it. So good afternoon, everyone. Very happy to be here. It's a really privilege for me to discuss about the monitoring and evaluation. And Emily, sorry for disappointing you on the items that I'm going to discuss because the request from Apple was talking about the AI-enabled enhancement for non-communicable disease monitoring and evaluation. But just to point out what we have done, the good news is we already have the list of the indicators, very limited number and efficient indicators, and we are waiting to get the green light from Apple for developing including the 10 plus conditions, related conditions to the NCD module, which is already developed within the architecture of the DHIS2, and it is available as an Android version offline system, which takes less than 30 seconds for completing the recording. And when we have when we including the conditions like type 1 diabetes, sickle cell disease, rheumatic heart disease, and congenital heart anomaly in the module, that would be completely usable for countries. But the area that today I'm going to talk is how we are going to move forward. And it was, for me, very interesting. The topics that you were discussing is a part of my also discussion. Next slide, please. So what now we do have, there are different components for NCD surveillance or monitoring and evaluation. It could be surveillance of mortality, it could be surveillance of population or surveillance of policy and capacity in the system, and also it could be facility level. And we call it facility-based monitoring. But considering the new, feature that AI brought to us, we can think about moving from facility-based monitoring to facility-based intelligence. The current system that we have a system that's creating data, and we have to check the quality of data also. Sometimes there are a delayed in reporting or delayed in finding the problems, and also creating the report and dashboard, which usually is reactive dashboard. You see it if you get it by chance, or you have to be very expert on the interpretation of data. And many colleagues in the facilities, they don't have time for going through this system, and also they don't have enough expertise to do it. And we do believe that the new features like intelligence, artificial intelligence, can help us on checking the quality of data, on monitoring the patients in the real time and visibility to clinical pathway, also helping us to the prediction and prioritization of the patients and also facilities, developing the actions, and finally come up with a better outcome. So the AI doesn't replace the monitoring, but it transfers monitoring into intelligence. Next slide, please. When we are talking about the intelligence goes through different components of the intelligence pyramid. First is about the data. So for now, if you wanted to evaluate the data quality, you need to go through many indicators, coming up with many statistical inference. But with the features that the AI is providing nowadays, we can easily, without any specific skills related to statistics, come up with the data quality in terms of heaping, in terms of plausible range, in terms of outliers, and so on. So that would be the first and primary use of the AI. Also, in terms of the patient intelligence, the AI can help us using the facility-based monitoring and platform, which is the one that we discussed about it, is a PHIS platform, and many of your country in Africa is using this. We can come up with the patient risk stratification, like as Emily mentioned, the last two follow-up prediction, or miss visit, or adherence to the medicine, and risk stratification. Related to the facility, we can come up with the facility performance ranking, also stock out, and workforce forecasting, medicine forecasting, supervision prioritization. You don't have enough resources to go through all facilities, and some facilities need more help, and the system can tell you which facility could be doing this. And also the program intelligence, which gives you the identification of the prioritized districts and population, also the achievement, the predict the target achievement, and also consider the available resources for achieving to these targets, which are very important one. And finally, it can help you for providing the action plan at the facility to the top level, at the higher levels, and also prioritizing the intervention, and also providing the optimization from the resources that you have. So this pyramid is give you the better value, and also better chance for decision making to come up with a better outcome. Next slide, please. So when we are talking about the patient intelligence, is exactly what Emily was referring to. So we are the AI in this package can go through all components of diagnosis, treatment, follow-up, retention, and also control. And based on several variables that already is in the DHIS2 package, you can come up with this one specific patient. What is the possibility or risk for missing the next meeting, the next visit, or what is the possibility of dropout of the program? So these are the components that are helping us for improving to keeping the patients and making sure the quality of the compliance, and also quality of services, and finally better outcome. Next slide, please. Besides patient intelligence, also facility intelligence is very important, which is usually data will be integrated on the system using the AI analytical, coming up with a very useful action for improvement. And this action could be performance benchmarking, or performance ranking, or workforce or medicine forecasting, or supervisory visit prioritization, and also quality of care monitoring. So the system gives you the numbers, and also the system gives you what are the main problems of this specific facility. Low diabetes control, or frequent insulin stock out, or low retention rate, and so on and so on. So when you have this, and you wanted to ask the AI for generating the action plan for next 3 months, to be able to achieve like the target in 2030, so that would be completely possible. Next slide, please. And not only patient intelligence and facility intelligence, but also program intelligence that can be run at the district level, province level, and national level, and even region level. And it can tell you about the facilities or countries or districts that they need the support for improvement, which area needs more prioritization in terms of resource delivery, or in terms of supervisory visit, and what are the largest gap in each level, and how you can fix this, what would be the best investment among the available intervention in the system. So it could be also creating a global dashboard based on the agreement of the countries, but besides the regional or Afro level monitoring, it could be just limited to the country level monitoring with all the districts, regions available over there. Next slide, please. So when we are talking about the facility intelligence, we are thinking about the agentic approach for AI, and it gives you for example, if you are at the level of the country, you can ask for ranking for you the 5 top districts with lowest retention rate, and what are the problems for each district separately, and what would be the next action on this. Next slide, please. And when we are talking about the insights to action, we are talking about using all available data which is available at the facility or community or lab system or pharmacy, supply chain, workforce, financing, surveys and population level, and also external data, to come up with the answer to where we should focus on within a country or within a district or within a region, and what is happening in this system, and what will be make a biggest impact among the available intervention for us, and what action should be taken to get the highest effect from our intervention, and then see what would be the results. So this kind of approach, which we call it agentic approach for AI, is the practice that now we in HQ are doing it, and the beta version of this package is available, and we are now looking for funds to get the support for completing this. But when you have this agentic approach in the system, every single people among the health professional or managers at the district level or national level, they do have an expert who is checking all available data and telling you what is wrong with the system and how you can fix it. Our plan is every single person who is at the national level taking like 5 minutes of their time in the day, looking at the problem with in the we call it situation room, the daily situation room. They can just look at it and see what is the problem for today and what are the possible actions. And the system itself taking the targets into account and providing milestone for every 90 days. For now, we set it based on 90 days, but it is possible to reduce it or increase it, the number of days. And it would be translated at the Ministry of Health, what would be the milestones. Also, it translated to the district level and also translated to the facility. Next slide, please. So in the future, what we are thinking is like a population intelligence, patient intelligence, facility intelligence, program intelligence in all layers of the intelligence in the system, probably large health system model rather than large linguistic model, and to come up with a better decision and better outcome. I think that's a next slide. That's a last slide of mine. Next slide, please. Thank you so much for your attention, and sorry for taking more time.
Merci beaucoup, Dr. Fashad. Thank you so much. Thank you so much, Dr. Fashad. I think your presentation is welcome, showing the importance of artificial intelligence, the pyramid, but also we have seen the concrete utilization of EA in terms of NCD data collection, data improvement, improvement of NCD statistics, but also investment. data for action, a lot of dashboards, nice slides, how to measure impact, and also to mobilize resources for NCD. So thank you so much for your presentation. Now we are going to move for the next presenter, and the last but not the least, Professor Faston Goma, that will share with us the experience of MNE for Pen Plus in term for Zambia. Dr. Faston, thank you so much. You have 10 minutes, please.
Thank you very much. Mine should be rather quick, I suppose, because all that I'm trying to do is give a demonstration of where the data that Emily has shown us came from. Zambia will be used as an example of where that data is coming from. Thank you very much. Let's go to the next slide. Yeah, so I'll try and go through that to give an outline to my presentation. I hope I don't lose you. Next. Sorry, I think technology wanted me to do the closing ceremony. Just the next slide, sir.
Just 1 second, please.
Okay. I hope the system is not protesting. That has been on for a long time. It needs a break. Or it has gone into some form of hypoglycemia. Yeah, so I think all we have to say is okay. Right. Next. Thank you very much. So in Zambia, we are now operating from 5 different sites. Actually, all the 5 sites have been set up as training centers, and so we are ready to roll out the national operational plan. But you can see where our patients have been coming from and the numbers to date. Exactly what Emily was showing. Next slide, please. When you look at our case finding, we've not only stuck to the people who have been coming to us from the different areas, but we've actually gone out to the maternal and child health department to do newborn screening for sickle cell disease. Zambia is one of the countries with high burden of sickle cell disease, and we've gone into newborn screening, and so we actually are working with midwives from there. We have screened so far 4,000 babies, and of those 21 are positive for sickle cell disease. 9 have already been linked into care, and the 12 are being processed. Next. These are the different conditions that we have enrolled so far. Topping is sickle cell disease. We have quite a burden of type 1 diabetes, number of cardiac patients, and a number of epilepsy, and then we have other NCDs as well. Among those other NCDs are mental health conditions. Next. And this is how they have accumulated to date from the different centers. The first two, Chifubu and Chipata, are the ones that we started just about 13 months ago. And Kapirimpochi, Matero, and Mwachisompola are the centers which we started originally with the help of the Hemsley Fund, and Chifubu and Chipata are being supported by the Scottish government. Next. And that's how we are doing when it comes to retention. I think we must say that we have learned a lot of lessons from our HIV colleagues, and Zambia is one of the countries that scored the 95, 95, 95 on the HIV universal scores. And here we are with the NCD approach as well. You can see at Matero, we are at 97% overall, Kapiri 98%. We are lowest in Chipata at 82%, but that is where we said we have just recently started. Emily did say in her presentation that when you just start these clinics, there's actually rather poor adherence to reviews, and so you tend to lose a few patients. But as you go on, they actually become more adherent, and you get to over 95%. Next. And these are some of the things I think we've been talking about as to how Pen Plus clinics make it easy for us to refer patients to tertiary level care. And from our cardiac, from the patients we found from the echoes being done by our mid-level staff, we've been able to diagnose patients with tetralogy of Fallot. We've been able to diagnose patients with severe mitral stenosis, mitral regurgitation, and we've sent them directly to the National Heart Hospital. And we can say, as to date, we have had actually one of them operated on. And sickle cell disease cadres have become very, very close to the sickle cell consultants at the tertiary level hospital. And so we don't refer patients anyhow now, because they can actually pick up the phone and get a consult done virtually, almost on demand, so to say. They are always available, and that has made work very, very easy. We've had cases which previously needed just straight referral, as in our bullet number 3, patients who come in with anterior bossing. The protocol says refer to tertiary level hospitals, but in this case, we actually just called the tertiary level hospital, and the consultants gave the advice that was needed, that these patients needed to go on to have monthly blood transfusion, and these were done at the center. That's, I think, a very big leap in terms of access to care. Thank you very much. Next. And also to just say that with the patients that we are dealing with, there's usually a problem when it comes to access because of distance and poverty, requiring that we do help them with transport refunds and food packages, and those have actually helped in keeping these patients in care. So we have our numbers there, and I think those numbers actually do translate to the percentages that I showed you earlier on. Next. Talking about how Pen Plus has improved access to medications in the different facilities, you can see that in terms of sickle cell care, when we started, only about 30% of patients were on hydroxyurea. Currently, 100% of them are on hydroxyurea. Folic acid, I think they were doing quite well. They were around 70%. We've pushed that one up to 80%. And antibiotics have been an issue, but we have actually edged it up slightly there. When it comes to sicklers getting blood transfusions, the rate at which they have been transfused has gone down because of the better HB response they are getting from being on hydroxyurea. and only a few of them now miss classes because of crisis, meaning that the amount of crises have been reduced because of the care that they are getting from these clinics. Next. Type 1 diabetes is also an issue, but you can see that we have had improved parameters. When we started, less than 20% of them had glucometers, but now we are at 54% of them have own personal glucometers. When it comes to prescription of insulin, we have also improved the proportion of patients who are on basal insulin, and there's been a great improvement in the level of HbA1c. When we started, less than 10% of them were at target. Now we are at 58%, slightly above Emily, 54%. So we are happy that we are there. We hope that we'll keep a tab on this. Next time we'll have a league for Pen Plus clinics to see who is doing best when it comes to HbA1c. Next. Amount of echoes done now. Access to echo in Zambia is a problem right now. The tertiary hospital, I think we have a 2 or 3 months waiting list. But when you come to our Pen Plus clinics with our mid-level cadres empowered with echocardiography skills, you can almost have it done at point of care. And we have had 215 patients so far who have been through these echoes. As I said, several of them have been found to have a serious disease. Now, I think I must mention the one who has had cardiac surgery. Someone did mention yesterday that we move from one disease to another in NCD, and that's what happened here. This person had a severe mitral stenosis and went to our National Heart Hospital. They operated, they have put in a metallic valve. So now we are back to treating the metallic valve, okay, trying to anticoagulate, doing INR and doing warfarin titrations, but we are happy that it has been done. And we have 5 awaiting surgery. We hope it will be done soon as well. Next. I did say that we have quite a good load of epileptics on our enrollment, and we can say that with improved care, the number of seizures reported by these epileptics has gone down drastically, and the number of seizures per patient have also gone down significantly. So we really want to say thank you, Pen Plus. We are doing something for our population. Next.
Please.
And this is just showing about our mentorship sessions, that we actually have mentorship in 5 conditions currently: diabetes, sickle cell disease, cardiology, epilepsy, and mental health. Next. And that's it. Thank you very much.
Thank you so much. In fact, if we leave time for Professor Goma, he can speak for hours. Thank you so much. Thank you so much. I think Professor Goma also highlighted and demonstrated the use of data sources in Zambia. Many sites and centers, 20 centers. And he also showed us the number of cases they have, the rate of retention, which is very strong in the case of Zambia. Also, you also show us that you had the opportunity of providing some social support and to improve the functionality and the amelioration of the utilization of the health centers, but also medicines have a lot of opportunity to put patients under different kind of medicine, including hydroxyureas, folic acid, glucometers also available. You showed us really that you are monitoring your polio indicators in the case of Zambia and where the data came from. Congratulations to Zambia. So I will not have a question for you, but I will ask if the audience have some questions for you. We'll take maximum of 3 questions. If there is questions in the room, it is welcome. Yes, we have here in the center that lady in yellow. Yes. Thank you.
Bonjour, je vais parler en français. Je suis docteur.
Good morning. I'm speaking from my name is Dr. Luminary. I'm from UNICEF from Cote d'Ivoire. My question is to Professor Pastor. I would like to know, first and foremost, please go ahead. Thank you. I would like to congratulate the 3 panelists for the good information that they've given us. Particularly, I'd like to speak to Professor Pastor. I see that in Zambia, you have very good results on management of your patients. And the question that comes to my mind is that, is this treatment free, or there is some patient contribution? Because I see that you have very good outcomes in all the pathologies that you are treating when it comes to NCDs. How do you go about getting input, the facilities? Is it donor funded or it is government funding? And how do you look at sustainability of all these results? Thank you very much. Do you have any other questions?
We have in the back, please. Au fond, au fond.
At the back, there's a question.
Troisième main, je la vois.
And I see the third hand there. Could you please give them the microphone?
Monsieur?
Could you please hand over the microphone at the back? We'll come back to you, madam.
Thank you.
So thank you very much, moderator. So I really wanted to acknowledge great presentation, all 3. I'm Dr. Meros from Japaigo, Tanzania. And my question goes to the second presenter. Very impressive work on bed blast monitoring, but I wanted to understand 3 issues. 1, the cost of introducing an AI-based monitoring system, and scaling up, how they can be able to scale up in other countries if we're interested. Is TA going to be provided, etc., etc.? Thank you.
Thank you so much. Now here, please.
On my left.
Okay, good afternoon. I'm Dr. Nasser from Tanzania. I had one question for Dr. Emily. I wanted to ask you, you have achieved high active participations of patients in care. I wanted to ask what factors drive the most, and what do you recommend other countries to do too? Thank you.
Thank you so much. So we'll go for these 3 questions. Okay. Exceptionally, we have one more hand. Okay. Il y a une 4e main ici.
There is a 4th hand at the front.
Yes. Wanted to ask a colleague who is online, how are they navigating data sharing cross-border? Because it's an issue now with Data Protection Act that many countries have enacted and gives a very strong obstacle towards sharing data cross-border. And for generating AI-based data for algorithm training, you having more multiple centers brings a component that ensures that the data that are used and the algorithm that is trained is well trained because you have a robust data that you have put in. And now, given that we have some restrictions, some of other countries are very strong, some have frameworks that allows, how do you navigate across as WHO, Afro, or any other component that we may wish to engage? Thank you.
Thank you so much. Thank you. So we'll start by Dr. Faston, Professor Faston. Please, you have one question on the cost of interventions. No, it's not.
Thank you very much. The Zambian government policy is to offer free medical services at primary care level. And that is where we are operating from. And so far, we've been grateful to
Dr.
government
Faston, very quickly,
in that
because we are
3/4 of what
have
we have
exhausted
needed,
our time.
3/4 of what we have needed has been available, and so it has been free. But the 25% of the shortages that we have had that to supplement from the project. And so we've spent a little money from the project trying to get the drugs in and sometimes the laboratory supplies.
Thank you so much,
To do things
Professor.
such as HbA1c. Thank you very much.
Thank you so much, Professor Emily. Can you go with your question, please?
Yes. Thank you for asking me a question on my very favorite topic. I think the retention in care is so important, and we should all be advocating that that's always presented. So beyond number treated or number in care, are we retaining people in care? So I'm going to tell you 5 things I think are really impacting it, not necessarily in order. That really depends on context. But one is minimizing out-of-pocket costs. So if there are high charges to medications, consultation fees, or even transport, you'll see a drop-off of retention. Number 2 is consistent clinician. We have qualitative research I mentioned that says if the patient comes back and knows the person in the consultation room, that's really going to encourage them to stay in chronic care. So that has a lot to do with our staffing and training model, is that consistent clinician. Number 3 is consistent medication supply. There's at least one country that can watch if there's stockouts, the loss to follow will rise and then it will fall again when the drugs are back. So the consistent supplies are really important. Number 4 is data systems to flag missed visits. So being able to know who's expected at clinic today, who missed a visit, and helping find them, be that through a phone call or a home visit or a community health worker or a peer educator. And then the last one I mentioned is really kind of the experience of the patient at clinic, to not wait in really long lines. And that was where I mentioned the importance
Thank you so
to
much.
separate Pen and Pen Plus to make sure the lines are reasonable and that the consultation time is attends to the complexity of the condition.
Thank you so much, Dr. Emily. And last but not the least, Dr. Fashad, are you online? For
Yeah,
your
I'm
question?
online, but I haven't heard anything from the audience. So if there is a
Okay,
question,
the question is about the AI, how we scale up. Is there opportunities to scale up the experience, giving the cost of the high cost of piloting them?
so we don't know, we don't have the experience of scaling up this. What we do have in hand is a beta version of the AI for the strengthening the health information system at the facility and those features. What we do need is to have it on the ground as a pilot and then see how it is possible in system. But what we know is for many of those features, we can create it inside the like engine inside the server, which doesn't need that much a strong infrastructure of the IT. The internet and speed up the internet. So there are solutions for scaling up without a huge cost. But I am not in the stage that can tell you what would be the possibility of this, because we are just created the beta version of this, and we need to get some supports, financial supports for the implementation as a pilot. And then if we show the case for the governments, that would be the possibility of the scale up, because it makes life easier for everyone, from the policymaker until the clinician.
Can you touch a word on the cross-boarding data sharing, please?
Sorry, I didn't get it.
The cross-boarding data sharing.
Oh, so the data sharing is the domain related to the government. So what we are actually suggesting is to build it at the national level, and if then there is an agreement at the regional level for making some benchmarking and learning across the different countries who are implementing the system, then the system provides the feature for regional level data sharing. But it is completely, data is in the hand of the government, and ownership belongs to the country. But then they have to decide about.
Thank you so much. Thank you so much. I think we are done. I would like to thank you. We can give a round of applause to our presenters. And then we give back the floor to the team. Can we come on the photo, please? Thank you.
Thank you very much, Dr. Sidi and the team. So it's time for lunch. We'll break for lunch. We have 45 minutes to go for lunch. And after lunch, we are going to have 2 back-to-back parallel sessions. We'll start with country experience sharing. We have Sierra Leone, Liberia, Uganda, Ethiopia. That will happen in this conference hall, Celos. Then Mozambique, Ghana, Zimbabwe. That will be in Mikumi on the first floor. So this session will last for 1 hour. Then it will be followed closely with another parallel session. We are going to have abstract oral presentations for the abstracts. That is also 2 parallel sessions. And as you can see on the screen, the abstracts that will be presented, or the presentations that will be done in Celos Conference Hall, you can see the titles and the presenters. Then we have same for Mikumi, the titles and the presenters. So kindly take a look, and that will help you to determine where you want to actually participate with respect to your area of interest. So just look at the screen and then decide which presentations you would want to participate. So we have 45 minutes for lunch, as I've indicated. Once you step out, there are some ushers there who would direct you to where you are going to have lunch. After lunch, that's for 45 minutes, please. Today we want to really respect time. So 45 minutes, and then we will have our first parallel sessions for the countries, experience sharing, and that will be followed closely by the second, which would be oral presentations. Thank you, and enjoy your lunch.
Yes, yes, yes. Yes, yes, ni majaribio. Ni majaribio ya kipaza sauti. Tunajaribu kipaza sauti. Yes, tuna check. 1, 2, 3. Ni majaribio ya kipaza sauti. Ni majaribio ya kipaza sauti. Yes. Yes, yes. Yes, yes. Yes, yes, yes. Yes. Yes, yes, ni majaribio. Yes, ni majaribio. Yes, ni majaribio. Yes, yes. Yes, yes. Ni majaribio ya kipaza sauti.
Thank you so much, Dr. Coffey. With us today, we also have Dr. Gene Backham, who is a professor at Harvard Medical School and is also the co-chair of the NCDI Poverty Network with us. Dr. Gene, could you speak on the key issues that are driving the Pen Plus program and why this agenda remains so urgent for Africa?
Fourth short year since the region adopted Pen Plus as a regional strategy in 2022, has been an explosion of activity in engagement with Pen Plus. There are currently 20 countries that have initiated programs. 5 of them actually have operational plans to scale them up. And there are more than 30,000 patients, people receiving care and being protected from poverty. This is an incredible achievement, but we think that actually in the next 10 years there's an opportunity to do a huge amount more. This is because we showed at this conference that investments in 10 Plus have returns on the order of 4.5 times more than their cost. And with really modest investments on the order of 60 cents per person per year, we think that we can expand the number of people in the African region receiving 10 Plus care to 1.5 million. And this will require, again, relatively modest investments by national governments on the order of 1% increases in health expenditure. But that needs to be really supported by global partnership, global coalitions, people who are affected by these conditions all over the world and who don't want to see their brothers and sisters dying in the same conditions that they've been able to live with as a result of life-saving treatment. We think that the movement that we're started here in Tanzania just 2 years ago at the first international conference on 10 Plus and it's continuing here is really showing that global solidarity is possible.
Thank you so much, Dr. Jean. We will now like to turn to Ms. Neema. Ms. Neema Muhammad, she is a sickle cell disease advocate and a key voice in the Voices for Pen Plus program. Ms. Neema, if you could give us, please, some reflections from this forum, from the perspectives of people living with severe NCDs, what meaningful inclusion in this movement, what does that look like? Thank you.
Thank you. For the behalf of the people living in this disease, our first is we want inclusion with the people living with non-communicable disease must be included as partners in taking services, policies, and priorities. We are not only fighting for care or recipients of care, but also important voices and presence. Also, my takeaway is importance of integrated care. Non-communicable disease cannot stand alone, so we want the mental health of the people to be care because burden of living with a chronic illness is not only physical, but also emotional, psychological, and social. Also, we need to expand services for severe non-communicable disease more region. For I and fellow warriors who happen to be beneficial of this Pen Plus initiative, but we saw the benefits of Pen Plus clinic. So we wish and we want this service to go beyond to every warrior, every warrior with non-communicable disease can access it and can be able to benefit from it.
Also, we want the capacity building training and mentoring for 10 plus in implementation. When we go to the clinics, we want to see the doctors, the doctors, the healthcare providers who are well trained, who knows our conditions. So it will be very wise and it will be very good for us to receive a proper care for better management, treatment, and well-being for our conditions. Also, what we want is inclusive, integrated, accessible for non-communicable disease care for people living with non-communicable disease.
Thank you, Nema. Finally, we would like to move to the country now, just to get that country perspective. We have Dr. Mary Mahige with us today, who is the Director for Research at NIMRI. Yes, yeah. So Dr. Mary, please could you provide us with an overview really of the country-led expansion plan for Pen Plus? What's the plan? Where do we go after ICPPA 2026? Thank you.
Thank you very much. So at Tanzania, as we always been talking about pilot implementation has been done in Pandora and Karachi, and we've learned a lot of lessons from the pilot implementation that we've done, and we've been able to document to the research that was done there. Together with the implementation, we've learned that Pain Plus really improves patient life, improves outcomes, and is also cost effective. And we've been able to document that through implementing Pain Plus services at these different hospitals, we were able to reduce referrals by about 80%, and that improves. If I try to also improve patient retention, they're able to stay and access services at that different hospital rather than them being referred to higher level facilities and they're not able to attend. But the research has also shown that it has improved, as you know, 10 plus conditions affect children. So also it has been shown that it improves school attendance, their outcome, and also their well-being in general. So as a country, we're working together, taking the lessons learned from the work that we've been doing at the National Institute for Medical Research. Together with the ministry, we've gone through analyzing the results that we found in this pilot phase. And together we have looked at it and seen how the implementation can be adopted and actually be implemented in the country as a whole, aligning with our local policies and our local guidelines and also our local situations. So we've done a series of stakeholders meetings to realign the implementation so that it can be scaled up. And as I speak, we have a draft operational plan that is now being validated and ready to make sure that as a country we start the scale up. But it's not only the discussion part because some of the implementation has already begun. So the main issue is really aligning what we're planning to do and our local policies and guidelines. So to take it to a national scale.
Thank you so much, Dr. Mary. Finally, I would like to take it back to the country. We have with us Dr. Omario Buguyu, who will be representing the Ministry of Health. Dr. Buguyu, please can you brief us on the country's NCD priorities? Thank you.
Thank you very much. Within the country, there's a lot of priorities, and this is based on findings, either from the clinical perspective or some from the survey. We did a recent scape survey in 2023 and realized that we still have a lot of people who have a lot of non-communicable diseases looking at the disease perspective, we have around 1 in 5 of adults having hypertension, and 3 in 10 in 100 adults with diabetes, and we have around 20% of adults with depressive symptoms. We also have injury as some of the challenges that we have. We have number of persons who diagnosed of cancer. In a year, around 45,000 new cases of cancer and around 30,000 deaths from cancer yearly. Again, we have more than 15,000 thousand people born with sickle cell disease. Almost 20,000 people, child born with congenital heart disease. So we have a lot of problems when it comes to non-communicable diseases. So priority in terms of the burden of the disease, we still have number of conditions that we think we need to intervene. But all in all, we still work within the 10 plus, and we've stick these three conditions as a priority condition: sickle cell, type 1 diabetes, as well as heart diseases. But we still have a number of individuals who still need help. Looking at human resource health, we have a gap, and especially at PHC. We are blessed to have very strong primary healthcare facilities with enough spaces to work on, and with at least a relative well-equipped facility, and with presence of universal insurance, we know we have adequate enabling environment. What we need is just a support in the catalytic fund to make sure that some of these initiatives are adopted within existing infrastructure. For example, when NIMRI did studies on Pen Plus, we accommodated the finding from the Pen Plus, and we demonstrated that by establishing almost 96 pen clinics. We skipped the rheumatic heart disease component because of the infrastructure. We are not accommodated to that. But with the sickle cell type 1 diabetes, we immediately incorporated within our structure. And we keep on increasing based on the demand. So the call of action, especially to the local, again, we accommodate what WHO Afro is asking the member states to follow, one using local resources, and we've been demonstrating that, because out of these 96 facilities, it was just it was co-investment between the team from NIMRI, colleagues from other programs, as well as local authorities. Again, we have a relatively enough human resource to adopt, especially within our district hospital, where most of these 10 plus clinics are, but also at health centers. We, especially high volume health centers, we have adequate human resource for that. And as a country, we have essential medicine list, which also accommodated most of the health commodities needed for such kind of facilities. And our financing, especially through universal insurance, we think that in the next few years, we could accommodate more than 70% of Tanzanians who are in need of these NCD services, especially for the severe and
Thank you so much for that, Dr. Obugoyu. I would now like to just take a few questions, just in case they would like us to answer anything that was not spoken on. Upendo, naomba uje, ulikuwa na maswali. Na wengine mna maswali yoyote? Aha. Aha, okay, sawa. Kuna maswali yoyote? Hamna maswali? Aye. So there's no questions. If there's Anything else you would like to say? No? Asante.
Just to thank WHO. Just to thank WHO, AFRO and WHO HQ for again selecting Tanzania for this meeting, and our colleagues from NCDs, Poverty Network, and other supporter and delegates who attended this meeting, because without them, this event wouldn't happen. And coming back to Tanzania in the space of 3 years, we showed the trust that we have to us. And if somebody trusts you, there's nothing that you can do unless give back the trust. So we appreciate WHO Afro, appreciate it being Poverty Network and Huxley for supporting this event.
Thank you so much. Okay, so that concludes this brief press briefing. For us, we will be providing you with all their names after this session, but thank you so much for taking the time. I know it's during lunchtime and you're all very hungry, so I would like to close and let us proceed for lunch. Thank you so much. Eti mnataka ya Kiswahili? Aya. So, Dr. Mary and Dr. Boguzi, please, if you don't mind. Neema, naomba ubaki.
Ili eneo litakiwa litumike tena, ndio kama na nini.
Tumalize tu alafu. Mna maswali? Umeona eh? Haya. Ameuliza katika huu mkutano mlikubaliana nini?
Huu ni huu ni huu ni mkutano wa tatu wa kimataifa ambao ulikuwa unakutanisha sehemu kubwa ulikuwa unakutanisha wakuu wa nchi kwa ambao umewakilishwa na mawaziri wa afya kutoka katika nchi 10 ambazo zilishiriki hapa, lakini lengo ilikuwa ni kupata nchi zote karibu 40 zinazokuwa sehemu ya jumuiya ya shirikisho la shirika la afya duniani kanda ya Afrika, ambapo Profesa Janabi ndio mkurugenzi wake, na tulikuwa tunakutana Tanzania hii mara ya pili kwa ajili ya kujadili utoaji wa huduma za magonjwa yasiyoambukiza, hasa yale ambayo yako katika uhatarishi zaidi. Tunasema severe non-communicable diseases. Hii severe ni nini kwa Kiswahili fasaha? Na katika hilo nchi wanachama walikuwa wakijaribu kupitia mikakati mbalimbali. Kwanza kusoma kutoka kwa wenzetu, kila mtu jinsi alivyofanya, na bahati nzuri Tanzania ni miongoni mwa nchi vinara ambao wamefanya vizuri katika eneo hilo. Lakini la pili ilikuwa ni kujengeana uwezo, na hasa wale ambao bado hawajapiga hatua katika kuandaa mikakati ili kukabiliana na magonjwa yasiyoambukiza, hasa yale magonjwa hatari zaidi. Na hapo tunazungumzia magonjwa matatu ambayo tunazungumzia kwa kiwango kikubwa katika eneo hili. Tunazungumzia ugonjwa wa sickle cell au selimundu, kisukari aina ya kwanza, na tunazungumzia masuala ya magonjwa ya moyo ambayo kwa kiwango kikubwa ndio yanaonekana kuathiri zaidi watu wengi na yanahitaji utoaji wa huduma za kibingwa katika hatua ngazi za msingi, ambayo kwa mara nyingi huwa na makubwa ambayo tutafunga, maanake baada tukifunga mkutano kusema kwamba ndio tumekubaliana, lakini mwelekeo ni kwamba kuna mambo karibu manne Dr. Mary anaweza kuongezea ambayo yamejadiliwa na tunafikiri kwamba tungeweza kukubaliana. Moja, kukubali na tunasema kuadopt kwamba huu mkakati unaoitwa 10+ ni mkakati ambao bora na ambao unaweza kutusaidia katika kukabiliana na janga hili la magonjwa yasiyoambukiza. Lakini ya pili, kukubali kwamba kuna changamoto ya upatikanaji wa fedha duniani katika kufadhili au kusaidia utekelezaji wa miradi mingi katika eneo kwenye sekta ya afya, na hivyo mkutano huu ulikuwa unafanya viongozi pia kufanya commitment, kujitoa kwamba na sisi tunahitaji kufanya upatikanaji wa fedha kutoka ndani kwa ajili ya kuweza kutoa hizi huduma za afua na magonjwa yasiyoambukiza. Maanake hapa ni kutoka katika bajeti ya serikali, lakini wadau wakiendelea kutusaidia. La tatu ambalo tulikuwa tunajadili ni upatikanaji wa bidhaa za afya na dawa, na kama bara Afrika sisi ni waingizaji wakubwa wa dawa kutoka nje ya nchi na sio wenyewe wazalishaji. Kwa hiyo miongoni mwa mambo ambayo tulikuwa tunakubaliana hapa ni kuona ni kwa namna gani tutafanya uzalishaji wa ndani na uwezo unapojengeana uwezo ili hizi dawa na bidhaa zingine za afya zipatikane kutoka. Lakini la nne ambalo la mwisho katika mimi ya rekodi ni umuhimu wa kufanya tafiti na usimamizi wa takwimu za afya, kwa sababu fedha, mikakati na miradi mingine yote inategemea kuwepo kwa takwimu bara, kwa sababu ndio zinakwambia kumbe kuna wagonjwa 10, inatakiwa basi kuwe na wagonjwa 10 ili mikakati yako ipange kwa ajili ya wagonjwa 10. Kama hauna takwimu imara, unaweza kusema kuna wagonjwa 10 lakini kumbe kuna wahitaji 100. Kila wakati unapokuwa unapanga mipango yako utashindwa kufikia malengo kwa sababu hakuna takwimu zilizo. Kwa hiyo haya ndio mambo makubwa manne yaliyokuwa yanajadiliwa.
Asante. Sasa wewe naomba usie kwenye masuala ya 10+, kwanza kuelezea 10+ ni nini, alafu pia hiyo expansion plan ya Tanzania.
Asante, sawa. Asante kwa kuniuliza. 10+ ni mkakati wa utoaji wa huduma kwa wagonjwa ambao wana magonjwa yasiyo ya kuambukiza ambayo yanahitaji huduma za kibingwa, lakini wanapatiwa hizi huduma kwenye ngazi ya wilaya. Kama tunavyojua kwenye mfumo wetu wa utoaji wa afya, hospitali za wilaya ndio ngazi ya kwanza ya rufaa. Lakini kwa sasa ambavyo huduma zetu zipo, hizi huduma za wagonjwa ambao wanahitaji huduma zaidi za kibingwa huwa zinapatikana zaidi kwenye ngazi ya mkoa, hospitali za mkoa na hospitali za kanda na hospitali za kitaifa. Kwa hiyo kilichokuwa kinatokea, hawa wagonjwa walikuwa wakihitaji hizi huduma, wakifika kwenye hospitali za wilaya wanaandikiwa rufaa kwenda kwenye hospitali za mkoa na hospitali za kanda mpaka kufika hospitali za taifa. Changamoto kubwa ilikuwa inaonekana ni kwamba hawa wagonjwa aidha kutokana na hali za afya ambazo wanakuwa nazo ama kutokana na uwezo wa kiuchumi wanakuwa wanashindwa kufika kwenye zile hospitali za ngazi ya juu kupata hayo matibabu. Lakini pia magonjwa ya kuambukiza ni tofauti na magonjwa ambayo ni ya muda mfupi. Kwa hiyo ufuataji huo wa huduma wa kila mwezi kwenda kwenye ngazi hiyo kutokea mtu anapoishi ilikuwa pia inakuwa changamoto. Kwa hiyo NIMR kwa usimamizi wa Wizara ya Afya tumekuwa tukitekeleza utafiti kuangalia kama tukizishusha hizi huduma kwenye ngazi ya wilaya na kuwafundisha wataalamu ambao wako kwenye ngazi hiyo, lakini pia kwa kupata usimamizi wa karibu kwa wataalamu wabobezi ambao wanatoka kwenye ngazi za juu za hospitali, tutapata matokeo gani. Kwa hiyo tumetekeleza huo utafiti na tumeweza kufuatilia hawa wagonjwa kwa muda wa miaka 2 sasa, na katika matokeo ambayo tumeona ni kwamba wale madaktari wa pale kwenye ngazi ya wilaya wameweza kutoa huduma vizuri na wale wagonjwa wameweza kupata huduma zao vizuri na wamepata matokeo mazuri kama ambavyo wangepata zile huduma kwenye ngazi ya juu ya huduma. Kwa hiyo tulichojifunza ni kwamba tuna uwezo wa kusambaza hizi huduma kwenye hospitali zote za wilaya nchi nzima, wakati tunaendelea kujenga uwezo wa wataalamu wetu wa afya, kwa sababu hatuna madaktari wabobezi kwenye kila fani ambao wanaweza kuwepo kwenye hospitali zote. Kwa hiyo kwa kutumia wale ambao wapo kwenye ngazi za juu, aidha kwenye hospitali za mkoa ama kwenye ngazi ya kitaifa, basi wale madaktari wanaweza wakasaidia kwa kuwapeleka kufanya huduma za usimamizi, wakati hawa ambao wako kwenye ngazi za chini wanatoa huduma. Imetusaidia kuhakikisha kwamba wagonjwa wengi zaidi wanapewa hizi huduma, lakini pia hata idadi ya wagonjwa wameongezeka ambao wanaenda kupata huduma kwenye zile hospitali za wilaya. Lakini tumeona kwamba tumeweza kupunguza rufaa kwa kiwango cha zaidi ya 80%. Kwa hiyo vile vile kuweza pia kupunguza matumizi ya pesa, ambayo kwa sababu matumizi ya pesa kuna yale ya hospitali, lakini vile vile yule mgonjwa kwenye kusafiri anapoenda huko nje ya mkoa, kuna baadhi ya gharama ambazo anakumbana nazo ambazo ziko nje ya, hata kama ana bima ya afya, ziko nje ya ile bima, yani vitu ambavyo vinalipiwa na ile bima ya afya. Kwa kufanya utafiti huu na kuihakikishia serikali yetu kwamba hichi kitu kinawezekana, tumeweza kuonyesha na matokeo yamepokelewa vizuri, na sasa tuko kwenye mchakato wa kuhakikisha kwamba tunachambua vizuri yale matokeo na kuja na mpango mkakati wa kinchi kuweza kuhakikisha huduma hizo zinapatikana nchi nzima kwa hao wagonjwa ambao wana magonjwa yasiyoambukiza ambayo yanahitaji huduma za kibingwa. Na mara nyingi haya magonjwa huwa yanaathiri watoto, na magonjwa haya kama tulivyoambia kwenye mkutano huu ni kisukari aina ya kwanza, magonjwa ya selimundu, lakini vile vile magonjwa ya moyo yanaitwa rheumatic heart disease. Kwa hiyo hawa wagonjwa wapo, kuna ambao wanatoka kila mwezi kutoka mikoa yao kuja kupata huduma huku juu kwenye level ya hospitali za kitaifa. Kwa hiyo kupitia nafikiri matokeo haya, basi tutaweza kuwasogezea hawa wagonjwa hizi huduma mahali pao wanapoishi. Kwa hiyo ningeomba tumalizie ungemalizia tu mara moja.
Good afternoon, and apologies for the late start. We had to accommodate the media briefing here. So we'll start with our parallel sessions, the country experience sharing, and I'd like to introduce our moderator in the person of Dr. Joseph Moga to moderate us through this session of country experience sharing. Thank you.
Good afternoon. Hope all of us have had some good lunch and we are ready to restart the program. This session is when you look at your program, it is session is round 2 of country experience sharing. We are going to look at some of the countries that are implementing Pen Plus, they will share the experience. This is basically a perspective from the Ministries of Health. We've lined up for you initially 5 countries, but Tanzania's case was already presented. So we have Liberia, Uganda, and Ethiopia. So I will request the Ministries of Health officials from the 3 countries to come up here, and they will make their presentations. Then thereafter we'll have a quick Q&A. As they walk up here, we have from Uganda, Dr. Frank Mugabe. From Liberia, we have Jemseta, Miss Jemseta. From Ethiopia, Mr. Adisu. You are welcome up here to take your seats. And the representative from Sierra Leone. Yeah, Sierra Leone. Yeah, you're welcome. Yeah, so as a way of introduction, we are reminded that Pen Plus implementation, as you look at it in the operations manual of Pen Plus, has about 5 phases of implementation. So these 5 phases are basically what countries go through. There's initial stage of capacity assessment, and then that's phase 1. Then the second phase of putting the service delivery model in place, developing the protocols and all the necessary ingredients for implementation. Then the third phase is a pilot phase usually. And then the fourth phase is a scale up or implementation. And then the fifth phase is country national scale up. And as you can see, out of the 20 countries implementing now, 15 of them are in phase 4. That is a scale up phase. And the 4 countries you see up here, they are all in that 4th phase of scale up. So we want to hear really their activities they are doing, their achievements they have made, the challenges they are facing, and thereafter we can have questions for them. So without much ado, I may call the Minister of Health Officer from Sierra Leone to give his presentation. And we have 10 minutes. We are really time strict this time. Thank you. Please, you're welcome to share the case of Sierra Leone.
Good afternoon all. Kindly can they put up the slide? Again, good afternoon. I hope we all enjoyed our lunch. I'm Michael from the Ministry of Health, Sierra Leone. I'm also the coordinator for the NCDI network in Sierra Leone. And we are here as a team. We have Dr. Sarah from Quam, Dr. Batran, and Dr. Elias from PIH. Next slide. Yeah. So basically, Sierra Leone is a small country. We are located along the west coast of West Africa. And again, Sierra Leone is divided into 5 regions and 16 districts. Our health structure is also divided into 3 phases, which also includes the PHUs, which are the peripheral health units, as well as the secondary hospital, which are districts, as well as the referral and tertiary hospital. And again, also as a country, we have gone through a lot. Sierra Leone has gone through war, civil war for 10 years. Again, also during the Ebola saga, we are also a victim, and as well as mudslide, and again, also poverty. But notwithstanding, as a country, we are always striving. The journey about Pen Plus basically started in 2019 when we set up the NCDI Poverty Commission. With this commission, the formation of the commission, which is a multi-sectorial commission, which involves other line ministries, as well as civil society and NGOs, and again, also the UN agencies. After 2019, when we set up the NCDI Commission, again, also the Commission thought it fit to do a research, to have a first-hand based information about current trends, risk factors,
of NCDs within Sierra Leone. With that document, which we basically call the Sierra Leone Non-Communicable Diseases and Injury Commission findings and reports, with the recommendation, we realize that there is urgent need or call for the Pen Plus establishment in the country. In 2022, Sierra Leone Pen Plus journey started. Next slide. So for us in Sierra Leone, as I do mention, this is the map of Sierra Leone. Currently, we have two key partners as I introduced the team. Pen Plus is being implemented in two major districts currently, one which is in Kono, in the eastern parts, operated by PIH, and then in Pujong district, operated by Kwam. These clinics are doing exceptionally well. And if you can look from the map, you will see that there is urgent need for the scale up, which will be supported technically and financially with WHO and is going to be implemented by the Ministry of Health. These will be the new sites in blue, which are in Cambia up north, and again, Moyamba down south. Next slide. So, as a country, we have developed the National Operational Plan, but we know you cannot develop that document without costing it. So as I'm speaking, we are at the final stage of the costing, and come next month, we'll validate and launch that plan. So, and again, also in Sierra Leone, we also have a strategic document, which is the NCD strategic plan, but in April this year, that plan has expired. So we are currently reviewing it and updating it. And again, also, as a country, we have been supported with so many colleagues from the regional advisory team on harmonizing our Pen Plus training package, which will serve as a tool that will be used in the context of Sierra Leone perspective. And again, also, as I mentioned, come next month in July, we'll also be validating and launching the operational plan. And again, also, as I said, for the new sites, which will be opening come maybe by end of this year towards early 2027, an assessment, needs assessment was conducted with support from WHO and again also with collective collaboration, partners in health and Quam were in lead, again also in supporting us in conducting those assessments. Next slide. So for trainings, we have been having lots of various training. As you can see, we always have weekly clinical continuous medical education as well as continuous development training with clinical staff. And again, also we have also trained medical officers, community health officers, nurses on diagnosis, management, and related emergency linking to NCDs. And again, also we support again from PIH, the staff was sent to Kenya, which we train on echo diagram. And that staff again, after completing that training, cascaded that training again to 10 other staff locally. And again, we've been training our laboratory staff to see how best they could be interpreting the results for HB1 sickle cell and full blood count. And again, also our community health workers, the CHWs, you know, they have been contributing a lot in helping to identify and again also creating an awareness and referral for our community people, which they see as of high risk towards NCD condition. And again, also with the Pen Plus project, it's more or less like an introduction part of data collection on EMR, the electronic medical records, because for Sierra Leone, it's not common. But with the Pen Plus project, that again has yield some progress, which we train both M&Es and as well as the data collectors and all staff operating within the Pen Plus clinic. And again, also with the Pen Plus project, we are using the peer educators. You know, they say who feels it, knows it. So we have been using it for sickle cell and diabetes, and again also doing training for social workers, because we know with NCD conditions, you need so many psychosocial support again. Next slide. So for our indicators, the Pen Plus, what we have done in Sierra Leone, we have included it quite recently within this year. We thought it fits that because the indicators were very, very limited. So we tried to incorporate the Pen Plus screening follow-ups into the DHIS to see how best we could have more indicators, and again to have improved data to see how best we could be addressing our conditions on NCD. Next slide, please. So these are just summary of what we have been doing. As I earlier mentioned, we as a country now we have already developed the NOP, which we will validate next month with the costing attached to it. And again, also we try to harmonize the training manual to adapt into Sierra Leonean context. And again, also Corridor Hospital, which PIH is operating, we are also trying to use that as a training hub for all NCD condition. Moving forward. So next slide. So for the site implementing, as I earlier mentioned, PIH is operating in the east, which is in Kono. So they are operating at the main referral hospital, which is Koidu Government Hospital, plus extra 5 peripheral health units, which it's more or less like a urban spokes approach. And again, also Kwam, they are operating in Pujol in the southern part, and they are also supporting 7 PHU within that district. And again, also, these are the 2 potential clinics which we will be opening, Cambia and Moyamba. And again, also, it may impress you, the Pen Plus clinics, they are going beyond Sierra Leone. For Pujong, they are receiving even patients from Liberia. And quite recently, for PIH, there was a patient, they are receiving treatment for cardiovascular issues from Ivory Coast. So it moves beyond. So next slide. So these are some of the patient enrollments since we started the project in 2022. For now, for Partners in Health, they have recorded 1,309. And again, also, you will notice for the health workers trained, it's over 70, which include medical doctors, the community officers, as well as nurses. And again, also, even admin staff, admin to see how best we could navigate operation properly. And again, also for data collection, as well as the social workers. So about 70 of them have been trained within the 2 sites. Next slide. So this goes for Kwam. Again, also they have enrolled 520 patient enrollment, and again also they have been doing very well in terms of training various cadres of health professionals in their site. Next slide. So for our challenges, we with all the success being said and done, we still have issues. There are still stockouts, because of the high cost of NCD drugs, and we know they are lifelong issues. So what we are doing to mitigate this is to see how best we could focus on how drugs and reagents tracking is being done within the central medical system. Again, also improve communication with pharmacy clinics to see how best they could be chipping in for cost recovery approach. And again, also patient social challenge, which is becoming an issue for loss to follow up. And again, with that, we have been seeing how best we could be doing social support in transport reform, education for kids with sickle cell. And again, also, we see we have limited skills, which has to do with knowledge and confidence in managing severe NCD. We know there are issue of human resource gap, which also affects the occupation of employees in week. And again, also the issue about government support. You know, there's lots of investment within the system now to see best how we could improve the services of NCD in Sierra Leone. And again, also, we are looking at scaling up. We only have 2 functional clinics for now, but come the last quarter of this year, we'll see how we set up 2 new clinics, which are the Moamba and Cambia. And again, also the issue about low public education. That one is very, very serious. As they always say, people suffer because of lack of knowledge. So we are using the district health management team, local authorities to see how best we could improve on that so people will start aware. Next slide. So our priorities is to see how best policy and strategy are implemented. We are developing lots of policies to see how best we can integrate them, support the MOHN to see how best we will develop more gains in towards implementing pen plus activity. And again, also the scale up. One approach we are using for our scale up is integration in Sierra Leone. Integration because we believe for us to achieve the universal health coverage, we need to tap into other resources because accessing funds or resources is very challenging in Sierra Leone for NCD management. So that's why we believe in integration and other approaches will gain success in it. So next. These are photos from our various training and integration project. Next. And again, also doing our public education, approaching schools, and again, also using radio, and that's again also an exchange program, which we also did with French-speaking African country, visiting the site in Koidu to see how best they could learn and see how we could improve services towards that. So these are the assessments as well as the integration of Pen Plus into the DHIS. We see Dr. Fassad, who was online. He was the one leading that one from WHO. So I thank you all, and I thank you.
Thank you very much. We can see some good work going on in Sierra Leone, over 1,300 patients on care. The planning process is going on. You're launching your plan in July. Good luck. I think things are going quite very well in Sierra Leone. Also the partnership, Quam and the government. So that is really great work and an example of how we can push Pen Plus forward. So I think we now come to the next country, which is in phase 4 of implementation, that is Liberia. And we are glad to have Demseta here, who is the director for NCDs at the Ministry of Health. She will share with us the story of Liberia. You are welcome, Demseta.
Good afternoon to all. I will be sharing with you Liberia's experience. By way of introduction, I'm James Smith, the Director for NCDI, Ministry of Health. Next slide, please. So while we are trying to roll this slide, Liberia is located in West Africa. We have 15 counties that are subdivided into 98 health districts. And the burden for NCDI in Liberia has increased over the period. And currently we have a disease burden of around 38%, and of which 60% of our cases of hospitalization contributed to attributed to NCDs, and 43% of all deaths are also attributed to NCD cases. So looking at all of these burden on our country with a population of 5.2 million, it is concerning as the Ministry of Health to be able to take corrective action. So currently as a country, we are implementing an integrated PIN and PIN Plus services to be able to address the disease burden for NCD. Between 2022 and 2025, our health management information systems have reported a total of 40,751 cases for just hypertension and diabetes. And just to further emphasize, for our pool pen services, we have it across all of the 15 counties. Specifically for Pen Plus, we have enrolled 90 patients between 2022 to 2026. In terms of our operation site for Pen Plus, we have scaled up from 3 sites to 7 sites, and our current scale up is in 2 counties where we will be providing services to a catchment population of 229,990. If you look at the map, sorry, I don't have a pointer just to point out our scale-up site. The area in yellow, Lofa, is our scale-up site. Next to it in blue is Bone County, our 2 new scale-up sites. Yes. So for our PIN Plus focus, we continue to emphasize on community engagement and awareness, which is key, as well as early detection, linkages, and follow-up. We also want to improve our standardized protocol-based management to ensure that health workers have protocols that can be used across all of our sites. We focus on strengthening our data for informed decision-making, as well as building capacity, ensure we have diagnostic and medication, as we intend to scale up to 12 of our remaining counties. Yes. So looking at the mapping and engagement of our partners, we want to emphasize that we have a very strong multi-partner collaboration in Liberia for our PIN and our PIN Plus implementation. And just to list a few, just to list our key partners, we have WHO that are supporting the national coordination, as well as providing technical support and financial support to scale up PIN Plus. We also have Partner in Health, our pioneer implementing partner who started this journey, and we have learned from that, and we are scaling up. They also support us in terms of our national trainings. We have Clinton Health Access that are also implementing in one of our counties. We have Counter United Methodist Hospital, supported by the World Diabetes Foundation. They are implementing PIN in 14 of our 15 counties. We also have support from Life for a Child, and specifically for type 1 diabetes. They are supporting us in 2 counties. We have a new implementing partner, IECD, supported by Sanofi, implementing PIN in 2 counties. And we also collaborate strongly with CONSA, and they are mostly focused on newborn screening, and they have supported us to develop our community health manual for community health workers, specifically focused on sickle cell. And the AMP Health contributed to supporting us to develop our national policy and strategic plan. We continue to strengthen our collaboration through an established technical working group meeting where we ensure that all of our implementation are harmonized for scale up. Next. So looking at national strategy protocols and guidelines that are in place, we recently validated our national operational plan, and we intend to launch. We are developing a national PIN Plus strategy. We also have standardized clinical protocols because we want to ensure that clinicians have protocol across all of our sites that are harmonized and for consistency in implementation. We also have our national training curriculum that we adapted from the NCDI Poverty Network as well as our protocols. They were also adapted from the NCDI Poverty Network. And as a country, we have developed our PEN guidelines that have been disseminated and in use across all of our PEN sites. Next. For capacity building, we have established as a country a national PEN Plus training center where we have master trainers to support us as we intend to scale up. We have also been able to orient 10 specialist doctors. And the essence of orientating these doctors is to make them to understand that we are not creating doctors out of the male-level health workers, so that they understand that it's a partnership and they need to contribute to mentorship. So with that buy-in, we have 2 designated specialist doctors that are currently serving as mentors. We also had an orientation for 80 health workers from our 4 new PEN Plus sites. And that orientation was intended to have a clearer understanding of PEN Plus so that they know it's part of the integrated services that will be provided. So basically, those from the health facility were drawn from all of the departments, including the labs, the pharmacists, and even administration, to have a clear understanding of PEN Plus in their facilities. So our national master trainers that were selected, they are currently ongoing training with technical support from the NCDI Poverty Network. We continue to tap on their resources to strengthen our PEN Plus program in Liberia. We have provided foundational training to 15 clinicians across our new scale-up site. We continue to emphasize mentorship and to also strengthen our peer education and follow up at the community level. Currently, we have 2 returning cardiologists, which is a plus for us as a country because they have committed to supporting our PEN Plus mentorship. Thank you. Next. In terms of our key PEN Plus indicator and our routine M&E framework, we have integrated PEN Plus indicator in our national DHIS tool, as well as our HMIS in our routine M&E framework. So these are priority indicators that we identify, and we believe that once we have information based on these indicators that we have outlined, it will help to inform programs decisions. Next. So a summary of our protocol, standards, training programs, as well as medication. So we have a standardized protocol-based management that have been integrated into our health policies and strategies, especially our EPHS, Essential Package of Health Services tool, and our national NCDI policy and strategies. We have included the national standardized protocol management approach for our severe NCDs in our recently validated operational plan. In terms of our training programs, we are yet to finalize our curriculum for training of health workers, but we have training manuals or materials that we adapted from the Poverty Network that we use to provide training. We have essential medications and basic technologies in our district facilities that are implementing. And as a country, we have a system for collecting our mortality data on a routine basis. Next. So looking at our number of implementing PEN Plus in our country, number of sites, we want to re-emphasize that we have 7 sites. Of the 7 sites, 1 of them supported by Clinton Health Access with fundings through the NCDI Poverty Network. Partner in Health also support us in 3 sites with fundings from the Poverty Network. And we have WHO that is supporting us in 4 of our 7 sites. So for area of support, it cut across all aspects of the Pain Plus strategy, including service delivery, workforce, in all aspects. WHO, they provide policy guidance and technical support oversight for our implementation. So with WHO, we are strengthening the county health team to implement Pain Plus, where we provide them guidance and support. Next. So looking at our numbers of enrollment, we've enrolled a total of 90 patients since our Pain Plus scale up. And looking at the table, it gives us this aggregation of the cases for sickle cell, diabetes type 1, and rheumatic heart disease. So specifically for our health worker trainings, we want to emphasize that for medical doctors, we are not actually doing training, but because Pain Plus is new, we capture orientation as training because they go through an orientation to understand the entire Pain Plus package. So for that, we consider it a training. Specifically, we focus on the male level health workers, and we have trained 34 male level health workers. And interestingly, in our country, because we try to contextualize Pain Plus, we also have physician assistants that are also supporting us. Looking at the numbers for administration, it provides a total of staff across all of our Pain Plus sites that receive orientation in the Pain Plus program. Next. So for our challenges, which is not unique to just Liberia, but I have seen it being flagged across all other countries' presentation, we emphasize human resource shortages because we know that Pain Plus is new. We have not really trained our workforce to be able to implement. Our infrastructure were developed before we initiated Pain Plus, so we are struggling with space. We have limited specialist support. Our NOP, we need to launch it. It has delayed, and once we launch it, it will be widely disseminated. Limited funding is something that we cannot overemphasize because to implement Pain Plus, to ensure services are readily available and sustained, you need funding. Diagnostic equipment and reagent shortages, limited awareness and sensitization about Pain Plus services. Not only the services, but the community ability to identify this condition and be able to report at the facilities. Delay in our DHIS2 and HMIS rollout. Even though we have integrated our Pain Plus indicators into these reporting systems, but for my country, it was just this year we started having a standalone NCDI reporting tools, and that dissemination started in March. So as part of our mitigation, we want to strengthen our data system to ensure that our reports are of quality to inform programs. We also want to have a robust awareness campaign, which is very key for early detection, where we work with the community health workers and persons living with this condition to provide awareness. We also want to advocate for dedicated national resource mobilization for sustainability. Next. So as part of our priorities for 2027, we have a very big goal to scale up to 6 additional countries. We want to achieve our target, and we know that with this mindset, we will achieve it. We plan to launch our NOP and be able to scale up operation in our 6 counties. We want to finalize and implement our Pain Plus strategies. We also plan to do training for health workers. We continue to strengthen our Pain Plus training center and mentorship program. As we all know, Training alone is not sufficient. There should be continuous mentorship for our male-level health workers to ensure there's proficiency. We also want to strengthen our reporting systems. We want to ensure that we have medication diagnostics available through our existing government structures. It should be included on our essential medicine list. And doing supply chain quantification and forecasting, we also want to ensure that NCD commodities are considered. Improving access to diagnosis is also key in our referral system, as well as having specialists to support our nationwide scale up. Last but not the least is to strengthen our domestic financing, which is very critical for long-term sustainability in services. So I conclude by saying PEN Plus is not a project, but it should be embedded and integrated with all services that are available in our country. Thank you.
Thank you, James Seta. That is a very good way to close strengthen domestic financing. I think that speaks the strongest. And I think it's exciting you've been able to scale from just 3 to 4 additional facilities within a short period of time. That was very impressive. And of course, also the number of partners we have is quite significant. 8 partners, I can see. That's very good. And I think we deserve a round of applause for that. The next presenter is from Uganda, Dr. Frank Mugabe. This is one of the countries that also is in the scale-up phase. They are also quite doing very well in the 10 plus journey. So Dr. Frank Mugabe is at the helm of things at the Ministry of Health for NCDs. So Dr. Frank, you're welcome to give us the Ugandan story. Thank you. He has also been the TB manager for Uganda for some time, so he knows chronic care very well.
Thank you, Joseph, for that kind introduction. Good afternoon. Are we awake? Okay, thanks, Tarot. So I'm going to share with you the current achievements and challenges for Uganda. I believe you know where Uganda is. We're in the north of Tanzania, the west of Congo, and I think the east of Congo, and the west of Kenya, and the north of Rwanda, and the south of South Sudan. We have a population of about 47 million. We are a small country with about 2,400 square kilometers or something. So we are small but highly populated. And we are a very active country and very beautiful. So you are free to come to Uganda. We started implementing PEN Plus in 2022, but that was after the Poverty Network Commission that was done. Uganda had a privilege of participating in that commission. And as you know, the focus of PEN Plus is on severe chronic NCD conditions, which in Uganda were largely provided for in the referral hospitals, regional and national referral hospitals. And some of these conditions, as you know, they include type 1 diabetes, sickle cell disease, congenital heart diseases, and chronic respiratory disease conditions. And you also know that there was limited access to these services, as I have stated, and there was a need to decentralize in order to improve the quality of care and to preserve life for these vulnerable populations. Currently, we are implementing the 2 general hospitals with a lot of appetite to expand to 22 facilities. Next. So what are our program objectives for PEN Plus? We strengthen quality of clinical services at PEN Plus clinics and building on the previous project cycles. We prioritize training and mentorship. We have established a robust training system, longitudinal mentorships, leveraging on mid-level providers, the medical officers, clinical officers, nurses, laboratory assistants, and others. We are working on planning and policy, where we have developed the Penny Plus strategy, and we're also working on integration of this in the national NCD strategies. Next. So we have been able to mobilize a number of partners, local partners and international, to participate in this effort, led by the Ministry of Health, which provides technical and leadership. We have a technical advisory committee headed by the Commission on Non-Communicable Diseases, and we have also a steering committee headed by the Director of Public Health, who represents stock management, and the number of decisions that are made at these different levels, both technical and guidance decisions. We have World Health Organization, which has supported assessments, has supported review of training materials, and also provided technical guidance on and whenever it's required. We have been able to mobilize disease experts from our National Referral Hospital, our Centers of Excellence, Uganda Heart Institute, Makerere Lung Institute, and these have showed that most of the capacity building, training, clinical mentorships, and also supported the mobilization of resources, especially the Heart Institute for the children who have needed surgeries. We have been able to get some subsidized surgeries. I can proudly talk of 18 surgeries performed, which would have not been possible without this kind of intervention. We have chai, you know chai. The other day we had a presentation about chai, and we're enjoying what chai is doing in Uganda, both for pain plus and pain conditions. We have seen our commodities for hypertension and pain, hydroxyurea and others, their prices come down, which we are not failing to achieve using our national procurement systems. Next. We have CDIC. CDIC had a session here. I was happy to see the SONEA team facilitating in a session. They have helped us to provide most of the insulin that the children have required and the glucometers. And of course, this has improved the access to care. And we have also been able to work with them to form patient support groups. In Uganda, because of certain challenges, we encourage NCD patients to come into groups to mitigate some of the challenges that they face, whether for pain or pain plus. We have our central public health laboratory that it has scaled up sickle cell screening. So we are able to screen, and we hope that in the next step will be to confirm, confirming the screening positive for sickle cell. The host districts, these ones have helped us in implementing ownership of the Pain Plus and also shouldering the data reviews and performance reviews where these hospitals are hosted. I hope we are also seeing some of the pictures that are showing some of the work. Next. So, regarding the national action plans, national strategies, we have posted our national operation plan, and that is tentatively how it's looking like. And we have also been able to do it through a multi-sector consultative framework. We received very useful technical contributions from most of the actors, and this has been largely led by the Minister of Health, by the focal person who happens to be myself. And we are looking forward to submit this costed plan to the top management next month for the requisite approvals. Next. So capacity building, a lot of work has been done in capacity building. From the word go, from the time we started, we had, for starters, we had the clinical guidelines, we had the cascaded models that that we have prepared, and continuous mentorship. And in this, we are able to achieve decentralized clinics to establish at the two facilities. We have had competence-based trainings which have improved the confidence to manage and diagnose some of these semi-complex conditions. And the things have been standardized. At least our health workers, they know what to do. They are confident at the diagnosis, treatment, and they know where and when to refer. We have had work done in the policy shifting, specialized task shifting, and this one was demonstrated by the people we trained. In Uganda, previously, some of these services were reserved for physicians and other disease experts, pulmonologists, but today, clinical officer and the medical officer can really do this work. And this one has been made possible by the training and the protocols and regular mentorships that have been conducted. We are working towards the universal health care and integration, and we believe with more support we shall be on course. Surveillance systems have been put in place, and we believe that with continuous decentralization, we shall make progress in this area. We coming to the indicators, like I presented some time about integration, we are digitalizing the medical records as a country, and we are not leaving behind the pain plus conditions. So we are working on electronic medical records and digital register integration, and the pain plus conditions and indicators are being integrated in this. This is a process that we started some time actually before even the digitalization came. And we are to the forefront working with the NCD to make sure that this is achieved. You can see a picture of a health worker using Reactor, which is an electronic medical record in a hospital. So far, the general hospitals and the below health center are already equipped with electronic medical record, and we are working towards the world. Like I alluded, we have two implementing sites that I can say are fully functional at 100%. We also have a facility, Rural Hospital, where we trained. We did an assessment and trained, but for some small reasons it has not yet taken off because we are lacking a few basics. And like I said, we are eager to expand to many more hospitals, which we have already earmarked and mapped in relation with where they are and the disease burden that are there. And we are piggybanking on the national operation plan to be able to do this. These are the numbers. Unfortunately, we have very high numbers. I've seen the countries presenting their numbers with many treatment sites, and our numbers are really high. When you look at sickle cell, they are not, we have a very high burden, a sickle cell. Because the trait alone is at 13%. Then those with sickle cell at 0.7%. So when you apply on a 48, 47 million, you know what I'm talking about. So you can see by March 2026, a total of 2004 for sickle cell alone, type 1 diabetes 206. This is only for the pain plus sites, the two. It doesn't include the wear, I must emphasize. And rheumatic heart disease 16, congenital heart disease 58, because people are actively looking out for them. Before that, we didn't know that we had a lot of congenital heart diseases. But thanks some of our experts like Dr. Judith, who is there, she has been really a champion. You can even stand up for recognition. She has championed this. Most of these congenital heart diseases, we really didn't know that you were there. And imagine these are being picked by the mid-level and confirmed by our cardiologists during using devices like those echo machines. We have started on the hunt for those cardiomyopathies. So far, two have been picked in 2026. Asthma, COPD, you can see severe hypertension, severe diabetes in a spirit of pain plus. The insulin-dependent diabetics, adults, we're also giving them priority. We are not leaving them behind. Next. The health workers trained. We have not trained many because we are at two sites. We have not included the well trained. We are talking about Atura and Nakaseke, 50 of them. And the peak of the training is 2023. And we have a multidisciplinary cadre that we are trained. You can see we have 8 medical officers in total. We have 10 clinical officers, 13 nurses, other professionals 19, and these total have 50. About 37 of these are very active in this clinic. Challenges. So the challenges are similar to those that have been stated by others, but we have a bigger sickle cell disease burden. We would want to do more on prevention than waiting to diagnose, because it is catastrophic to continue to just wait to diagnose them. And that's why those screening programs have come up. I've heard of stock out of medicines. We also suffer from the same. Delayed access to blood transfusion was an issue that we have tried to mitigate. Financing, we suffer from limited financing and the challenges of community fora. And on this forum, we are showing what has been done. But it requires much more advocacy and much more commitment. And we call upon, of course, our government and the well-wishers to bring more resources. These interventions are resourcing things. They are not a joke. My last slide, next. So these are our priorities: mobilization of resources, scale up, and we are piggybacking on the NOP. There were some good news from UNICEF. We shall follow up that. We want to accelerate integration of the indicators. We want to improve our advocacy so that we get more medicines. We want to strengthen multi-sector partnership at lower level capacity, so that we continue to expand and strengthen the patient-centered and community-based models, including follow-up and psychosocial support, to enhance monitoring and evaluation. Thank you very much.
Thank you, Dr. Frank. That was very good, a good story, but we unfortunately have very short time, so we have to to speed you up a bit. So we are left to one presenter. That is Mr. Abisu from Ethiopia. You are welcome. We have only 10 minutes to share the story. Then we shall have some time to.
Good afternoon. Thank you for having a chance to present Ethiopia experience on PM Plus. My name is Ajisu. I am from Ministry of Health, Ethiopia. Just to give you overview country of Ethiopia, we have almost 1,000 million population nowadays, and almost 40% of the population is under 15, and there are 15,000 health posts, which is close to the community, which engage in health promotion and awareness creation activities. And we had also 4,000 health centers. They are also close to the community, and they are engaged in screening and other diagnostic activities. There are almost 400 hospitals. Out of these, almost 300 are primary hospitals or district hospitals, which are eligible for PM Plus implementation. Our life expectancy is almost close to 17 years, so we are at risk of NCD. And we had 12 regional and 2 city administration, the country organized in this way. The next plus, thank you. When we come to the healthcare tier system, we are 3 healthcare tier system. There is a tertiary level, there is a secondary level and primary level. This is based on type of service provided and the population served under this. And the PM Plus is under the primary hospitals. So we implement PM Plus at the primary hospital level, which expected to serve for 1,100 populations. Next, please. When we come to the disease burden, Ethiopia faces triple burden of disease: communicable, non-communicable, and injury. Almost 52% are due to injury and NCD. Among them, NCD account for almost 43%. Of all of them, cardiovascular disease is the leading cause of mortality in the country, almost shares almost 42% of the causes due to NCD. There is also neoplasm, almost it is 17%, which is cancer, especially cervical and breast cancer is the commonest cancer in Ethiopia. And there is also diabetes also account almost 2% of the population are suffering from DM. It's almost 2.5 million are now living with diabetes. Next, please. So when we see the partner mapping and engagement in PM Plus, it is start with the engagement of the government. There is a government Ministry of Health, which this prevention and control lead executive is directly engaged in PM Plus implementation. There are also insurance and agencies which engage directly for implementation of PM Plus. And there are regional bodies, regional health bureaus are the one who implement PM Plus. There are also partners and UN agencies who directly involved or potentially involved for PM Plus implementation. NCDI Poverty Network, or the eye opener for the Ministry of Health, and they support a lot on PM Plus implementation. UN agencies, especially the WHO country office, are technically as well as financially support the PM Plus implementation. Align Tiwandi, UNICEF are potentially support NCD, and NCD Plus. And Africa CDC, AMREF is also plan to support NCD. There are also CEOs and academicians, especially Matheus Wandu Foundation. Mr. Wandu is here, the advocate for NCD, the I person for NCD, and he do a lot for NCD prevention control, especially on compacting tobacco. Previously, he is more engaged in breast cancer awareness creation activities and implementation. Nowadays, they are implementing PM Plus well. And there is also Ethiopia Diabetic Association, especially on pain implementation, they engage much more. And there is also Ethiopian Health Association, technically and as well as financial. And there is also medical college, universities, all the protocol development and other. And there are also researchers. All of these things are worked under the technical working group, which is technical working group established at the Ministry of Health, which is led by the Ministry of Health, and they are oversee the PM Plus implementation. Next, please. So when we come to the journey of PEN Plus implementation, it is go back to 2016 with NCDI Poverty Commission establishment. During that, the NCDI Commission assessed NCD condition and synthesized data on NCD. After that, the site level assessment, comprehensive site level NCD service assessments were done. Then the time-driven active-based posting was done in selected health facilities. Then PEN Plus clinic were established in 2 selected sites in 2 primary hospitals. Then the national operational plan developed, kick out, and in between the national plan launching and national plan development stage, there is site level readiness assessment have been done. Next, please. So when we come to the capacity building, almost 14 individuals or healthcare providers trained on PEN Plus, and 44 individuals were trained on PEN to support case identification and the referral. So the PEN Plus is more focused on type 1 diabetes, rheumatic arthritis, and there are also other conditions which are not included in this slide. And the training approach is also mentioned in our NOP, it is framework integration. So there is training condition based as well as the number of trained, the number of days to be trained is also already mentioned, already stated. So the training were provided as per that standard. So there is also initial training for PEN Plus sites. So this is the center of excellence or the center of hub to provide or to scale up the training. And most of the trained persons are from Ministry of Health dedicated staffs at the facility level. We didn't set another staff to get training. So the training are from facilities which is dedicated by the government. There is also mentorship. So there is certified master trainers who can engage in continuous mentorship and training. So when you come to the numbers, almost 805 individuals are enrolled to care and treatment for PEN Plus. Among them, 83 are active now. And people living with type 1 diabetes have access to home glucose monitoring. Almost 100% of them are access for that service. And all of them are optimal basal bolus insulin regimen. That is a good achievement. And the hemoglobin A1 greater than 8 is also 70% of them are good achievement in this area, and the clinical outcome maybe shows some great achievement. And the number of individuals who get cardiac surgeries are 10 children are get cardiac surgery. One of the challenging issue in the country is the availability of cardiac surgery. We have only one cardiac center in Ethiopia who provide cardiac surgery. I think there are almost 10,000 individuals are waiting for cardiac surgery, which is a challenging issue. Next, please. So when we come to the data management and implementation framework, we have the core restoration book, which is also implemented for PEN, and now we integrate PEN Plus in this standard restoration book. Every individual has unique ID, and it is interoperable with medical DHIS and e-tracker. So this is what we implement. There is also data system integration. We try to integrate in core restoration, and for the future, we plan to adopt simple app, and that maybe is an important thing. And we also propose DHIS indicators. So Ministry of Health now under revision of DHIS. So this is a good opportunity to include PEN Plus conditions or PEN Plus data elements into DHIS. We already proposed some indicators, data elements to propose to include to DHIS too. We had also done different data quality and reporting tools. The clinical audit, there is also standard clinical audit tool. So we implement for PEN Plus conditions. Next, please. So this is a launching of our national operational plan in 2026 in the presence of higher officials, Dr. Mekdas and the State Minister, Dr. Bijuma. And there is also other stakeholders, the engagement of which shows the engagement of different stakeholders. Professor Jean Buchman from NCDI Poverty Network, and there is also Professor Francis Casello from WHO representative of Ethiopia, and there are also other partners, and there is also Mr. Wondu, the founder of NCD in Ethiopia. Next, please. It is some indicators included in the operational plan. We plan to reach 150 facilities, and we also plan to access insulin for 33,000 individuals. And there are 10 facilities are already assessed, and they are eligible for expansion of scale up. Site level assessment were done, and now they are ready for scale up. And we come to the funding. Before we preparing the PEM Plus operational plan, we made a site level assessment. What we found during that is almost 68% of the facilities are their own equipment, diagnostic materials, and human resources. So we minimize our fund, and with the gap is almost 42%. So we fill to 42% gaps by government commitment, 40% maybe shared by the government. We plan to mobilize 32% from the partner, and there is also CBHI communities based insurance, and now there is also social insurance, and there is also inevitable out-of-pocket expenditures. So in general, our PEM Plus may cost around 63 USI. Yes. Next, please. So our potential partners, what I mentioned previously, is Online Tiwandi. They are our potential partners, UNICEF, and there are also partners engaged on pain implementation, World Diabetes Federation, CHAI, PDIC, and Life for the Child also engaged in availability of insulin, and some of the partners are already engaged in pain implementation. So we need some scale up for PEM Plus implementation. Next, please. This is the challenge, gaps, and mitigations. One of the challenge is limited health insurance coverage. So Ethiopia have a limited health insurance coverage. So the mitigation may integrate services into existing insurance scheme. So we must integrate PEM Plus conditions into existing health insurance scheme. The program reduce direct out-of-pocket patient cost. This is the ultimate goal, reducing the cost out-of-pocket expenditure. There is also funding availability versus huge needs. I think PEM Plus needs huge resource, but the gap is also huge. It is almost what I show in the previous slide. It's almost 42% gaps to implement PEM Plus. So we must advocate for increased domestic financing, what the country already done for other programs. There is also service with the national health financing mechanism. So we must strengthen the national health financing mechanism, and we must include in our operational plan, national operational plan, we must include PEM Plus conditions, and we must post and we must allocate budget for PEM Plus implementation. The other thing is complex supply chain. Actually, it is a challenge almost all of African regions. There is also a complex challenge, especially on quantification, forecasting, and availing. Most of the PEM Plus condition instruments are not in Ethiopia. So there is a challenging issue to have NCD supplies, PEM Plus supplies. Next, please. This is a priority area for 2027. The first one is scale up implementation. So we plan to implement PEM Plus in 10 health facilities. So this is the one we focus and we work on. The other one is coordination. So we must maximize resource coordination to effectively align all partners initiatives direct to our NO. So we must make alignment with our partners. So this coordination is one of the focus area. Some guidelines may be may need revision. And there is also plan to develop some training manuals, clinical protocols for healthcare providers. And we more focus on ensuring the availability of commodities. And the one what we more focus is data management system. So we already select indicators. So we plan to digitalize data capturing as well as incorporating the selected data element to the HIS2. What our motto is: if there is no mentorship, there is no training. So mentorship is the crucial one. Being providing training is not enough, so we must mentor. Thank you.
Thank you very much, Mr. Abishu. This is fantastic. And one thing about Ethiopia is the ambition. They planned 150 facilities by 2030. I don't know how many of our operational plans are of that target. That is really commendable. Big plans, and I think they will achieve it, given the way they have performed in the past. So really, I'm informed that time is not on our side. We have key events coming up. And maybe before they go, just one word. We have said so many things here. If you are to, there are many countries here that are planning to implement 10 plus. Can you say in one word what is the most important intervention they need to consider? I know you have said many things. Just one of you, one. You may not have enough time for discussion. So, Frank, what is that one thing that, if you want to advise South Sudan is here, they want to implement 10 plus, what should they do?
I wanted to advise myself. I think for Uganda, we needed to scale up because the people are there, they need the services. So that's what we want. And for South Sudan, if you have not started, my advice is that please start. We are willing to offer a platform for you to learn from. Please start.
Thank you. My word is I kindly request to integrate with existing system. PIN Plus is not a new thing. It is strengthening the service provision at primary hospitals. Thank you.
One key thing for me, government should take leadership and ownership of the PIN Plus implementation. You cannot rely on partners because the intervention need to be sustained, and it should not be treated like a silo intervention, but like he said, integrated in all service delivery.
And for us, Sierra Leone, our key goal and operations are partnership and collaboration. It has really yielded fruits. We see how what our partners are doing. Because of that, I would say there's vast improvement in the NCD services because of that strong collaboration and partnership.
Wow, that is good, really. Partnerships, leadership, integration, start. So I think, Jonah, I think we're almost through the session, unless we have one very burning question from the audience. Anyone? Yes. Since it's from a lady, we can't refuse. Please ask the question. The doctor from Tanzania, the lady in the middle there. Yes.
Hello. I guess, sorry, I know time is we're out of time, but my name is Dr. Nasra. I think you know me already. My question is to the Liberia. From your data, you said from 2022 to 2026, the PIN Plus includes 90 patients since for the 4 years, and estimated people with type 1 diabetes is 13K patient, but you only cover 50 patients of type 1 diabetes. So my question was, I've seen your priority is scaling up by 2027. So my question was, what is the main barrier? Like, for them to be covering all the 12,000 left patients to be covered in the Plan Plus services in Liberia, and the role of the government too for the Plan Plus review. Thank you.
Who do you want to ask? Liberia. Yes. The main barrier to scale.
Data. All right, so what I understood, let me just respond to that. So yes, we started scaling up since 2022, and the scaler was only in one county out of 15 counties. And in that county alone, we had our 3 sites. So currently, for last year, our scaler expanded to 4 additional sites. So that makes up to 7 sites in total. So in terms of our cases, yes, the figures may be low, but what I want to emphasize here, one severe NCD condition is an issue of concern. We see other countries having high cases, but looking at our country population of 5.2 million, if you even look at other countries just within their small district, it's our entire country. So if we are reporting 1 case from county or 2, is something of concern as a country, and we must take the appropriate action and ensure that we scale up so we can have early detection and be able to manage the cases on time.
Okay, I think that's good. We give a round of applause to the panel, and really we give you thanks for the good job that is doing. We have got back to the management. You are welcome to take your seats.
Thank you very much, Dr. Joseph and panel, for that excellent delivery. We have the final session, after which we'll have our closing ceremony, and that is oral abstract presentations. And to moderate the session, we have Professor Rubin Muta. Please, if you are here, kindly to moderate this session. Let's give him a round of applause, please.
Thank you, Madam Chair, for inviting me to moderate this session. So can we stand up and stretch a bit? I know we are tired, so some 1 minute only. Stand up, please. Good. You can sit up. Good afternoon. So we have 5 presenters for abstracts, and 2 are visual, 3 are present. May I call Dr. Bavin Mlenga to come in front? Bavin. Dr. George Msengi. Dr. Simon Pierre Boni. So other 2, Lulu Tian will be online, and Ablo Wachino Prudence will be online. So George, Bavin, and Simon, you come in front. Yeah, you can sit there. So we'll start with Bavin. Bavin will be presenting on decentralizing cardiovascular diagnostic services in Zambia through primary care training. You're welcome. Only 10 minutes, please. We are short of time.
Good afternoon. So my name is Bavin. I'm coming from Zambia, part of the Ministry of Health and the PENPAS program. We want to share a few results regarding the decentralization of echocardiography services in Zambia. So as you may know, cardiovascular conditions are the leading cause of morbidity and mortality globally, and even Zambia is affected. But then there's this problem of diagnosis that we have. So the situation in Zambia is that echocardiograph services are provided mostly at higher institutions, higher facilities, but not really at primary healthcare facilities. But then even in those primary healthcare facilities where they are provided, there are issues like there are no skilled or trained healthcare workers to do the echoes. And then also the children suffer because not everyone who's doing the echo will be able to do the echo on children. And then the other important thing is that the quality is also questioned because they did not receive any form of mentorship or continuous professional education. So through the PENPLUS model, we are privileged to train healthcare workers in echocardiography, the mid-level providers. These are the nurses and the clinical officers. Next. So through the PENPLUS, we had to train the PENPLUS providers in our 5 implementing sites. We got 2 per site, a clinical officer and a nurse to participate in this training. It was planned in a staged model where they were given some classroom sessions to just give them some basics on echocardiography, more like a theory. And thereafter, they were exposed to 2 rounds of 5 days of practicals, where they were given deliverables to do echoes to practice on patients, whether it's a cardiac patient or a non-cardiac patient, just for the purpose of making them get the idea of doing echoes. So really the focus was on them be able to bring out the images from the 5 views: the parasternal long axis, short axis, apical 2-chamber, apical 4-chamber, and the subcostal views. Thereafter, they were sent back to their respective sites, and they started going through virtual mentorship. They do the echoes, they upload and share with the cardiologist, and also a recognized international echo master trainer. Next. So just to share the results, we found them quite interesting. Hopefully you're able to see the numbers. So in total, this was done from Q3 in 2024 through to Q1 2026. So between that time, we've had 629 echoes done. But like I mentioned, in the primary healthcare facilities, the people offering the echoes, not all of them are able to do echoes on children. So through the PENPLUS model, specifically this training, 9% of the echoes done were in children and 7% were in females. Then the abnormality detection rate was at 39% from that 629. Then moving on to the conditions that were detected, you realize that of interest is mitral stenosis and the congenital heart diseases. So mitral, 7% were mitral from that 243 abnormal, and then we had congenital heart diseases standing at 5%. Then the majority of them were reduced left ventricular systolic function and other cardiac conditions such as dilated right ventricle. So these results were interesting in that where we are now, the ones that were identified with mitral stenosis, the sites were able to refer them to the National Heart Hospital, and they were confirmed as mitral stenosis and congenital heart diseases. And we have 5 that are pending surgery. They are on the waiting list for surgery. Then the others, like the other cardiac conditions, have been treated at the site. So the sites are receiving mentorship from the cardiologist, and there is a treatment plan that has been offered. Next. So in conclusion, we are saying that decentralized echocardiography services is feasible, and it has really shown to work for us as Zambia wants to use this platform to increase the number of cases we're detecting for RHD and CHD, especially for children who do not usually get these services. And I also forgot to mention in the health facilities where it's provided, some of them actually have to pay, but in the Pen Plus sites, it's been given for free. And once this is done, it gives an opportunity to make an early diagnosis in real time, initiate treatment, and also it improves the referral pathways, which translates into improved quality of life. Thank you.
Thank you, Bavin, especially for being on time and for that great talk. So, yeah, we'll ask questions later on. I will call upon Dr. George Msengi, who will be speaking on service readiness for severe non-communicable diseases at district hospital. This is my brother. Welcome.
Thank you, Prof. I'd like to break the rules of presentation. I see some people are a bit dozing off. So I will present like as if I was teaching in a class. I always wish to be a teacher like you, Prof. But the challenges I have 10 minutes, right? Because I have 3 stories in the middle of my presentation. Yeah, can you hear me? Am I audible? Prof, I can use this, I think. I want to break some rules. So I'll be walking around as I present because I think I can see the presentation. So I always wished to be a teacher, but in my high school, the only challenge I had, I think I will not be a very good teacher, is because when I was trying to, my friends, the first attempt seemed very, the moment they don't stand, I get frustrated. And if I'm teaching someone for the 3rd time, I would almost push their head, how can you not understand this? So that's why I think I would not make a very good teacher. So I'm going to be talking about readiness for severe NCDs dose in Tanzania. The mic is taking me back to. So service readiness for severe NCDs in district hospitals in Tanzania. So in Tanzania, please wait until I say next. Please wait until I say next. So in Tanzania, we have hospitals that we call district hospitals, which are first-level referral hospitals. So how the structure for Tanzania healthcare system is, we have tertiary and referral, highest referral center hospitals, and then the lower level, which is at the local government authority, are these district hospitals. They are not as low because they do provide tertiary care, but when we talk about Pen Plus in Tanzania, this is what we're aiming for. So a few months back, in October last year, we did an assessment of which we selected some few district hospitals, and we tried to see whether they were ready for what we call Pen Plus, because we had piloted Pen Plus in 2 districts in Tanzania, in Kondoa and in Karatu. Next slide, please. And this was actually facilitated by NIMRI, the Prime Minister's Office for Local Government Authority, together with the Ministry of Health. And these are some few data which have been talked about by a number of people, and I will not repeat this. The burden for NCDs in Tanzania is high. 33% of all the deaths happen because of NCDs. 41% of the DALIs happen because of NCDs. But the biggest question to ask is, why is it important right now for Pen Plus? First, it's because of WHO. WHO has brought Pen Plus to us by endorsing it in 2022. And furthermore, NIMRI has given us the privilege through the NCDI Poverty Network to actually pilot this in Kondoa and Karatu. So we have demonstrated feasibility of how Pen Plus can be effective. And lastly, in order to scale this up right now, we needed to have a facility readiness index assessment. Next slide. So the overall goal was to assess whether these facilities, district hospitals, were ready or not. And our objectives in this assessment was evaluating the facility infrastructure, the human resource, determining whether the medicines and the clinical practice were actually fit for Pen Plus expansion, assessing the data systems, and most important of all, understanding the gaps and prioritizing investment for a national Pen Plus scale-up. Next, please. How did we do this? So first of all, we did a cross-sectional study whereby this happened, as I mentioned, in October 2025. And I was trying to explain yesterday to someone that you can actually do this assessment at a much more cost-effective. This was funded through WHO. So we had the researchers go to these facilities and not only ask the questions, but actually physically verify what they were asking for. But you can do this at a much more cost-effective, whereby if you have the right policies and you have the right infrastructure, the facilities can fill these forms and actually provide this input to you. And you can just go, instead of spending 4 or 5 days for the assessment, you can actually just go for the counter verification. So these district hospitals were selected from 7 healthcare zones. Why do we have 7 healthcare zones? I am not very sure, but there are 7 healthcare zones in Tanzania mainland. And out of this, we have regions. So 2 regions were selected in each zone, and 1 hospital, district hospital, was selected for each region. And we use the SARA, which is the Service Availability and Readiness Assessment tools for WHO actually. And these are the same ones that were incorporated and actually adapted for the earlier pilot that was done in terms of its readiness index. And we assessed 6 domains. This was infrastructure, human resource, equipment, medicines, together with service delivery. And there's a factor, an analysis factor called composite readiness index, whereby you analyze multiple factors together and you see the overall readiness index through the weight of each factor. So 4 equally weighted domains were actually assessed. These were conditions managed, essential medicines, essential equipment, together with service delivery. And all the ethical parameters were considered. Next page. Next slide, please. So let's go straight towards the results. What was our composite readiness index then? So in terms of medicine score, and after this I'll go a bit into the details of the medicines that actually had cross-border line. So medicine score was actually the best in terms of the strongest domains, whereby 94% of the medicines for severe NCDs that were assessed were available. In terms of equipment, in all the 14 facilities, 87% of the equipment we had assessed were available. In terms of service delivery, this was mostly the one with the highest variability. It scored 68%. And of the composite readiness index, 1 facility scored the lowest, which was our Morogoro facility, and 1 facility scored the highest, which was Mbeya District Hospital. In terms of the conditions that were managed, Penn has done remarkably well in Tanzania. So when you talk about hypertension, type 1, type 2, sickle cell, and asthma, these were managed at all the facilities, 14 facilities that were assessed. Unlike this, in our national operational plan for Pen Plus in Tanzania, we have expanded further from talking about the 3 severe NCDs. We have included other severe NCDs, such as epilepsy. We have also included mental health in this, and we have included asthma in this. So mental health was managed in 13 out of 14 and heart failure in 11. However, the critical gap was in actually your area of interest, Professor Muta. Rheumatic heart disease was only actually managed in 3 out of 14 facilities, even though this is quite preventable with the prophylaxis, and chronic kidney disease was 4, together with cancer was only managed at 4 out of 14. Next slide. So this is a bit of an interesting aspect. When you talk about short-acting insulin, metformin, beta blockers, calcium channel blockers, so when to those who are here and are interested in the scale-up of Pen Plus, either in your specific facility or whether you're interested in partnering either through NIMRI or any other facility to scale this up, these data here are very important because some of these medications here were 100% available, but the long-acting was 85% available. ACB inhibitor was 85, loop diuretics were 85% available, but the essential medicines which are critical and had critical shortages, for example, warfarin. Any post-operation patient, this drug is actually, I would say, another life and death borderline drug. So anticoagulation, warfarin was only available in 5 out of 14 of the facilities, and hydroxyurea, which is extremely important, and I say for the third time, extremely important in sicklers, was only available in 3 out of 14 of the facilities. When you talk about essential equipment, which is our last gap there, you'd see that the HB electrophoresis, which is used for confirmatory of sickle cell, was not present in any of the facilities, but also in terms of asthma, spirometry, and EASE equipment was actually present in 1 out of all the facilities. Next slide, please. So when you talk about, we talk about the sickle cell disease paradox, we talk about sickle cell a lot in Tanzania because if one can guess, what do we rank in Africa in terms of the burden of sickle cell? Tanzania is country number what? Random guess. You can shout it out. Tanzania is country number what in terms of the morbidity trend for Africa for sickle cell? Number 1. Number 2. So those who say number 1, number 2, so there's one who says number 1 in Africa, number 2, number 3, number 4, number 5. So we are the 5th in the world, and in Africa, we are actually number 3 in Africa. So we are doing quite high in terms of the numbers. So it's very important. So when you talk about the facilities that manage sickle cell, the ministry has done quite a good job. All the facilities did the basic management of the sickle cell, even though the confirmatory, in terms of the definitive diagnosis, could not be made because the electrophoresis was not there. But however, also facilities lacked hydroxyurea, and only 5 out of 14 of the facilities hardly had sickle scans. So you can ask yourself, how do we manage what we cannot diagnose? Yeah? So what does this mean to the patients? It means that there's a lot of clinical and symptomatic ground management, but also there's no quite definitive diagnosis. Next slide, please. So another important and very important area is on the aspect of loss to follow-up. So we try to assess these facilities on whether they had any formal loss to follow-up. First of all, even definition. How do you tell whether this patient is lost to follow-up? So only 4 facilities could actually even define if this patient does not come in 3 months, then he's lost to follow-up. If he doesn't come in 2 weeks, then he's lost. So only 4 facilities has this definition. 3 facilities had a tracking system. 3 facilities had a contact system that once we know there's a loss to follow-up, we know where this patient lives. We have someone who can actually make a contact. But 7 facilities had received medical records in terms of referral once they had a patient who came in with complication. So only 50% of these patients came in with previous records. Other than that, they were starting from scratch. This is very expensive. It's repeated and tiresome work, but it's also time consuming. So when you come to the aspect, why is this very important for Pen Plus? Because type 1 diabetic patients need insulin every day. Once you have a loss to follow up, this is a life and death decision that you have to take as a clinician, as a facility, in knowing that this patient, if he's not here and they did not come for their insulin, are they at the traditional healer? Are they at their grandma? Are they at the prayer house? Or where are they actually? Because this is very common in Africa. Same thing for sickle cell disease, same thing for heart failure and rheumatic heart disease. Next slide, please. So this is close to my end, and some of the key priority actions that we had actually emphasized on is, first of all, to have regional hubs. Because if we say we want to expand Pen Plus without regional hubs, it might be a very high investment demanding area. So we might expand to the most important and basic equipment at these hubs, and confirmatory diagnosis, for example, HB electrophoresis, could be made at these hubs. It is important to procure hydroxyurea and hemoglobin electrophoresis, especially in facilities that we know Pen Plus conditions are being managed, but also that we know patients are there. Sickle scans were important, but also not only the scans, but also the cartridges to those facilities that had the scans. In terms of the medium to long term, medium term, apart from just establishing hubs, equipping the hubs, having anticoagulation supply, in-service curriculum, and in terms of the long term, mobile outreach in terms of rural catchment is very important to identify new patients, but also quarterly and annually monitoring and evaluation are very, very important. Next slide. And so in conclusion, the overall facility readiness index was 80%. Universal strength is that infrastructure, insulin, core NCD management was very strong. Critical gaps are sickle cell confirmatory, loss to follow-up systems, and rheumatic heart disease was severely underserved. What must change, I've already mentioned before. And the broader message for ICPPA 2026 is that Tanzania district hospitals are ready, and actually with targeted investment, Pen Plus is achievable at a national scale. We saw Ethiopia have a target of 150. We have 186 district hospitals. Their population is much more than us. And another important message is the sickle cell paradox and loss to follow-up actually can be corrected, and this evidence is now available and actually incorporated into the national operational plan that we're working on and almost to completion. Thank you. You have been a very good class. Please clap for yourselves.
Asante George, thanks for that great presentation on readiness to managing NCDs in Tanzania. As you said, you analyzed a lot of domains, 6 domains: infrastructure, human resources, and hospital information systems. And you analyzed really good, but I not see analysis on infrastructure, human resources, and information system. Maybe you tell us at the end. So I'd like to invite our third presenter, who is Dr. Lulu Tian. She'll be presenting virtually, and her talk is on adapting the Pen Plus monitoring and evaluation framework for sickle cell disease program implementation, a case study from Ghana and Nigeria. Can we share? Okay, she's there already. Welcome, Lulu.
Hi, how is the audio? Is this all right? I unfortunately cannot see my slides. Would it be all right to kind of present in split screen?
Can you project, please? Okay.
Excellent. Thank you so much.
Okay,
I'm sorry I couldn't be there in person, and George, I want to thank you for your presentation. This could not be more timely. I feel like, I don't know if you looked at my slides beforehand, but the topic of sickle cell disease and loss to follow-up are things we'll talk about in this presentation. My name is Lulu Tian. I'm a senior technical advisor with the Clinton Health Access Initiative, CHI, and I'm here presenting this case study on behalf of a broader CHI team listed here, as well as collaborators from the Federal Ministry of Health in Nigeria and the Ghana Health Service. And as the moderator mentioned, I'll be discussing about Pen Plus M&E, specifically adapted for a sickle cell disease program that's implemented at a national level. Next slide. Just to take a step back, with some support from Coefficient Giving, CHI is supporting the scale up of SCD services in public hospitals and select regions in 3 countries, which are Ghana, India, and Nigeria. For this conversation, I'll focus more on the work in integration in Ghana and Nigeria. Next slide, please. So the nexus and the impetus for this work really came from 2 needs. The first, a need for measurement and visibility that's also bounded and exists not just kind of on its own, but very much in the context of national systems. And then on the other hand, it's really integral to understand where, who, what can we do to course correct, and what can we do to strengthen the quality of patient care and strengthen program implementing national health information management infrastructure. And in Nigeria, there are also state level systems in place. Lastly, we would be remiss to not mention that specific indicators that are needed for routine monitoring. And these indicators span everything from screening all the way to treatment and retention and care.